Nothing's happening.
This is not a touch screen. This is not iPad. Sorry.
Good morning and a very warm welcome to the India Arthritis and Osteoporosis Conclave. I'd start with just a request. If you have a phone that's on, please switch it on silent mode. For the opening remarks, I'd like to invite Dr. Dhananjay Gupta, who is the founder of and secretary of the Bone and Joint Society and the host of this conclave. Dr. Dhananjay Gupta is the director of orthopedics at Fortis Hospital. Dr. Dhananjay Gupta.
Thank you, Astri. Gentlemen, you might find the hall a bit scarcely crowded rather, but take my word for it, a lot of people who have logged in online and they're enjoying the proceedings. So the India Arthritis and Osteoporosis Conclave has been wrongly mentioned here as international, but hopefully by next year onwards, it may become true also. This is the third edition in the series. And when we started, the basic idea was to, if you look at the theme, that was a locomotion disability prevention in the senior citizens. And the idea was to promote the idea that orthopedics is something not only about the medication and the surgery, it goes much more beyond that. Prevention is the key. And then next year, unfortunately, we were living in the COVID pandemics, the things had changed. Everyone was concerned about the COVID, and hence the last year theme was about the musculoskeletal health in the COVID times. This year, we are going forward. Hopefully, COVID pandemic is behind us now, and that's why we need to start planning about the global disability prevention strategies. I'm not the only host. We have a group of hosts here, and I'm really grateful for Delhi Orthopaedic Association. The president, Dr. Lalit Mani, is here. They have been supporting us throughout. J.D. Goenka University is represented by Dr. Dhananjay Gupta. He has been a pillar, rather backbone of this event, and he's the one whose continuous efforts have made it happen on a regular basis. Fortis Flight Captain Rajendra Hospital, my Karam Bhumi rather. We have our FD, Dr. Rajiv Nair, our colleague, Dr. Govinda Bedi. So we all of us combined together are here to host you and give you a good scintillating academic as well as scientific program. Well, the timing of the event is very important. It falls between the World Arthritis Day, which happens on 12th of October. If you want to be part of this movement, you just put on a blue band and promote the idea that yes, don't delay, connect today. It's time to work, and you need to take affirmative actions to tackle this problem, which is a cause of major disability all over the world. And World Osteoporosis Day, which is going to be on 20th October, and it's being represented by a white color ribbon. You can be part of it. Started in '96, and it was taken over in '97 by International Osteoporosis Foundation. And this year theme is Take Action for Bone Health. MSK Health. Sorry. Is there any way I can minimize this thing? No? Okay. So, it's definitely a huge problem affecting the almost 20% of the population. It seeks orthopedic opinion because of the musculoskeletal problems which they face. And it's a growing problem because of the regular increase, gradual increase in the geriatric population. It's not only the geriatric population we are concerned with. We have globally a pediatric group also, which is concerned with the musculoskeletal conditions happening in the children all over the world. And they also need preventive measures as well as corrective measures to tackle this growing epidemic. Even surgeons, they are not immune from this problem. And more you think about the latest in technology, like robotic assisted surgeries also, they're also having sort of a, they are sticking their claim on the health of the surgeons who are using robots as well. Prevention, yes, we all know, but we need to detect these problems early and intervene early so that we can prevent this disability from getting prolonged. So prevention strategies, we are basically hope to focus on increase in the skilled manpower. This is something which is the need of the hour. COVID epidemic has taught us repeatedly. Digital tech upgrade, online consultation, there's been a huge increase in the online consultation. This is going to be the norm. And the flip side is, yes, it has improved our connectivity with the patients to a great extent. Another thing which we learned from the COVID is that we need to maintain the local supply chain. If there's a disruption, if you are simply waiting for the things to come from outside, from the far off places, there's going to be a disruption in your treatment chain, and that needs to be tackled aggressively. Then financial support and rehabilitation cannot be ruled out. We have various national health programs, and we are basically concerned with the one national program, which is about the non-communicable diseases. We have Dr. Anil Kumar. He'll be deliberating on one such program, which is being run by a central government. So as we discuss about the skilled manpower, that is the basic service personnel which we require at the grassroots level. And if you remember, this slogan came out in the newspaper during the COVID pandemic, the second wave, let's fight COVID. And Delhi government came up with this idea that let's get paramedical health assistant, because they realized that it is a shortage of the basic health which is affecting the population at large, rather than your high care tertiary centers and your highly trained doctors. And if you look at the size and composition of the health workforce in India, you will realize that we are definitely deficient to a great extent as per the WHO standards. And moreover, this particular ratio is skewed, has a skewed distribution across the states, rural, urban population, as well as public and private sector. Inadequate qualification, and almost 20% of the trained health professionals, they prefer to sit at home because they don't find the working conditions or the incentives good enough to work there. So we need to invest heavily into the manpower, technology upgrade, and their skill enhancement. Tech upgrade, and as we discussed earlier, the online consultations have jumped by almost 500%, and this trend is likely to continue. And with this, I would like to end my intro, and I'll invite Ms. Asri Ghosh to take over further so that we can start with our first session. Thank you so much.
I'd like to invite the panelists for this first section. Dr. Rupali Roy, she's Assistant Director General, Ministry of Health and Family Welfare. Dr. Rajiv Nair is Facility Director at Fortis. Hospital, Basant Kunj. And Dr. Gurinder Bedi, Director, Orthopaedics at, and head of the department at Fortis. Our first talk today is by Krishnan Dharmarajan, who's the Executive Director, Center for Digital Financial Inclusion, which is a non-profit center that develops and supports digital innovations for social impact. He'll be speaking about bridging the gap, forging alliances between caregiver and community for musculoskeletal rehabilitation. Krishnan Dharmarajan, please.
Good morning, everyone, and thanks a lot for having me over. I have had many years, driving and executing large programs across sectors, across domains inside the government and now outside the government after I've come. And what I would like to share and put forth some views is when we look at a large problem like this around musculoskeletal conditions and disorders, what are some of the ideas that come to mind for somebody coming from a different domain where we look at possibilities of digital technologies and tracking and reaching out to remote rural areas? How do you make all of this come together into the problem that we have today? If you just look at the prevalence, that itself is necessary to put this in context. So globally, we have 1.71 billion people today afflicted globally. That's about 171 crores. So it's massive. It's like a huge epidemic. For example, whenever I am called to a conference like this, I really dread it because chairs without an armrest give me the backache within 2 minutes. And I'm suffering for years and I don't know where to go. So I don't know how many of me like me are there. So it's a very everyday problem. You usually find me standing somewhere at the back. People say, why don't you sit? How can I say I can't sit? And every conference in the city runs with these chairs, this pandal type, this disaster. Okay? So just give you an example of how little people think in this, and it's been going on. Right now, the WHO estimates that 40% of the people over the age of 60 are afflicted, which is a big proportion, and 80% of these have lower back pain. So look at these numbers, and various studies have shown other factors, not just old age, not just over the age of 60. I mean, we are looking at middle age, we are looking at female gender, we're looking at education status, if that is lower, and those performing some kind of repetitive hand movements. So there are so many segments of the population, and there are specific conditions that impact each of them. And I don't know how much of these have been tabulated, tracked, understood, right? They're also associated, I understand, with mental health decline, MSK conditions. And low back pain seems to be a huge contributor across sectors. And close to, if you see close to 600 million throughout the world are afflicted just with lower back pain in millions. This is what the WHO data says. And interestingly, even those up below 45 years, those who are afflicted with MSK, about 75 to 80% of them are down with lower back pain. And how many of us are doing something about it? We don't know. And it's a really significant proportion. We're talking about the younger people here, not necessarily the old. Right. In India, we have research studies that indicate that this community-based prevalence of 20% due to absence of screening mechanisms. So there are a lot of communities, maybe geographies, where up to 20% are suffering. And in some segments related to population, related to occupation, it's as high as 90%. So there could be certain occupations where the prevalence is as high as 90, and we need to identify what they are, where they are, what we can do about it. And today, when we look at the elderly population, we found that 60% of over the age of 60 are afflicted. In India, 12% of the world's elderly population lives in India. And so that becomes a significant part of the catchment area that we are trying to address here. And research studies also show a rural-urban difference that Dr. Dhananjay pointed out earlier. One is in case of prevalence, it's definitely quite a bit more in rural areas. And also the health-seeking behavior for these MSK conditions are also less in rural areas than in urban. So people, even if they are afflicted, they won't know. There's no screening to say that they are actually afflicted, and there's no way they are going to initiate a health-seeking process from their side. So it's a far deeper social problem than just a medical problem. So a major number of musculoskeletal conditions go unrecognized, either due to poor understanding of the factors or due to less efficient screening and treatment opportunities available to the community. So a major number of these unrecognized cases are either from the rural areas or people with lower socioeconomic status. So when you're looking at things like screening, what is it that we normally look at? I'm just looking at it as a layman today from outside. We have these tests available in large hospitals. We have, the DEXA X-ray scan for bone density. We have MRI for detailed picturing. We have computed tomography scans for detecting bone abnormalities. We have musculoskeletal ultrasound for motion imaging. All of these are there, but they are in large hospitals, maybe like Fortis, Apollo, in all these areas. But what are we there going to look at those crores who are afflicted across the rural? 65% of the country today is in rural. How are you even going to reach these kind of devices to track and screen? And do we have a solution other than taking a big machine and putting it in a village and hoping that it becomes viable, which is not going to be viable. So it's just not going to happen. So try to look at what are the alternatives which are kind of developing today. So we have different IoT devices today using digital tools which are getting developed. For example, we have a pocket-sized osteoporosis scanning device that works by measuring the cortical bone density, thickness of the tibia, and the device algorithm uses that data to calculate the density index and estimate the bone mineral density of the hip. And then the device can be connected to a computer via USB. So just an example of what can be done by a pocket-sized device, okay, which could do something quite similar to a laborious DXA. So is that going to work? Then some Bangalore-based company, I understand, also has developed some smart wearables and leg bands that scan our body, track skin hydration, extracellular, intracellular water, and all of that. And they need to be worn just for 10 to 15 seconds, about twice a week, and for its data to be transferred via Bluetooth. So probably low-cost stuff, which can work in rugged environments remotely. Then we have other handheld disposable devices that measure the bone loss, okay, which are typically at-home devices that can help patients learn whether the treatment is working or not. And they're all single-use test results, just like some once use and throw kind of stuff. Then we also have portable ultrasound bones instometers. So just looked at some examples of smaller devices other than the bulky ones, which can probably potentially give the direction of how can we take it to farther areas and look at screening at the large kind of numbers that we're today looking at, right? But these devices, which we are not talking about, they're yet to gain acceptance at scale. We still have not reached that. And while we sit on one side and maybe wait as Indians to see while some Japanese, some Korean company develops something and shows it to you and we buy it, why don't we start thinking of developing it? I mean, we can today do R&D and develop these kind of devices specifically suited for the Indian conditions, calibrate them to the extent necessary just for screening, not necessarily for diagnosis, and try to put our R&D efforts into that. In fact, we bring some learnings because I have been working, and me and my team, we have looked at maternal health programs across the country. And there, when we found the kind of conditions that are required to be tracked among mothers and among newborn children in remote geographies and rural areas, we found that there is a need to develop some kind of IoT device which is low cost, rugged, and can work in remote areas. And we have gone to quite an extent. We have done some R&D, found how it works, and now are able to go to clinical trials. And all of this has been possible in just 9 months. So why I'm saying is that we can work on multiple domains like this. We can look at these problems and try to solve it by ourselves without waiting for somebody to come and give a device and us negotiating the cost. Why don't we do that? And it doesn't cost so much at all. And if you look at the scale of the problem we are addressing, it's nothing. So, and we have the talent today in the country to develop these kind of devices to make it happen, and specific devices for specific conditions. Okay, and this R&D today is booming globally. And we need in India to take the steps, because here is where the usage is going to happen. This is where, we have 1.3 billion in this country. This is where the usage is going to happen. We need to develop things specifically for these conditions. Well, these are more of hi-fi things. We can also use simpler digital tools to screen and monitor MSK cases in remote areas. When you look at these numbers, we can look at simple mobile devices to be able to do that. For example, we could have mobile apps that can be used to conduct surveys and track patients' progress over time. It can be used for collecting data for screening purposes. The app could either be installed in the respondent's phone, or it could be given to the caregivers. If it's part of the public health infrastructure in the country, it could be given to the ASHA workers, the ANMs, the MOs in the field. They could use these apps to get the information and send it back to a central analytics platform. It can be also used to keep track of patient's medical history. It could help monitoring critical details of the patients on a periodic basis. And when this data comes centrally, that's when its richness can be really leveraged. We can generate insights on the prevalence across different geographies, assess the prevalence across gender, profession, education, age, monitor the symptoms and recovery of patients, and devise effective remedies for specific segments. I will come later to an example of
right in saying that presently we got no app completely dedicated to musculoskeletal health at all? Abhi tak we've not seen anything very popular besides the watches and everything.
Can communicate with us, nothing more than that. So clearly, it's a lot of distance to go till it scales, and there is a room for a lot of new development here. In fact, we really don't even know what we are trying to address. We are trying to see that this is the problem, and I'm trying to put a device. But if you actually see in the field what is the specific thing we are trying to address, and we can frame some IoT, some device specifically addressing these conditions in India.
Because there is a Prime Minister's initiative right now for putting every citizen in the country on a clinical database, so you can actually access. I don't know. MSK will be lower down in the priority. I think the most likely the cardiovascular and the diabetes profile and all will come slightly higher up in terms of assessing the disabilities, because eventually, I think every healthcare program in the country has to depend on the database provided. In terms of how do we plan for the next 10 years based on what is the current big problem, and unless this problem comes up in a way that you can make a database, you will never have a solution to put forth. So you can't go to the government and say, look, it's a problem, and says where is the where is the data about the problem that you're talking about?
So I think it's up to us to devise a program like this, or even have a pilot or whatever is sent. For example, what I was showing you is something that is done in the remote Northeast across a whole state. And what kind of has been done there is way ahead of what has been done in the main land also. We are tracking something like 500 data points across every mother, and even trying to use AI and ML. So we should allow, a lot of this innovation and stuff to happen. One of the problems with these, so one of the issues which I feel as a practitioner is that when you look at these large programs which are driven out, see, the whole emphasis here is on scale. See, the emphasis on scale, on numbers, on Aadhaar, and that's not it. I mean, that is one track. You keep doing your Aadhaar business, everything. But let's look at the actual medical stuff. And that's something in which we should allow a lot of pilots to happen, scale them up. There have to be 50 such platforms in the country, not one. This is a huge country. There have to be 50 such stuff, which you look at differently, which scale independently, which has their own set of experts working on it, and new learnings coming out of each. So we need to have a million flowers bloom here, and not focus on one platform. That's something that we need to be careful on. We have to allow each state, each functional segment to develop its own strategies and execute it.
So in MSK, not much of technology is happening as such in prevention area, I would say first. So there are two technologies. One is piezo sensor based, pressure insoles and pressure seats and all. So a lot of data is available with bioengineers. Huge repositories are there where the data is there, but I think there is no much of articulation between clinicians and the bioengineers. So and the other problem I found is that they have a very complicated and very, I would say, in-depth software and all to filter the data and then to put some algorithm and to finalize a particular outcome. So one area would be if we can have a set algorithm for a particular function, and we make such sensors, I would say user based, because these days we have I'm working with surface electromyography these days. So they have huge softwares, and many of the data can be analyzed in many ways. But if let's say we have a fatigue analysis, so we have a set algorithm for fatigue analysis. So if we have a sensor and if we have a preset algorithm there, only a beep should come that this muscle is getting fatigued. Now this is not happening because of the user, and suppose you have something like this on the steering of a car. So there is a prompt that your muscle is getting fatigued. We have algorithms, we have data repositories, but they have very huge softwares. You do the EMG, and then the software will take some time to analyze this thing, but that is not required at the user's end. So there are things and there are data available also. Like I'm working with a senior professor of Italy. So he says that huge repositories are available in European and American, setups, because they are bioengineers. So that kind of, but they do not know what exactly do we need. Because if we have a large software where we're putting electrodes, then we are taking the data, we are doing noise filtration, we are putting algorithm, and then finally we say that, okay, the muscle is fatigued. But by the time the whole thing has gone, maybe that muscle is now in the stage 2 or 3 of fatigue. So we need, biofeedback kind of things. So there are two items, piezo sensors and surface electromyography sensors can be looked into. Thank you.
I'm afraid that we will just have to go on with the program. I would also request everyone using a microphone to remember to hold it, because even though we can all hear each other here, but since this is actually a Zoom conversation, so now I would like to invite Public Health Specialist Dr. Anil Kumar, who's Deputy Director General of the Directorate General of Health Services, to speak on the need of the hour, which is a national program for the health of the elderly. Dr. Anil Kumar.
Good morning to all of you. And I would like to thank organizer of this activity for inviting me and my colleague, Dr. Rupali. In fact, I was hearing the previous speaker, and it is really happy to note that the previous speaker was talking about the program at primary healthcare level, about ASHA, about the auxiliary nurse midwife, how they are working, they are functioning, and lot many things about data. Now, I think it's a very, it's a good opportunity for me to bring program to you. There seems to be a gap between clinicians and the program, what program is doing. And probably many clinicians, they are not aware about the program, because many of those things which you expect government to do, the program is already doing, and program is moving in that direction. So my presentation is will be covering a wider area beyond the scope of probably what people or the attendees are expecting. And to make a point about the program, I have to do that. So I will be covering why we need a program for elderly in India. And I will be presenting a lot of data about it. First of all, as per 2011 census, the elderly population, and I will be mostly covering the elderly population, means population above 60 years of age. That is what we take in the program, is 8.6%, that is 10 million. And the population is expected to rise to 30 million by 2050. Today, it is around 130 million, that is 13 crore. So 10 crore in 2011, 30 crore in 2050, and today it is 13 crore. And the population of age 45 and above is expected to be 40% by 2050. That is 65 crore. So that is how we are growing. And population age 75 and above is going to increase by 340% between 2011 and 2050. By 2060, we expect that 25% of our population will be above 60 years of age. Now that is very, very important, and our all resources in health that is going to be, dedicated to this population. Now, till now we were talking about the maternal child health. That was our priority area. But elderly population is going to be our priority area in time to come. So that is what we have to keep in mind, and we have to prepare for that. And we have to start early. We are already probably late, although program started 10 years back. But we have to work very hard to reach each and everybody. And I will be covering why it is important. Now this is the graph, as you can see, and you can see more than 50% of our elderly population. And as you know, as you grow, the problem is also increasing. So starting 45 years to 75 years, single morbidity and multi-morbidity is increasing. So more than 50% of our elderly population is having either single morbidity or multi-morbidity, and actual number may be more, because this information is based on what they perceive, what they inform. But when doctor is examining them, maybe they will find more, more of the morbidities in the population. And this is again, talking about some of the diseases: cardiovascular disease, hypertension, bone and joint disease, diabetes mellitus, chronic lung disease, neurological or psychiatric conditions, all growing, all increasing with age. In most of the cases, below 45 and above 60, it is doubling. Sometimes it is increasing by 3 times also. So that is and population is also growing. So this is what the quantum of problem we are going to have. So by 2030, 45% of the total burden of disease, majorly non-communicable disease, is expected to be borne by the old age population. So all of you attending this event, you are going to be very, very important as far as healthcare delivery is concerned in our country. Now, if you go by different diseases, different group of diseases in the elderly population, and I am covering population 60 and above. Elderly population for the program means 60 years and above. Cardiovascular disease, 36%, 34% of the population is going to have that type of problem. Hypertension, 32%. Bone and joint diseases, 18.8%. And you can calculate 13 crore population today, and you can calculate the quantum of the problem which we are having. Diabetes, arthritis, 10.7%. So it should be around 17 lakh people, if I am calculating correctly. Out of 13 crore, so 1 crore and some 1.5 crore, I think. So that is a number. Chronic lung disease, urogenital conditions, asthma, chronic heart disease, all going up, all increasing. Anemia, 4.7%, COPD, 2.80%, stroke, 2.70%, neurological psychiatric, 2.60%, and so on. Osteoporosis, 1.3%, 17 lakh people having osteoporosis, elderly population today. Alzheimer's, 1%, 13 lakh people, they have Alzheimer's and dementia. Depression, 0.80%. Cancer, malignant tumor, psychiatric illness, all, we have problem. We need, the doctors, clinician to provide services. So who are they? Now these are the people, elderly people, large number of elderly people in our country They are having, different type of health conditions. And who are they? They are not getting pension. Most of them, 91%, not getting any pension. They are not even aware about the government concessions. 71% of them currently not working. 64%. No schooling, never went to school, and they are physically not active. This is the population. So when I'm talking about all this, we need to concentrate on primary health care, the prevention, all that. Not only clinical care, but the prevention aspects also. And we need to work very hard for that. 36.2% are widowed, and 22.6%, only 22.6% they receive the government concessions. Others, they have not. They are not satisfied with the living arrangement. They are living alone, and they experience ill treatment. Now, this living alone and experiencing, ill treatment is going to grow up. We know now children, they are moving away for work. Some of them are going outside the country. Some of them, they are moving within country, leaving the parents alone. So this problem is going to, going to grow. So that is why we need a program. So this is the program, national program for healthcare of elderly. So this program, as I said, launched in 2010-11, but still the speed with which this program should have been implemented is not, what we initially thought. We are very slow in implementing it. So what are the objectives of this program? To provide accessible, high quality, and affordable, comprehensive and dedicated healthcare services. Now this is something, the type of objective we have. And many a time, the population, the people, they always say that government is not doing what they are expected to do. It's a huge task, reaching each and everybody in the country, especially in rural areas. It's not that easy. And we need to build a framework to create enabling environment. Now these are words, but when you implement it, words, it's a simple, one-line sentence. But when you have to implement it everywhere, it's a mammoth task, not that easy. And we have to tell them concept of active and healthy aging, which include yoga also, which include, exercising also, which also include the social environment in which they are working. And then the Ministry of Health and Family Welfare, they need to bring all stakeholders together, convergence. And when I'm talking about the convergence, it's not only the other ministries, Ministry of Social Justice, but also all of you, the clinicians, the different organizations. We need to come together. Only then probably we can successfully implement this program. So what this program is? This program is about primary health care, the dedicated geriatric care facility through primary and secondary healthcare system, and the tertiary geriatric care through regional geriatric center and national center for aging. So we are building infrastructure, and also we are conducting research. Now research, so far we have conducted one research, that is longitudinal aging study of India. Some of you probably aware about this research, but we are planning more research activities. And my previous speaker was talking about the research activity required. Yes, of course. And government has to be leader in that. It's not that, others conduct research and provide input to the government. Government need to take research, they need to coordinate research, and that is what we are planning to do. So talking about what we expect. So as my previous speaker said about the ASHA and the multi-purpose worker, that is auxiliary nurse midwife, their role is going to be very, very important to reach the population, the type of problem we are talking about, and the different, variables we talked about, that population, the health education. Now, health education is not something which you use the television, you use newspaper. If we have to reach the population in rural area, we have to use the local people. We have to use the panchayat. We have to, we are talking about the local, Mahila Mandal or other social groups. We have to, address directly to them. Now, this beautiful advertisement on television looks, really great to us in urban area, but doesn't reach. That doesn't reach, rural population. Healthy aging, that concept, people should be, talk about the healthy aging. We know in village, when, people, they are older, they will sit somewhere outside in some area, they are, chatting throughout the day. They try to pass the day, less of their contribution in different, activities. And some of them are suffering and they continue to suffer because they accept that. So we have to talk about the healthy aging, how productive life they can lead. And, what to do about the people who cannot move. We have health centers, we have the, hospitals, but people will not move. They are bedridden. They cannot go. So I know I have traveled throughout the country and I have seen people, they cannot move. So we have to reach them because they cannot come to us. We have to reach them. So we have to find out the way how to do that. And this is what we are doing in the program at primary health center. Now, primary health center will be, coordinating all these activities at sub-center level to reach people. They will be having, medical officer who will be, not only imparting clinical care or clinical services to these people, but also coordinating all those activities, the preventive activities. He is expected to conduct health assessment for them and do some simple, investigation like blood sugar and all that, blood pressure, all those things. Now we have community health center also in our system. Now in community health center, we need to provide some rehabilitative service and we have the staff, appointed. Now when I'm talking about this program, some of you may question that we have not seen these type of services are available. This is the program and we have to effectively implement this program. And this is, it will take some time when program will be, is seen everywhere. But this is the program and we are trying to implement it everywhere. Now, domiciliary visit, as I said, many of the cases are bedridden, they cannot move. The domiciliary visit is also, from our trained staff from community health center, we organize that. At district hospital, now we have 10 beds allocated for elderly people, separate ward. Either they can be separate ward or they can be allocated beds in different wards. That provision we have. And the referral service, they can refer the cases to higher level at district hospital, or they receive the cases from primary health center and they have to attend that. And then at tertiary care level, the scheme is under what we call Rashtriya Varisht Jan Swasthya Yojana. That is the scheme for tertiary care, where complicated or serious, geriatric cases are seen. We have to have some sort of, specialized clinic over there. Like, we can have the clinic for, osteoarthritis. A clinic can be there for joints problem. All those joints problem we can have clinic. Or for mental health, we have a special clinic for elderly care. And at this level, these RGCs, and which are, there in 18 states, 19 RGCs. Now these, and we are planning that in all the states, we have one regional geriatric center. So we expect that we will be having at least 2 MD geriatrics available everywhere. Now this is a problem. MD geriatrics not available. We do not have enough number of people who can be, appointed as assistant professor or associate professor there at geriatric, regional geriatric centers. So how to build up that type of thing? So we are talking to the Open University, Indira Gandhi Open University, to create, some sort of at least diploma course, or maybe if it is possible degree course to, to have more, specialized people in that area. They are expected to develop training modules, research. And then we have the National Center for Aging. One is at AIMS, other is at Chennai. Third one we are planning to have at PGI Chandigarh. Now these are going to be specialized centers where high level of services for elderly care will be available in all specialized area, and they will be coordinating activities, clinical and otherwise primary healthcare or secondary care health activities all over the countries. So they will be coordinating, they will be guiding. So this is what we are planning. This is about the program. We are also planning to start by the end of this year the e-consultation for elderly, because and it's very, very important for them because they cannot come to health centers. So how to reach them is through teleconsultation, the e-Sanjeevani, and the issue is these people, they do not many of them, they cannot use the mobile phone, they cannot use the computer. So this is one of the issue, and we somehow we have to reach them to teach them how to use these digital devices like mobile phone and all other digital devices. So that is going to be an issue, and we were talking about assistive technology also. That is also, for that also we need to teach them how to use these digital devices. So this is one of the issue, and this we have to address separately how to do that. But these are the services which we are going to provide to the elderly people through e-Sanjeevani, and we know we have limitation when we have e-consultation. There some limitations are there. So how to link this e-consultation with referral system, whether they can go to nearby healthcare delivery system or the private practitioner over there, the specialist. So how to link with them? That is one of the issue, and I think we all concerned stakeholders need to discuss that how program and the practitioner can be linked, so that healthcare delivery can be ensured to each and every person, and also the private practitioner, they are also getting some sort of consultancy fee. We need to work on that. So this is a portal. This is our website, and we are trying to develop this website in such a manner that a lot of information is available for elderly on this website, and not only available. I mean, how we can use to connect to everybody, including practitioner, so that we get some sort of information on this website, and then the practitioners, they can be contacted, local practitioner, and if possible the services can be provided at his home, or they can reach to the right practitioner. So these are the things which we are planning, and this is some of the activities we are planning immediately. My previous speaker was talking about the development of database and analysis. I think that is very, very important. Government should develop, should have database. This is what we are planning to have, database, and database is not only about the clinical information, but also other related information, so that necessary action can be taken. So all activities of the program need to be linked with the database, and we need high quality analysis at all level: primary level, secondary level, tertiary level, and national level. Only then probably we can provide them the services which they need, and we need to generate awareness among them. And as I said earlier, not only through mass media or the newspaper or any other print media or any other, but using local people, the panchayat. And the panchayat is, I think, is one agency or one platform which we have underutilized. We need to utilize that panchayat platform so as to reach them, and lot of field research to develop innovations. Assistive technology, which we are talking about, and I think all of you are concerned about that. We need to develop assistive technology at local level as per our need. Not some assistive technology available in West, and we are bringing it. First of all, it is going to be expensive, and maybe not suitable for our people. So we need to develop this assistive technology at local level. And I think the different, the engineers, IITs, and the clinicians, they need to come together to develop assistive technology that is suitable for our people at rural area. And why I'm talking about rural area again and again, because 70% of our population is still in rural area. So we need, I think, time to come, the program and the clinicians and the people attending this particular event, we will be talking more about these problems, and probably we'll find out a solution together, and we will work together. Thank you very much.
We won't have much time left for discussions. We need to be
Very,
clearly more
yes,
sharp and
focused, yes. Thank you very much, Dr. Anil Kumar, and Mr. Dharmarajan for very interesting presentations on healthcare delivery. Our next talk is by Dr. Ramesh Kumar Sen, who is President-elect of the IAOC 2021. He's talking about a call for action, the national program for the prevention and treatment of osteoporosis. Dr. Ramesh Kumar Sen has an orthopedic practice of 32 years, 20 of which were at the PGIM ER at Chandigarh. And he's a prolific writer. He has more than 200 research papers, and he's a member of the AO International Pelvic Expert Group.
वीडियो किधर है?
Speak about let me share my screen. Thankful to Dr. Dhananjay Gupta to have asked me to speak about osteoporosis, the implications and the task ahead in this India Arthritis and Osteoporosis Conclave. Let me share my screen. So I've been asked to talk about the national program that should be for prevention and treatment of osteoporosis. We all understand that osteoporosis is a disease which leads to loss of bone mass, making the bones fragile that are likely to break easily. When we look at the BMD in a healthy woman around 30 to 40 years, we all appreciate that most of them remain in the normal part. Some population will be osteopenic and some will be osteoporotic. But as the age advances, as you can see on the right side here, as the age advances, while this small percentage of osteoporotic patients, gradually it starts making it more and more dented to the percentage, and it starts affecting the graph, actually starts turning towards the poor quality of bone as the age advances. The implications are, when we look at these things, the poor quality bone with the age, as the age starts becoming more, the osteoporosis is grossly involving all the bones, but specifically in the hip. And this specific change comes from 70 years to 80 years, when suddenly, while all the bones are gradually increasing for 14% to 21, 38%, here suddenly from 8% it becomes 24% when the age of 70 starts. So now the hip becomes extremely susceptible to get a fracture, and That is the reason that most of the problem of the morbidity patients get is the hip fractures, because the vertebral fracture may not be that morbid. The Colles fracture is not likely to be that morbid as the hip fracture is. Now it is estimated that half of all the women and 1/3 of all the men will sustain some kind of a fragility fracture during their lifetime. And now when we are looking for a hip fracture, while it is estimated it was in 1950 1.66 million, by 2050 it is likely to be 6.26 million affected. And very important is that most of them are likely to be involved in Asia. Now, how it affects our economy. Now, if we look at the healthcare expenditure in this management of osteoporotic fractures, if you compare the management required in the hip vis-a-vis at all other sites, you notice a significant difference here. It is 8,600 USD, millions of USD as compared to the all others. So that is what is an important of hip fractures. The risk of sustaining this hip fracture in a patient of 50 years, let's say a lady 50 years, is not very high if the BMD is good. But as she is osteopenic, this risk ratio rises to about 50%. And accordingly, what it does, what this risk ratio, the increase in the risk of clinical outcome is much higher than the blood pressure issue or the cholesterol issue. This causes a lot of burden on the patient's economy, the national economy, because the care for the hip fracture is primarily hospital-based. Whenever there is a OPD-based, this does not affect with the age. Nursing care is slightly increasing, but the hospital involvement, as you see in the graph, remarkably becomes more and more as the age advances. And when you compare osteoporosis with other diseases, while in the men it does not have that kind of a effect, it comes down in the list of hospitalization, while in women it is the second biggest cause of in-hospital stays for the ladies at that age. Another important issue we have to understand that these variations, these risk ratios will differ from a developed country to a developing country, and here you can have a comparison of 3 countries. So what we have to understand is that each country will have to have its own set of plans, its own strategies to manage this. Now, looking at the Indian scenario, we perceive that 1 out of 8 males and 1 out of 3 females is suffering from osteoporosis. What it is doing, India is the largest affected country in the world it's likely to become. And there are 2 more things which we have to understand. While the men are also significantly more involved, another point is it's a relatively younger age as compared to the Western population that we are getting these osteoporotic features in us. Now we appreciate that while 1 in 3 women over 50 will experience a fracture, it will be 1 into 5 men who will experience that kind of a fracture if the person is more than 50 years. And that is an important perception that we have to understand the osteopenia and osteoporosis, which are very important events happening in one's lifetime. Now, there is a longitudinal aging study in India, which they have published in 2020. Now, what we are seeing it here, this elderly population from 1950 till 2000 till 2050 is gradually increasing in the extent of it. And this is typically, while the pediatric population is decreasing, the age group 59, that working population is basically constant, the elderly population is increasing. And this, you can see the kind of increase here, while we are looking at the elderly 60 and above, 6.9, 11.5 to 19.5. While in the pediatric age group 34, 24 and 18 to 4, 80% only. So this is an important system, understanding that elderly population is projected to rise to 20% of the total population. And what is important here is, while the death rate is 7 per 1,000 population overall, it is 38 per 1,000 population in the patients who are more than 60 years. So this is a very highly susceptible. We understand that Government of India has several health and social policy measures like Ayushman Bharat, like health wellness centers, the Pradhan Mantri Jan Arogya Yojana, National Program for Healthcare for Elderly. But we also appreciate that these are likely to cover about 20% of our population and not all the population concerned. When we look at the economics of well-being in India, this LAC data says that outpatient expenditure vis-a-vis it is primarily with the medicines. But inpatient expenditure is a lot more in medicines, in tests, in hospitalization, nursing home stays, and other expenses which are required. And very important, the most frequent reason for debt, the indebtedness in our population in urban India is a health-related expense, which is not there in a rural area, which is not the other way around. It is maximum is coming from the health issues. And when you have these patients, when you have the assessment which has been done in this long-term aging study in India is a self-reported chronic health conditions. What we see, these chronic, which we focus on the chronic bone and joint diseases, this keeps on increasing, and that there is the patient perception, the population perception with the age. It's also perceived that ladies are more involved, and it is also there that it is in the urban population. And this is the kind of the rural population which we can see the diseases include arthritis, rheumatism, osteoporosis, and all other diseases. And when you get more than 60 years, the percentage is increased, and when it is overall, this is the percentage. But what is important here is that this osteoporosis is involving along with the age, and it is not less than any of the other diseases, like somewhere in the middle of the spectrum behind the cardiovascular diseases and behind the hypertension. But it is much more frequent than the diabetes, than the lung diseases and the neuropsychiatric conditions. So osteoporosis itself is a significant condition to be taken care of. And this is the epidemiological work. There are many studies encouraging this study of ours where we have found it out that the epidemiology, the risk factor in the postmenopausals are reasonably high. And all this review says that 8% to 62% of the Indian women are likely to be osteoporotic. And hip fracture rate is 159 per lakh population in 50 plus years of age. And this is quite a high figure. Then there are other fractures which can happen, and combined there could be the other ratios, but it's very important to appreciate that this is a very high morbidity causing issue here. Another important factor we have to realize it, that the patients are not aware. Now, this is our own paper which we published in 2016 about the deficit in the awareness level of these post-menopausal Indian women. And then subsequently, there have been other studies in 2017, these two said 2018, and other studies, which all acknowledge that there is a very low knowledge within the population about this problem of osteoporosis. Now, what this National Health Mission has the framework. This framework of implementation, which has been published from 2012 to 2017, says that non-communicable diseases will account for 53% of the total death, 44% of the disability-adjusted life years, and by 2030, this will be the cause of 67% of deaths in India. And they have all so many programs as we were looking at it. But where is the program on osteoporosis? It is not really figured well in all these programs. There is a program, tobacco control, oral health, palliative care, burn injuries, fluorosis. You don't have the program for osteoporosis. Maybe this is a part of that national program for health care for the elderly. Now, this is the Asian Federation of Osteoporosis Societies, which has found some studies done, and the editorial says that 33% of the patients after hip fracture received prescription medication for osteoporosis 6 months after discharge, meaning by 66% did not receive it. A very important factor, that even when we knew that the patients had a osteoporotic fracture, still the management was not in 66% of the cases. Likewise, the other study claimed that in 40% cases received calcium vitamin D, 60% did not receive. And the similar is the observation in Korea also. So this is a very important perspective. One was the initial understanding that people don't know it. even the perception here is that even once it is established also, still the treatment is not complete. So that way, the Asian Federation of Osteoporosis Societies gave this call to action that every country makes osteoporosis a national health priority. We must make the awareness in the public that they have to treat osteoporosis. We must have appropriate educational programs. We must measure the secondary fracture prevention, and for that we need the fracture license service. Now, what is this fracture license service? This has been evaluated in 2019 paper in Japan, where they have found it out that the OLS, which means the prevention, the osteoporosis license service, and which takes care of the primary as well as secondary, and the fracture license service, which takes care once the fracture has occurred to prevent the second fracture, all these services have been able to really help the management, and they are quite happy with this kind of a prevention. The similar experience in Spain also, where they have orthopedic surgeons, geriatricians, nurse, rheumatologists, case manager, and likewise the composition is like that this kind of a fracture license services are a cost-effective strategy, because these are a coordination effect of fracture license service with the primary care physician, which brings continuity in the care after the fragility fracture, and so the management goes on. Now, this very society has reported the cost in Asia in various countries. While they have found the cost is quite high in Japan, Hong Kong, Singapore, Malaysia, the cost is somewhere around less than 5,000 USD per osteoporotic fracture across the hip. But the problem is in Asia, where the people might have to spend, it reaches around 9.5 billion USD in 2018, and this amount of cost is likely to be 15 billion USD in 2050. So they have suggested the strategies to reduce the burden of osteoporotic fractures by making more aware, with the government to provide resources, promote anti-osteoporosis drugs to reduce the refracture rates, introduction of artificial intelligence into the healthcare information system, and cooperation between different countries. Now, this Asia Pacific Consortium also gave guidelines. They actually studied all the guidelines present in the countries. We had two societies providing the guidelines from India also. What they noticed, there was a significant heterogeneity in the clinical guidelines. So there had to be a framework in which the practical conclusions should be drawn. So this amounts to a program which Dr. Dhananjay meant that we should call for a nation is how to have a national program for prevention and treatment. And this is the sum of which I am doing recommendations. Recommendations create material and program for increasing public knowledge, educate about the disease, healthy dietary habits, regular physical activity, and bone health among the children. Second recommendation, educate medical trainees and healthcare workers, because we have seen the secondary, we have to seek for the secondary prevention. Promote the importance of skeletal health, highlight the important promotion. Then screening, diagnosis, and management. What is important here is the importance of creating guidelines for GPs, because here the role of general practitioner, primary care physicians, and family physicians is very important. We must have modules for identifying the patients at risk. We should try to get DEXA to most places. And then we must keep on updating our guidelines. Next, we must have a proper screening, which we might have to develop our own tools at our places, whether we make FRACs in the Indian context, but we must have a good database of our patients also. Then, as we had talked about, we must establish a proper fracture license service to get to all the patients who have already sustained fracture, so that they do not get the second injury or second fracture due to osteoporosis subsequently. And these patients, all patients technically will have to be made aware of the responsibility for their key health behavior. How do they walk? How do they sit? How do they have the efforts to prevent fractures? Another is the research. We must have a prospective multi-center cohort studies. We must have some regulatory financial atmosphere to encourage the industry to participate. We must have a national fracture registry for these fractures. And then we must have a committee that can look for the implementation of the outcome. We must have long-term research and a knowledge transfer, and we must have that implementation of the action plan, which can primarily be held from the Ministry of Health, which is all responsible. And then we have to include all the public health units, school students, primary care physicians, all the government agencies. So To conclude, the call for nation is we must have planning for a short-term and long-term goals. We must execute them, track the performance of the action taken to achieve all these recommendations. Thank you. Good morning, friends. I'm thankful to Dr. Dhananjay Gupta to have asked me to speak about osteoporosis, the implications and the task ahead in this India Arthritis and Osteoporosis Conclave. Let me share my screen.
बीपी में द कौन सा है नीचे वाला
And we would like to ask the panelists for their views on what has been discussed so far. We will keep it short because we have to get on to the next session. We're running short of time, but Dr. Rupali Roy, would you like to comment on what has been said so far?
Thank you so much, organizer here. There are so many things to like discuss, but I know there is a short, we are running short of time, so I will keep in short. I feel like as Dr. Dhananjay sir said, like the theme for this year for World Arthritis Day is don't delay and connect today. So, and this year on 1st October, we also celebrate the International Day for Older Person. And the theme for that day was digital equity for all ages. And I feel like both the theme have some connection. Like we may connect with all older person in all ages, including older person, either physically or digitally. And from all the like speaker, as they spoken from all the speaker, I can found like there is a need for advancement in digital advancement. So we have to work further in that direction. And definitely as our DDG sir, Dr. Anil Kumar said, like there should be some strong collaboration between the government people working for this program and the private clinician and other organization who are involved with this program. So some maybe in the form of some collaborative research, like under the program, as Dr. Anil Kumar says, there are our regional geriatric center. In AIMS Delhi, there both the thing is there, like RGC also is there, and then NCA is also there, and well-established geriatric OPD ward, it is present. So, and maybe with the one of the host for this program is the Fortis Hospital. We may think of, with the permission of DG sir, some collaborative research on maybe some on community rehabilitation, IoT devices, as our first speaker, Dr. Krishnan sir said, maybe as Dr. Ramesh Kumar sir said, the osteoporosis prevention treatment part. So we can plan in that direction. And for community rehabilitation, as sir said, now this program also integrated under Ayushman Bharat Health and Wellness Center. So under the program, we are trying to give at the best of our services at community level with the help of our field worker at the help. So these are the things. So we may work further, and some recommendation, as Dr. Ramesh sir said, we are fully, I am fully agree with that. But I think the few component maybe we can integrate in our existing program before starting the separate program for osteoporosis. That's all from my side.
Thank you. We'll just continue with the next speech right now, which is Dr. Ved Prakash Medha. He is a consultant orthopedic surgeon from Gwalior, and his special interests are arthroplasty and trauma. He'll be speaking about preventing disability osteoarthritis.
Dear friends, I hope you are having a nice day. I am thankful to Dr. Dhananjay Gupta and to the organizing team to invite me to present my views on medical management of osteoarthritis. I am going to take you through evidences with proven outcome on these measures. The three main problems that cause disability in this ubiquitous ailment are pain, dysfunction, and deformity. Non-operative methods go a long way to relieve pain and improving function. I am going to discuss the measures in two parts: non-pharmacological, those which involve change in lifestyle, and secondly, pharmacological or drugs which have a proven role in relieving pain and improving function. The first thing which has been proved effective by scientific evidence is exercises. Exercise of the joint involved and of the whole body. It keeps the articular cartilage lubricated. 2. It keeps muscle strength. And 3. It reinforces proprioception and prevents falls and joint injury. Aerobic and resisted exercises both have been shown by well-controlled randomized trials to improve physical performance, reduce disability and pain. Exercises should be an emphatic and important part of the treatment of osteoarthritis of any joint, weight-bearing or non-weight bearing. A systemic review of 6 randomized controlled trials showed a clear evidence of beneficial effects of exercise therapy in patients with osteoarthritis. Exercises make patients feel better. Their ability to do daily activities improve. Positive effects of exercise and activity go a long way in preventing and improving disability in osteoarthritis. One caveat, however, should be added and well explained to all patients who present for the treatment of their problems. And it is that short-term benefits of exercise can only be prolonged. Short-term benefits of exercise can only be prolonged by adherence to the regular exercises. To quote John Maxwell, "You never change your life until you change something you do daily. The secret of your success is found in your daily routine. Regular exercises is a habit. The trick to success is to choose the right habit and bring just enough discipline to establish it." Next thing a patient of osteoarthritis has to change in his life is lose weight. Interventions designed to promote dietary weight loss in overweight people with osteoarthritis have been unequivocally shown to improve symptoms and help in progression of disability. A meta-analysis of randomized controlled trials published on the subject supported that a weight reduction of more than 5% should be achieved within a period of 20 weeks to have any effect on the relief of symptoms. Weight reduction in obese patients with osteoarthritis results in dramatic improvement in pain and function on a short term as well as long term. Not only that, weight reductions also reduces the risk for developing disabling symptoms in obese women. I hope men are no exception to this prudent observation. Braces have been used to prevent deformity and reducing pain during routine activities. Upper limb, especially thumb basal joint osteoarthritis, do well in improving function using simple splints. Bracing in knee joint osteoarthritis is a proven method to improve walking pain and probably in deformity progression. Effectiveness in upper limb have been proved by solid scientific evidence in medical literature. Their use in weight-bearing joints of lower limbs has, in a Cochrane review on the subject, presented a nebulous evidence. Aids in the form of walking supports, proper seats during work, aids helpful in bathing, dressing, working in kitchen, go a long way in improving quality of life. Help of an occupational therapist and a counselor is the best way to go through it. Drugs are a part of the treatment of osteoarthritis, an important part of it. Pain is best relieved by medication, but every good thing has bad things attached to it. Systemic side effects preclude use of analgesics and their choice out of a plethora of pain-relieving pharmacological agents. Recommendations from international professional organizations clearly indicate paracetamol as the drug of choice over a long-term use. Traditional non-steroidal anti-inflammatories like diclofenac, piroxicam, because of their adverse side effects in gastric mucosa, kidney, liver, cardiovascular system, should be used only when strongly indicated, that too for short or very short duration. COX-2 inhibitors, also called COXIPs, can be a safer choice in the presence of severe pain and or inflammation. But are these recommendations reflected in clinical practice? Survey data from developed countries indicate that majority of general practitioners who are usually first to see these patients are sticking to these recommendations. Data from India, I'm afraid, may show rebellious inclinations. But I will stress again that choice of painkiller in presence of pain in osteoarthritis is paracetamol. What about other drugs which have been claimed by lay press and non-peer-reviewed articles as panacea for osteoarthritis treatment? Chondroitin, which is a chondrin derivative manufactured from shark and cow cartilage, have been marketed as regenerator of articular cartilage. However, a meta-analysis published in 2007 showed the symptomatic benefit as minimal or non-existent. Glucosamine, market in sulfate or hydrochloride form, is also a natural compound found in cartilage. It is harvested from shells of shellfish and also made in laboratories. This alone or with chondroitin sulfate has been shown to contribute to reduce the intake of painkillers in osteoarthritis. Their use should be determined on the basis of available scientific evidence and prescribed with an informed decision on their doubtful efficacy. A meta-analysis of 26 articles published 3 years back also failed to show a conclusive evidence that they are effective to alter the course of the disease in osteoarthritis. Diacerin is a slow-acting medicine of the class anthraquinone, which is prescribed often for the osteoarthritis treatment. A Cochrane review on this drug showed a slightly more improvement of pain as compared to placebo. Collagen is a nutritional supplement from animal source which is rich in amino acids. It has anabolic and anti-inflammatory effect. Its use in osteoarthritic patients has been shown to decrease the symptoms, especially pain reduction. Oral hyaluronic acid is a high molecular weight polysaccharide. Its efficacy in relieving arthritic pain was demonstrated in several clinical trials. It showed improvement of inflammatory process and of muscular strength. ASU has been introduced in the treatment of symptomatic osteoarthritic patients. It showed positive response in pain relief and prevention of progression. So in summary, these nutraceuticals or oral supplements of animal and plant origin have shown prospects for improvement in symptoms, prevent rapid progression of disease process, and reduce the need for analgesic drugs. Intra-articular corticosteroid injections have been used for quite a few decades in treating acute exacerbation of arthritic joints. They have been shown to reduce pain and improve function at least for initial few weeks. However, in a Cochrane review of 27 randomized controlled trials, use of intra-articular steroids failed to show a change in the quality of life or disability caused by osteoarthritis. Viscosupplementation by injecting hyaluronic acid into the arthritic joint is a novel approach to relieve the symptoms. It is aimed at buying time to salvage the joint. It is used more commonly in knee joint osteoarthritis. Though a systemic review of 89 trials involving more than 12,000 patients indicated a small benefit with increased risk of adverse effects. A Cochrane view on the subject showed a beneficial effect on the pain, function, and subjective assessment. However, a considerable variability of clinical response was observed between different products available. Till now, we have been discussing on available evidence of various drugs on improving arthritic joint by reducing pain and restoring function. A role of alternative medicine at present times cannot be excluded from this discussion. Substantial subjective improvements have been claimed with other alternative methods of treatment like Ayurveda, acupuncture, massage with herbal liniments and oils. I am in no position to confirm or deny their claims. But of course, a scientific discussion and exploring their roles is a worthy line of progressing. Let me quote Irving Lemure: "The scientist is motivated primarily by curiosity and a desire for truth, and that's where the future for mankind lies." No treatment for osteoarthritis is complete without a good, compassionate listening and a sound, truthful counsel. A patient has to be explained very clearly that what has happened is a slow aging process without any fault of his or her part. It is not going to make him or her disabled overnight. What a doctor is trying to do with these methods and medications is to make his or her life and limb pain-free with tolerable disability. He or she has to accept it and contribute fully with his or her efforts. Just visiting doctor for a prescription on a piece of paper is not going to resolve any of her problems. He or she is a part of clinical team. Instructions about the exercise program and weight reduction have to be followed religiously. A good counsel is the most important part of the treatment to prevent arthritic joints to make him or her disabled. Thank you very much.
Thank you so much. Now that we are running short of time, can I just
Dear
ask
friends,
Dr. Gurinder Bedi, he
I
has
hope
30
you are having a
seconds
nice
to
day.
express his opinion about this
I am
particular session.
thankful to Dr. Dhananjay Gupta and to the organizing team.
We've had 4 talks in this. One by Mr. Krishnan Dharmarajan, who spoke about the advent of technology and the effect that technology can actually make in the healthcare sector, especially in terms of remote assessment of people and the implications of getting a database for these things. And more importantly, the absence of any much work, especially R&D going on in this sector, which has huge implications for our impending population. Anil and Ramesh both actually spoke about the national perspective on musculoskeletal diseases, especially the fact that we really don't have any organized program, in spite of the fact that this is somewhat about close to the 3rd most important disability in musculoskeletal problems, account for a significant amount of handicap which is there in the population. We don't really have a program running, and we especially don't have a program running for the geriatric population, because that seems to be, almost sort of ignored at this time, whereas we have things like, the women and child in programs and all are running. But the geriatric population, especially because they will become dependent, even with the smallest amount of disability, like a fractured neck or femur or something happening, the implications on their lifestyle and that for the rest of the family are fairly immense. But we are not really sort of organizing ourselves well. I think the importance of geriatric care in a country in which it's a looming crisis of a population of above 70 occupying somewhere about 20% of the actual population, and not having a program will put a huge dependence on the rest of the population to look after them. And unless we have actually a trained group of paramedics and physiotherapists and all looking into this problem, we will have a problem. So maybe a geriatric care MD or something that we discussed is a great idea, and that would be very, very useful. Dr. Mehta spoke about all the evidence which is there for managing osteoarthritis. And as you can see, there is very little actually firm evidence for a lot of practice that we presently do. And we actually, the wonder drug for arthritis just does not exist anywhere in the world at all. So it's not going to be something which is just going to be wished away or go away. It's something that you almost have to learn to live with. And the more you learn to live with it and fight the problem as a comprehensive program rather than that magic bullet, will not get over it. Thank you so much.
Thank you so much. You have eaten into the time of Dr. Ravi Nayyar, but still I would like to give him at least 10 seconds. Nayyar, please.
Thank you so much. I think from administrative point of view, it was a community rehabilitation, which was the main topic. I think we addressed the government point of view. We have the, as Dr. Bedi has said, There is no definitive program for this geriatric people. And I think so while in a corporate hospital, I'm there, the administrator. So there is no well-defined geriatric program. And I don't know what a government hospital, there are geriatric programs, there are geriatric clinic. If you see the outside world, they have the well-defined geriatric program to look for the aging population. And the last pandemic has thrown a lot of question to us. And I think so we need to work on this program. I'll not take time. Thank you so much for inviting Dr. Dhananjay Gupta. It was wonderful.
Thank you so much, sir. It's been a great honor to have you over here on the stage. Thank you so much, gentlemen. We do have arranged some mementos, but unfortunately, they are not the ones who can be carried lightly. So we'll keep them here. Moment you're about to go, let us know. We'll be too happy to hand them over to you. Thank you so much, gentlemen. Now for the second session, I'm going to invite the panelists. There have been certain dropouts and some additions also. So the first of all, I'm going to invite Dr. Lalit Mani. He's the president of Delhi Orthopaedic Association and the professor, Department of Orthopedics at Maulana Azad Medical College and LNJP Group of Hospitals. I would also like to invite Ms. Asri Ghosh. She has been an author and a journalist and a linguistic rather. She's been, and I would like to invite Dr. Neera Baryok. She is from the Judicial Services. Presently, she is working as a chief legal advisor with DDA. Please. So now I would like to invite our first speaker, an eminent educationist, Dr. Meenakshi Kushwa. At present, she is the principal of Birla Vidya Niketan, and I can vouch for her expertise in this particular field because both of my kids, they have passed out from their school, and the changes which she has brought about in the curriculum has been quite visible. Yes, Dr. Meenakshi, please.
So I'll have to keep pressing, clicking. All right. So good morning to everybody, and Dr. Dhananjay, good morning. And thank you so much for inviting me here, because I'm not a doctor in terms of medical professional, and too much of learning happened for me because one, I'm in that age bracket where these arthritis and these things are common. And trust me, each symptom I was realizing that I have. And each time there was a remedy or a medicine that was coming, be it paracetamol or anything, I was thinking, yes, I can have it if at all need be. So thank you so much. For me, personally, it was a huge learning. All these sessions were great. Well, I come to speak about the pandemic time, and majorly on 18th March 2020, when we were suspecting something like schools being shut down for some time and all, we were thinking how to continue with education, and bang on 18th March 2020, a new session was to start. So we quickly thought that let us start making videos and put them on the Google Drive so that children have something to see at home, and when they come back, we will be able to discuss and all. Not realizing that Google, or when you put something on Google Drive, which is the free account, more than 50 downloads happen and it just blocks. And schools have a lot of children. So we realized, no, it won't work. Trust me, there was no one to teach us anything. We were all, grappling and trying to understand how to go about learning. And the whole journey is nothing but full of learning, experiencing, and innovating. So today, when I stand here to speak about how online education has started, has impacted the minds of children, I would say that it has impacted hugely, negatively and positively both. It was a new beginning, of course. How do I pass on to the next slide? It's not working. Can I get help? I'm sorry. It's not working. Yeah. So, all right, thank you. So, my school started in 1983 and it was a smooth journey. And then came 2019 and everything was topsy-turvy. Schools were shut down. You can see that how the life of a school is full of children. There's no concept of physical distancing per se. And they are hugging, they are touching, they are at times hitting, they are, everything is, you know, in a very closed kind of, you can say, background. And there is nothing like keeping a mask. Children share from each other, the tiffins, the stationery items, everything. So for us, for our children, it was a major change. As you see in the pictures, our assemblies are all children standing very close to each other. And I am speaking mainly about the alpha age, that is the children born from 2010 and will also be born up to the year 25. So for us, as I said, this was a change that physical distancing was the word, you know, we really didn't understand how to teach. So lockdown started and I thought, all the principals thought that the world has paused, but education must not, because education is something that's going to have its impact in the future generations also. So we all kind of grappled to understand how can we go ahead with education. And finally on 24th March, when the lockdown was imposed, we started thinking what to do and we somehow discovered about Zoom. We didn't know what Zoom is. Trust me, we had never attended any virtual conference like that. And working on Zoom in itself was a huge innovation for all of us. 280 teachers, training all teachers to take classes when I was adamant, and most of the principals were adamant that we will not delay the session. The show must go on no matter how. So we had overnight trainings, we made groups, we taught teachers that how can they take classes on Zoom. Well, everything started, and then in newspapers it started coming that Zoom is very unsafe. Now with that, the parents started telling us, no, stop using Zoom because we are using the same laptops as our children are using. Now that was a huge challenge. So choosing the right platform was the biggest choice, starting with Zoom and ultimately with our innovations and research and everything, we all switched on to Microsoft Teams by July when the school reopened after winter vacation. Because cyber crime had also started coming up. Children were far more innovative than us. So it was like a, you know, cat and mouse race. We would think of something and children would graduate it before us and get into something even more naughtier, and there were complaints. There were 2 days when I had sat on the in the police thana station because some child had given some nasty comments about, a boy had given a nasty comment about a girl, and there was a complaint and all that. Then this boys' locker room came up, most innovative, you all must have heard of it. So one child from my school was also involved into it, and we were so scared, my God, it's coming in big ways in the newspapers and all. And what a relief when we ultimately came to know that the boys were not at fault in this. Trust me, I was absolutely thrilled, and the first thing I told my teachers, relax, boys are not involved into this, so it's not my boy who's going to be punished or anything, though he was also booked under cases and all. So challenging times, Coming next to technical know-how. As I said, we were all, trying to understand how to take on education. Technical know-how was most challenging. The teachers did not know how to make good presentations, which can be shown through an online mode. Normal PPT is okay. I personally observed around 600 classes online just to ensure that teaching is happening properly. Teachers made podcasts, they made videos, checking all of them because the parents had also entered our classrooms. Trust me, parents kept on telling us, this teacher is teaching well, this teacher is teaching wrong also. And there were a lot of things, so it was a continuous innovating experience that how can we deliver the best. And there were times when parents would attend classes on behalf of the children. And when we asked, why are you here? No, ma'am, my child is sleeping and I will teach him after I've learned in class. So, I can write volumes on the experiences. There were times when the video is on, mic is on, and the mother is telling the child, "Uthna, teri teacher aa gayi hai." So trust me, it was an experience. Children had bigger challenges because some of them had very small houses and they were sharing the laptops also. So one child would attend one class and the other one would attend the other class. So we started giving them recorded classroom sessions also so that children could see. And there were too many people at times living in the same house and they were visible and children were ashamed of turning on their videos. The moment we said, okay, turn off your videos because you are embarrassed, the child would turn off the video, turn off the mic, and God knows where he has gone because when the teacher is asking the questions, there was no response. The next innovation came in that, okay, make Google Forms or things like those so that you can continuously keep on asking children to answer the questions and you at least know that the child is mentally in class. So a lot of innovations and technical know-how. By that time, we had all graduated and we had all mastered. Limited resources was another challenge, that children didn't have laptops. Children didn't have, teachers also sometimes didn't have laptops because the lockdown started without any warning and they were teaching on their mobile phones, which weren't very effective initially. So these were the issues, and space problem I've already discussed. Network issues, genuinely or not genuinely. I mean, just to get rid of the class, ma'am, network problem hai. There were times when we could find out that there's nothing like it. Then the parents in the PTA started coming, no ma'am, there was no networking issue. My child was just trying to avoid. So we always told the parents that your responsibility is the maximum at this point of time because you have to actually see and monitor what your child is doing. Is he also in the classroom, mentally or no? But the parents are parents. Probably most of them have no control over their children. So, ma'am, he doesn't listen to me. Why don't you do this? Why don't you do that? Not understanding that we are also fighting a situation which is tough. And we have no control over children when they are across the laptop. A lot of parental education also had to be done, especially for the special children. The mothers or the fathers or elder siblings had to sit and we had to take special classes for them so that for them also, learning doesn't stop. They are able to take forward education with the children who were special, who are special. A lot of operational challenges. Cyber ethics was, I would say, 80% zero, because children are children. Somehow they got a license from the school and from the parents that they can use internet 24/7. So that was another. A lot of workshops were organized by eminent cybersecurity experts, so that children were educated that how to use internet in ethical way. That was very important. Evaluation was very, very, very challenging because children had mastered all the ways to unfair means to be assessed. There was a time when I thought I'm very smart, and I said, okay, everyone will put a earplug and the videos on, and the children would write the exams, and there's a teacher monitoring that, is he writing, nobody's telling, and all and all. Not realizing that they had remotely logged in the brighter students onto their computer who were telling them answers. They were able to see the question paper remotely, and they were telling answers to children. And we thought that the child is writing exams, but actually somebody else is dictating the answers. So as I said, that it was a cat and mouse race. Each time we were innovating something, children were immediately innovating far more than that. But yes, a lot of learning has happened, and children have become very smart by the end of these months, and they can use internet and the information of internet on internet in a very right way. Gradually, that sudden license for using all this has died down now. There's not so much of craze like that. So they are now coming back to regular learning. And yes, some students were so good that they used that time which they wasted otherwise in commuting, etc., to school. They have written articles in the journals, and they did a lot of discoveries and a lot of laurels they brought to school just because they could surf through the net, research properly, and be able to excel their skills. And so that was one thing good about that. I discussed the challenges, coming to now the solutions. So the first is that I said we started using Microsoft Teams over Zoom because we realized it is a much safer platform. Then self-paced learning, we all learned at our own pace, and training sessions were organized. We didn't have money to take help from outside agencies. So we would train ourselves, and then we would train the other teachers. There was training happening throughout the night in batches. Then there were children who didn't have laptops. So we provided them, not too many, but to few, we provided laptops and all, of course, mainly to the children from the weaker section. And we provided them laptops. We asked parents to donate laptops and mobile phones so that children could use those who were not able to use. And students were counseled to take classes independently without their parents sitting next to them. Cyber smart school we all became, and we learned to respect the digital users, the internet users. This is something that children have learned really well, that this is one area where they need to respect. And as I said, that craze is over now, and they are all using internet in a proper way. There have not been any issues of late. Netiquettes, everyone knows. So assessments were the challenge. So we innovated, and we started giving more of group projects. With group projects, children learned more to adapt and adjust with others. The groups were made by us, and children had to learn to work with each one in the group. Initially, there was a lot of hue and cry for this, because that child does not do anything, I do everything. So the child was forced to know, whatever you do, you have to motivate the other child also. So a lot of ICT tools were used, like Kahoot, quiz, Padlet, quizzes, etc., to make teaching learning more interesting. And most of the times we encouraged children to make these quizzes and questions, etc. So learning happened greatly in that way because children were involved in making the questions or quizzes or whichever way. There was a continuous evaluation in senior classes. There was never a continuous evaluation, but of course in primary classes it had always been, but it was more rigorous. Each day, in some way or the other, child was evaluated and commented that this is lacking, the child must do this also. Game-based activities started in a big way because just lecture is something not very interesting, mainly for children who are very young, who just can't sit for many hours in front of the computer. So it had to be game-based. A lot of challenges like anxiety, depression, all these came up. We learned to manage them. Children were used to help. Children were guided to help the other children in case of depression and other things. So a lot of peer learning also happened in this phase. Physical fitness was important because we knew children are not doing any exercises at home. So a lot of stress was given on physical fitness, and morning, evening sessions, regular classes also happened so that children did exercises. And we invited their parents also into this, that they can also come and join in for exercises because physical fitness is very important. The workshops were taken and you can see some of them. The parents are also doing exercises with their children. As I said that, it has become a rewarding experience, focus more on AI. So now today, after all those innovative studies and methodologies, practicing and all, we have switched over to a flipped classroom and a lot of self-learning has started. Like the teachers giving the videos, for example, and not teaching next day, but asking children to debate on those. So this is one good aspect of it. And AI and 21st century skills are being used in a big way, and they are being developed in a big way because NEP 2020 also focuses on them. These again are the pictures. You can see that the podcasts, life skills and everything. Art integration was involved in a big way, be it be kitchen, be it be garden or whatever, or the balcony. Children were encouraged to get things from there and use them while teaching. There was a 360-degree holistic development, I would say, that happened in this time and paving a way towards NEP 2020 in a successful manner. These are again some pictures that. So this is a screenshot of the resources which we gave online to children, and children could access them anytime. And this was the flipped learning aspect. Parents' role was very important all this time. A lot of storytelling and all these workshops were held even for parents of the primary school to ensure that they learn how to teach. The grandparents, the families were involved, I would say. A lot of innovation in pedagogy, additional content, especially through methodologies like gaming, coding, and other tools and apps are available. We learned to use, and best was that children helped us to use them because they are much smarter than all of us. Experiential learning took a leap. So we are better educated after all these months, and a lot of innovations happened, and we started thinking out of the box. So once teachers start thinking out of the box, they encourage children accordingly, and children are very smart in picking up. So I think it has been a successful journey for schools like ours, but then the ASER report and the Hindu and all newspapers say that 42% of the students in India have no access on remote learning. So that's a huge challenge. And if they say that very rightly, that the child's brain is formed up to 6 years of age, 85% of the brain is formed up to the age of 6 years. What has happened to the brain formation of those children who have never been to school, and at home also the atmosphere is not conducive. So these are real challenges which will be required to be plugged in once the schools start physically, and psychological, socio-psychological skills have gone for a toss in most of the children. So schools will have to work and find another set of innovative methods to be with them once all children come back to school, because I'm sure in spite of all this being done, even in schools like ours, we would see learning gaps. We would see psychological disorders, though the fractures have gone down, I'm told, amongst children, but the other issues have cropped up, and I'm sure we will all be able to fight this battle also. Thank you so much.
Thank you, Dr. Kushwa. It was quite an enlightening talk. And yes, it was a challenge, I think, for all the school management, the teachers, the kids, and the parents, of course. I mean, the biggest takeaway, I would say, rather, that the people, they had to spend more time at home and looking after the kids, their education, the way they have been involved in the complete process has been amazing. We have one more of our panelists who has just joined us, Ms. Sumi Gupta. Can I please ask her to come up on the dais, please? She's a chief editor, executive editor of a print media. She works for Tattva Chronicle, which is quite an enlightening magazine. I've gone through it a couple of times. Fine. The next talk is by Mr. Sharad Nigam. He's a vice president and head of strategy and digital operations, Hitachi India. And unfortunately, he had medical emergency at home, and that's the reason he could not make it. But he has sent his talk as well as the audio. Can we have the audio, please?
My sincere apologies, as I could not make it in person today because of a medical emergency at home. But I'm trying to record this so that I can still share my views while a team member there on site can navigate through the slides. If we move to slide number 1, these are 5 or 6 points which I wanted to share my views around. One is around how the COVID impacted on the liquidity and what were the sequence of events which happened. Also, I will try to cover impact of such liquidity issue on corporates, society and healthcare sector, and what could be the strategies to manage them well. Last but not the least is what little contribution Hitachi is doing in this sector. If we move to slide number 2, here I have tried to explain the whole sequence, how it impacted on liquidity with 6 major factors. If you see, the lockdowns led to supply chain disruptions, which led to reduction in consumption heavily. Because of less consumption, obviously it impacted on the industry, the cash flow, and many of us got either layoff or significant amount of reduction in our salaries and bankruptcies, etc., which impacted individual as a society and as an industry. There was a significant cash crunch for employees. And if we talk about sector, MSME was the sector very badly impacted. In these uncertain times, we also wanted to hold cash with us for the emergency or any uncertainty in our life to manage it well. With all this, how it impacted to healthcare sector, we know there are several reasons and there are several aspects, but one of them which I am trying to highlight here is government's decision to restrict elective surgeries and other non-essential treatment. This was one of the major factors which also impacted on healthcare as far as the liquidity is concerned. If you move to slide number 3, this is the kind of impact on corporate we have observed. The overall supply chain, which is supposed to be the heart of the whole business, was impacted. The labor shortage was observed, and the corporate sector was really struggling with the liquidity crunch to be able to pay salaries, to be able to pay rent and other common expenses. We have seen Government of India taking some measures to support the overall industry as well as MSME, and I have highlighted some of them. For example, we heard about the credit guarantee and collateral-free loans. Especially for the MSME, there was a allocation of a significant amount of budget for subordinate debt. In fact, there were revisions on definition of MSME. Such kind of several examples are there through which Government of India has been trying to help this sector in general as well as MSME as a part of it. If you move to slide 4, now the question comes that how corporate sector is trying to manage. So I have, there are several ways and there are several leading practices, but I have just highlighted 5 out of them here. First and foremost is the supply chain risk. What I have seen many of the organizations doing, that they did not depend much on the national or global supply chain, rather to maintain cash flows, they have sourced it very locally. And it really helped them in managing the cash flows. They also adopted some of the latest technology to predict such kind of supply chain disruption. They also, coming to point number 2, they also worked across all the 3 components of cash conversion cycle, which is maintaining inventory levels, extending payable wherever possible and intelligently, and also managing and expedite receivables. So all the 3 components corporate sector has relooked and worked upon to manage the cash conversion cycle. Some of the organizations where it was possible, they even went beyond these basic fundamental steps and worked on generating new alternative source of revenue from the same assets which they were using for their regular business. They heavily worked on variable cost and its reduction wherever possible and without impacting their core business. They also took advantage of various stimulus package. So these are the 5 important and major things which corporate sector had taken as steps towards this. If you move to slide number 5 and see how it impacted on society and individual, this year 21 was the worst year in terms of economic contraction with an impact of 7.3%. Even though this kind of national income declination has happened in past, I think 4 or 5 times, none of them was having such a scale. And to understand the gravity more, if you observe some points on the left side bottom of the slide, during the first national lockdown, the individual income had dropped by 40%, which is a huge impact. And to add, if you see the third point, which is urban unemployment rate, which increased from 8.8% to 20.8%, which is around 2.5 times. As I said earlier, some initiatives were taken by Government of India, and I think we are well aware. So to avoid any repetition, I would like to move to slide number 6. Now, as society and as individual, what could be their strategies? I think the first is self-explanatory, that we have realized and we have learned an effective way to manage emergency fund with us, either as at individual level or at family level or at organization level. Also, the exercise which happened across community was to strict budget measures, wherein we prioritize our expenses and only focus on essential financial commitments. I think this period has taught us several ways and means to manage our financials in a much better way than we had or we were knowing before the COVID. Also, while there were some support and offers, people have become aware to borrow with caution. The fourth point is taking moratorium on loans should be last resort. And the third and actually fourth point are both interrelated. Even if we have received some support from government or even other offer from private sector, an awareness among ourselves has increased to deprioritize loan in our to-do list as much as possible. Fifth point is related to the bare minimum and essential, which has become a priority for all of us, is to cover our life and health through insurance. These are 4 or 5 points I wanted to share. Now, if we move to slide number 7, how it all impacted the healthcare sector. I think I talked about it earlier that there was a significant decrease in the volume of elective procedures. And in fact, if you observe the second point in the right side, even many patients were not able or not willing to visit hospital. Even if it was not in the category of restrictions or regulations, many patients, because of lack of awareness or because of their, fear, they did not come out to have essential treatment. There was obviously a standstill in medical tourism, which we observed. In addition to the first impact, the second, if you see, there were a lot of unplanned expenditures in front of healthcare sector. And we all know that, a lot has been done by healthcare sector to maintain the COVID protocols and manage the operations in such a difficult scenario. The third biggest impact, in my view, was disruption in health insurance, where we even saw private insurance companies taking significant time in claim settlements. All these were very important factors which impacted healthcare sector. Now, if you move to slide number 8, the regulatory authorities have supported this sector in some way. For example, there was a on-tap liquidity window of 500 billion INR. There was loans to wide range of entities. And if you observe the third point, which is as an additional incentive, lenders were able to eligible to park their surplus liquidity up to size of COVID-19 loan book, which was again a good support to the industry. And from the Insurance Regulatory and Development Authority, we also observed a couple of things wherein they streamlined processes or improved some restrictions or guidelines for the claim settlement and decisions. Even I heard about the premium for health insurance also was made there was some flexibility made for the payment of those insurance premium. These were minor, but a support to this industry. If you move to slide 9, now the question is that what healthcare industry is doing to manage this crisis? I found one very good report from where I took this in terms of what CFOs are doing. And while there are some common things which were cutting across industry, what I observed, which comes out unique to healthcare industry, was, if you see the fifth one, which is implementation of long-term shift to telemedicine. And I think we can correlate with the scenario in which we are going through, how telemedicine has become an important concept in the scenario that we are going through. There are other aspects as well, for example, optimization of supplies, centralization of support function, reduction in non-clinical workforce. But all in all, these 8 or 9 steps have helped our CFOs to continue managing the top and bottom line of healthcare sector, and still managing the customer expectations by performing the operations of day-to-day things in a better way. If you move to slide 10, I have also indicated those 5 strategies which, as an organization, this sector took. They went through the liquidity requirements in detail. It is not that they were not doing it before, but the sensitivity and the detailing of the business plans, budget, and forecast was way above than a regular one. And that is why, as I said earlier, COVID provided an opportunity for us to look our business plans once again and critically examine them, what really is important and what really is critical for the operation. We also adopted different strategies to structure our capital, especially working capital, and managing the cost. Some of the organization also, which were flexible and had ability, they worked on raising incremental finance even. The third is very important aspect where we observed that the cash flow was a very big problem because of the movement and access to ATMs. And some of the healthcare organizations opened up to accept larger part of their payments via digital ways. So they were not restricting it to cash. And I'm talking about the mid-size. I mean, the large organizations anyway are accepting and have been accepting the digital payments and have all the modes and means. But there was a significant change in the mid-size and small-size healthcare providers, wherein they quickly adopted all these digital ways and means. They extended their source of revenue, and adopting technology to do that was one of the major trends. If you see, the fifth one is the stimulus package. The liquidity window, which I just talked to you 2 slides back, was also utilized. So these are the 4 or 5 aspects which I felt was a kind of trend among the organizations to manage this situation. If we move to slide 11, I will briefly talk about how Hitachi is contributing. I will not go into details, but I'll just share the glimpse of what is being done. Moving to slide number 12. Hitachi MGRM Net is a JV which works on providing solutions across the citizen life cycle. And as you can see, during the life cycle, we have multiple touch points, right, from birth to death. There are some 10 stages which we have defined, wherein a common resident or citizen goes through these different experiences, and healthcare is one of the most important aspects out of those 10. In this particular area, we are focusing on 3 things. One is telemedicine, the second is health management, and electronic health records. If we move to slide number 13, this is the MSTAR Health e-governance platform, And as shown in the slide, there are very important and important as well as effective modules to manage the healthcare of a common man. The modules which are highlighted with orange color on the top of the slide, for example, the hospital information management, medical college management, queue management, these are very fundamental but very critical element of operations in such sector and add a lot of efficiency in day-to-day operations. Then there are certain modules on the lower slide which are highlighted as green. These are those touch points and part of the overall delivery of different aspects of this e-governance platform, which utilizes all these operations of the orange color to make it effective. If you move to slide number 14, these are different. Telemedicine is a new branch of science. I mean, in our own word, we call it as a science, not just as a concept. And especially this concept and the adoption of this thought increased multifold during the COVID time, which included teleconsultation, counseling, real-time monitoring, remote diagnosis. These terms were only words or terms a couple of years back, but all and each one of these terms have significant impact and support in our life today post-COVID. If you move to slide number 15, the Hitachi MGRM has created a kit with some fundamental equipments which are being utilized by overall a larger community for immediate use in this scenario. So these were some glimpses of what Hitachi has been doing. And once again, as I said in the beginning, my sincere apology, but for not able to be there in person, but I am thankful, Dr. Gupta, to give me this opportunity, and I hope I was able to share some of these strategies across the three aspects where it is impacting a lot. Thank you. Have a great day, everyone.
Thank you so much, Dr. Sharad. It was a very comprehensive overview about the financial impact of the COVID on the society in general. I think before proceeding with the next lecture, can I have Ms. Sumi Gupta's views on the financial impact again, because I think we won't be able to get the views of each and every panelist on each and every lecture. So I think we'll stick to one panelist on one specific lecture. Sumi.
Thank you, Dr. Gupta. Good morning, ladies and gentlemen. COVID-19 pandemic and the ensuing lockdown restrictions caused unprecedented job losses, education divide, mental health issues. Amongst many other problems, India witnessed huge migration, economic slowdowns, and a large number of job changes. The way the financial model has changed, business models have changed. To give you some examples of how livelihoods have impacted, the CMIE data shows that lockdown affected about 43% of national workforce. That's almost saying that half of India's workforce either lost jobs or had reduced in incomes, impacting the entire economy. Even as late as December 2020, of those who lost work during the lockdown were unemployed. Further, the data shows almost 17% of the collapsed earning in lower income households, which in real terms actually means 1 month of salary per year as compared to 2019 in the year 2020. For lower income distribution bracket, average household income practically being zero, the 2 months of lockdown, they had no income going further, and 10% of the household lost almost 3 months of income from the period of March to August. The economy further shrunk 15.7% in the first half of 2020. To add to this, bank credit to commercial sector continues to be shredded, and private investment continues to be even lower after the phased relaxations and restrictions have been reduced. Despite all this, one has witnessed a new rise in the gig economy. I will share with you some data to see how we witness and what gig economy actually is all about. We have seen how businesses have changed their ways of working, advantages of remote working, and the impact on stressed cash flows. The pandemic introduced remote working and contractual jobs, project-basis assignments, and loss of full-time jobs. Now, the gig economy basically involves hiring of people for a specific task, paying them per task. Now, this was effectively rise in the US. And to give you an example, in the year 2014, about 14 to 20% of the entire workforce of the US was a part of the gig economy. But in 2021, it suddenly rose to 35%. And now it is estimated to be 50% by 2023. And having said that, in India, we are expecting something around 15 million jobs in 2021, going up to 350 million jobs by 2025. Estimated $455 billion in 2024 to be a part of this part-time job. So where you had a blue-collar job, white-collar job, secure job in all your sectors, now it's a part-time job, task-based job. So every leader, every manager, whether it is in the health sector or finance sector, has to restructure, remodel your way of functioning, remodel your business structure. One of the reasons, major reason for this rise is the accessibility and penetration of internet. That also changed. Approximately 15% accessibility and penetration of internet in India was in, say, 2015, to rising almost to 40% estimated today. So that has given access to people being able to access their devices at home and work from home. Also, another reason for this is that during the lockdown, forced schools to close down, offices to shut down, forcing parents to become teachers at home, forcing students to learn online. So teachers were working from home, parents were forced to do jobs, juggle between jobs, home, and teach. So they were stressed for time, and portion of their time went in giving emphasis to their children, managing their relationships within the family. A lot of mental stress was on the rise and still is on the rise. This forced them to take freelance work rather than full-time jobs, which was a lot of commitment on their personal time. Now, this freelance culture has given rise to this new concept of gig economy, complete gig economy. ASSOCHAM has estimated that about 15 million freelance workers are already in the IT HR sector, moving to healthcare, pharmaceutical sector, BFSI sector, rising almost to 75 million by the end of this year. Furthermore, FMCG pharmaceutical sector in a matter of 2 to 5 years, from a 15% as of today, will employ about 69% going forward. In a manufacturing, from 35%, freelance or contract workers, as you call them, will employ something about 65%. Technology BPO is already on the high, which is close to 57%, employing about 60%. And your services, almost 76% will be contractual workers. Now, one of the other reasons for rise in freelance is rise in freelance platforms. So rise in freelance platform like Upwork, Freelancer, Gurus, such platforms provide skilled professionals. There were somewhere around 80 such platforms in the year 2009, and there are 330 such platforms in the year 2021. So there's a huge change in the way, in the model, and these platforms are majorly accessed by millennials. So millennials are definitely the ones who want a work-life balance. They're the ones who definitely don't want a 9-to-5 job. They're the ones who definitely want the freedom of choice of project they want to work on. They don't want to do the mundane jobs. These are some of the reasons why there's a huge shift in the way the country or the way the economy is shifting, the way your funds are shifting, the way the liquidity is going to be shifting very soon. Also, there is another aspect to this, that there is a downside to this model. The downside is because of lack of security. There is no job security. You don't have pensions. You don't have a lot of futuristic planning that you can do in gig works. So there's a lot of mental health problems that have risen. So insecurity gives rise to a lot of instability. So that issue is still unattended to, which the health institutes along with the government probably need to look into, where studies are still being conducted or research at the moment, and surveys are being conducted. There is no concrete survey. However, there are some reports which say depression, suicide are on the rise. One of the reasons for that is because there is no regular income, there is no sustained income, and there is no job security. These are the reasons that have been attributed to some of these suicidal recordings in the recent last 1 year, especially after the lockdown. There is another survey where India stands to lose 135 million jobs because of the pandemic, which is likely to push the full-time workforce towards the gig economy further, causing a lot of insecurity and instability furthermore. So again, there is going to be a lot of pressure on the health sector specifically to look into the mental derivatives and health issues arising out of this instability. Government, however, has taken a step and created a code on social security, which will provide workers with life and disability cover, accidental insurance, health and maternity benefits, old age protection, including others. Under this code, the central and state governments will provide primary fund social security measures with a nominal contribution, maybe something like a 1 to 2% of their annual turnover, by the aggregator or your platform providers, platforms such as I just mentioned, who are the ones where you can hire these gig workers. In addition, the code proposed to establish a national security, a social security board, which will supervise and formulate schemes for the well-being of gig and platform workers. Not taking too much time, I will re-emphasize on the urgent and important and desperate need of health professionals to come forward and look into the mental health aspects of this huge workforce, which is entering into an unknown sector of instability and uncertainty. Thanking everybody for this session and thanking Dr. Gupta.
Thank you, Sumi. I'm pretty sure they may have come up with the theories about the financial situation, but honestly, the people, those who are feeling that crunch, this is something which is very hard to accept them. For our next speaker, I'm inviting Dr. Dhananjay Gupta. He's the director of Department of Physiotherapy at G.G. Goenka University, Gurugram, and has been a leading force for this particular event, Conclave. And it's indeed a great pleasure to invite him over here. Sanjeev, please. And I think the people, they have been sitting here since morning for the lunch. So let's not keep them waiting for long.
This hint is enough that I will not speak for much. And my time starts now. Okay, so good afternoon to all, and thank you, honorable panelists, Professor Mani and Madam Ghosh, Dr. Neera and Madam Gupta. So I am given this opportunity to speak for a very apparent and a very known, I would say, title, that is the challenges that we have been facing pertaining to MSK disability during the prolonged lockdown. And this is a buzz around and everybody understands it. And given the audience which is practicing healthcare, or in a way it is related to healthcare, so I don't think there is much to speak on it. But having been into teaching for past 25 years, I have realized that the more you speak on a particular topic, which we initially find that it's quite apparent and there is nothing to talk about it, but when we actually start speaking on it, we find something new, like I'm a teacher in physiotherapy since past 25 years, but anytime when I speak on diathermy or anytime I speak on ultrasound, I find something new for myself, at least. I don't know how is it on the other end for the students. So in a preamble, I would just say that we must realize that this MSK health is a biopsychological phenomena, and this is an emerging, I would say, concept which is now coming up in the clinician's mind, that besides the organic or the biological processes, a lot has been now related to the psychological things that happen to a person in its internal and arena around. So in those, I would say, contexts, we should have a larger picture of musculoskeletal disability and health. So now, when we say lockdown, we always think that people are at home, people are at leisure, they have more time. But this lockdown has got two extremes if we try to see it in a lot of dimensions. So first is, we had a population, not just healthcare industry, and that too towards COVID pandemic management people. We had, people who were looking for groceries. We had people who were looking for home deliveries. We had people, who were managing household chores and all. So there were conditions in which people working more in the hours. They were working in limited resources. They was working in huge stress. And of course, there was a larger population who had more free time. They were working from home, so the commuting was not there. So basically, I wanted to, give you this kind of insight that when we say that this is the lockdown period and what were the effects of the lockdown period, we have to understand that there were two extremes happening during that duration. So that is the first thing. And in the healthcare, of course, everything was shifted or focused more towards containing or preventing COVID pandemic spread. So all the conditions that could take a back seat, so they took a back seat, and same happened for the MSK diseases. And unfortunately, for the patients who were at high risk also, they were suggested to, defer it for some time. Then I was told that many of the corporate, organizations, they set up a quite good ergonomic settings, working from home people. They gave the complete desktop setup and everything. But a larger population, especially children, as Madam also suggested in her presentation, that they had highly detrimental and non-ergonomic workstations. And most of them were working with mobiles. Sometimes were sharing also mobiles. So you can see that there are two extremes that were happening simultaneously probably. And lastly, more availability of time is something, an apparent perception, but restriction of outdoor activity and mobility was a reality. And the one thing that we are missing in this conference physically is a vital portion of this conclave should be the patient population, which unfortunately we are not able to cater in this gathering. So I have picked up some excerpts from a research article wherein directly there were respondents who responded to different things. So first is, this is a published quotation that I have pain because I am sleeping a lot in daytime, up in night, sitting in recliner for many hours, and usually at 4 AM or so. So this is how they understand that the pain is there, or the more pain is reported, but the population understood that why is it happening so. Now in this slide, I have tried to, again, this is a published article, and of course this is not from India, but a comparable population was, asked for a questionnaire, and a total of 230 respondents were there in this questionnaire. So you can see that the people who were sleeping 5 to 6 hours, they were 80 out of 230, but during the lockdown, the number came down to 38, but not that they were, otherwise it would have been a very, good thing. But now you can see that the lower one, the more than 9 hours. So previously it was just one person who responded that I am sleeping more than 9 hours, but in lockdown, this number turned up to 22, which means 20 times. So same way, if you see the penultimate row, you will find that the 8 to 9 hours sleep, 18 to 85. So this is a kind of sleep trend shifting. And I'm not taking much time, but you can see the time spent on watching television and mobile phone. Now mobile phone, I would not say that it was a leisure activity only, because a lot has been done, work from home and education and all those things. So, but practically the mobile phone usage, again, there was a shift, and more time was spent on sleeping, TV, mobile. But unfortunately, as you can see in the last 4 or 5 rows, that practically the physical activity almost remained similar. So this was the scenario in the lockdown. Then there was a patient who said that I have also put on weight due to lack of exercise and easy access to unsuitable food, but feels that excess weight may have contributed to my pain. So this is there with the patient, that what are the reasons, but they were not coming up to the hospital as they were having fear that they may contract infection, or they knew that the COVID is around, so they were not reporting much to the hospitals. Now, the cause of pain, the respondents with the same survey, the respondents found that they have the pain because they are not at the routine, and they are doing too much of work also. Inactivity was also one of the reasons. So you can find that there are many reasons different respondents, responded to, and the uncertain future again is 15 out of 230 respondent gave this reason also. So these are the different causes, but the majority was inactivity, too much of routine work, and the reorganized kind of routine work. They were doing the same work, but now they were doing it online with a different setup, maybe at a home setting or something like that. Now, there is one more thing. Then a respondent responded like that, I have not been able to do much exercise since working from home. This losing out to the movement seems to have made the things worse. I'm not able to see the heading because of this Zoom, commonly reported painful areas. Yes, this is something important from a practitioner's or a clinician's point of view. The commonly reported areas were mainly the back, upper back, lower back, and shoulder. So probably this has got something to do with a poor ergonomic, workstation and more hours on, screen, maybe a mobile phone screen or a computer screen. But there is a direct correlation I could find that the back and shoulder pain were the most reported pain in the same survey. Now another thing is that people were less motivated to walk because they were having fear that their pain may get flared up and the treatment will not be allowed because of the shielding or confinement. So they were not doing activity even if they had that opportunity in their society or in their community to walk, because they were having this fear back of the mind that if by chance their pain or their ongoing chronic signs and symptoms get some flaring, they will not be allowed to take a treatment, or they were skeptical to move out to take a treatment for chronic conditions. Now, it's not that only the chronic ailments like arthritis and all were at risk. There is a study which suggested that the road traffic injuries were also at high in the later period of the lockdown. Then the suicide attempts were also slightly more reported in the later period of the lockdown. And there were some domestic accidents. This is very interesting that, because of less road traffic, there was unsafe driving. So we normally think that if traffic is less, we'll have less accidents. Of course, it was there in the initial phase, but then we found that there was some unsafe driving behavior also, and some fatal injuries were also reported in the later part of the lockdown. Then similarly, because of less support and financial disturbances, lot of psychiatric support was missing, isolation was there, financial disruption was there. So suicides were also reported more in the later part of the lockdown. And because the people were now more idle, so initially they were skeptical, but then later when the household helps were also not coming, so they ventured into do-it-yourself tasks. So they happened to have some falls also from the ladder or from roofs. So there was some accident reported because of the domestic chores also. So it's not that only the chronic part has taken a back seat. Maybe we'll have more of such things in the coming days, because now the people are coming out and now they are out from the shadow of the corona, and probably we may have spurt of all these things happening. So researchers believe that there can be a musculoskeletal sequelae also, because now, okay, so it's not that the problems that were not reported, they were not there. Of course, the problem could have been lesser because of, people were confined, but researchers believe that maybe people were having fear to come out and to report their problems, the musculoskeletal problems and chronic problems, especially the theme related, the arthritis and osteoporosis. So researchers are expecting that there can be a musculoskeletal sequelae of the post, I would say, COVID-19. Now, because this is almost taking a back seat, so maybe we'll have more reporting of musculoskeletal, signs and all. I need to see my next slide. This time is out of my presentation. It's taking time. Okay. Then there was a study which was, as I said, that musculoskeletal health and musculoskeletal disability and diseases are biopsychological phenomena. So there was a study which categorically, focused on the pain catastrophizing. I mean, the way the pain is, put up as a catastrophe, maybe in some exaggerated manner. So they have found that it's a behavioral phenomena, and sometimes the more you catastrophize your pain or ailment, it leads to acceleration of again. So it's a vicious cycle. So the more you try to report it, the more you try to exaggerate it, the more you feel it. So there was a study which found that the pain catastrophization is lesser in the people who did not have any chronic condition pre-COVID or pre-lockdown, but the people who had some chronic problem, chronic ailment, they had this phenomena of PCS more seen. The gray bars are of the people who are having the chronic problem previous to the lockdown, and the light gray bar is the bar of the people who were not having any. So you can see that there is a stark tendency of catastrophizing their pain and their symptoms during the lockdown period. So that was again a problem which we can find in this lockdown. So the final takeaway will be from the MSK health point of view, the pain was the most frequently reported MSK problem during COVID-19 lockdown, and generalized this is the pain. And in the previous slides, the low back pain, the shoulder pain was the majorly reported pain. Self-care continued during the lockdown, but was ineffective to prevent deterioration of the MSK health. Third is, this is something very dangerous, that forced lockdowns promote cope mentality, making the patients behaviorally adjusting to live with the MSK problems without seeking care. So probably this lockdown would wean out, but this cope mentality or this kind of psychology is because clinicians understand that it was already very dismal in India, that unless they had some ADL problem or they have some locomotory problem, people are not turning to a physiotherapy or to orthopedicians to get them at their best, because unless they found that now we cannot go to office, they were just managing. And this cope mentality, because now this time we forced it on the patient that no, you live it to it and wait for 3, 4 months, 5 months, 7 months. After COVID settles, we will see whether it can be managed or not. So this cope mentality, now we are forcing it. Probably this will be a dangerous trend later. So this is something there. Then lastly, of course, if MSK health is deteriorating, it will have a detrimental effect on the patient's physical activity, which is not recommended. And these are the 4 or 5 research articles I have quoted in my previous presentation slides. So this is all from my side. I wanted to give you something interesting and something new, because otherwise everybody understands that what is the effect of lockdown on MSK health. So these are some special interesting facts that I could gather from the research, and these are all published facts. Thank you. Thank you.
Thank you, Sanjeev. Can we take a bite from Dr. Lalit Mani about this particular talk? 30 seconds? No, please.
Bring out certain very important things, and directly or indirectly, possibly they are connecting to lifestyle which the lockdown imposed. And we really don't know whether this lifestyle is going to become life for people, because lockdown has brought in positives and negatives. So we really don't know what's going to be the continuity of these changes, whether people will stick on to their positives or they will continue to enjoy the negatives. And what's really going to happen to the graph of disease and disability after COVID is another question, because the graphs have really gone upside down during total lockdown and rebound phenomena when the lockdowns opened, especially the example you gave about road traffic accidents. So we really don't know whether remote possibilities of doing things is going to become part reality of the society, and how it's going to change the burden of disease. Maybe wearing mask and increasing the hygiene habits might help us in bringing down the communicable diseases. However, the non-communicable diseases, and MSK backache is one of the major ones, we really don't know what's going to happen. So thanks for really bringing out certain very nice things. Thank you.
I'm inviting Dr. Gagan Srivastav, Senior Consultant Cardiac Anesthesia in a hospital. He'll be speaking on the topic population in peril, hurdles in providing high-end hospital care during lockdown and lessons for health planners.
So I have been given the task to sum up in an allocated time, and I promise I won't take much of the time. But before we start and go on to the lunch session, I have a food for thought, and I think Dr. Meenakshi has left. So the food for thought, and it goes with this, the theme of this conference as well, the musculoskeletal health. And I wanted to highlight, and I have been putting it across many forums as well, why don't we make physical education as part of the curriculum from school itself? Why can't we give a weightage to the physical education classes that happens in school and add some points or some marks to the academic sheet or academic evaluation to the students as well? Maybe not evaluate those physical education as compared to, as similar to the academic subjects, but maybe carry forward some points so that the students are encouraged to participate in the physical education class. So moving on to my topic, the hurdles and the lessons learned. I think we have a lot of hurdles and we are learning the lessons daily. So the background, I think there is no background to the COVID hurdles, that it was all of a sudden that we had, it was just a bang on our head and we came across, oh shit, we are in the mess and we are facing the COVID now. So the healthcare machinery and everything was like compromised during that phase. The knowledge, judgment and decision of healthcare personnel was challenged every time and at every task during the COVID-19 pandemic. There were no randomized protocols. There was no kit, no previous literature, and nothing to get a reference out of it. And it crippled not only the Indian healthcare, but the entire world. So when we started, there were no diagnostic kits, there were no protocols for quarantine, treatment, and the isolation, the self-protection mechanisms like PPE kits, masks, respirators, all were evolving. And then came the vaccine and evolution of vaccine and the types of vaccine. So we started in a very chaotic state, and now we seem to be more confident in handling the COVID situation. So there were many hurdles to begin with. The human resource, the physicians, clinicians, and I think every person in the healthcare system was clueless about what is going on. There were a lot of multitasking. People were involved in all sort of tasks that could be engaged in. The global health became even more complex due to result of technological, social, political, and environmental developments and the practicalities according to the geographical areas. And there was significant shortage of skilled human capital because the disease was new and nobody was actually aware what next to be done. And there was always a debate on public versus private healthcare. The public was dealing with masses, while the private was providing the quality and exclusive healthcare services. So when it started and things evolved, there were a lot of fault identification. मेरा टाइम लिमिटेड है, मत कंफ्यूज करो. So the fault identification process started. There were a lot of blame games, and the faults were largely identified and highlighted by negative media reports, individual perceptions, public trials, social media judgments, and disputes between different individual systems and agencies. Everybody had their own opinion, and like everybody wanted, like, my opinion or my judgment is correct and the other person is doing wrong. So everybody was evolving and nobody was perfect in their evaluation. The infection rate and disease spread was too high. WHO declared it as a pandemic, and India was in complete lockdown from midnight of 24th March 2020. So then came the paradox. The doctors were suddenly made the torch bearers. With the declaration of coronavirus, the government, the public enthusiast, medical and paramedical healthcare workers, and identified them as corona warriors. It did help. Motivations and shoring of flowers and doctors and personnel being designated corona warriors was successful, but the actual hurdle was about to come. The reality was warriors were concerned with the enemy. It and the preparedness, preventive medicine, protective shields, there was nothing standardized and expensive confirmatory tests were there. So the declaration of pandemic overthrew the already burdened healthcare system, which was already burdened. There was two types of forces that were actually working. The first was a frontline workers or corona warriors, like the clinicians, the intensivists, and the healthcare workers. And there were backhand workers as well, the backstage performers, the molecular laboratories and trained manpower to conduct the tests. Costs, apart from technicalities, validation, performance, and end results required expert interpretation and medical acceptance. And since then, the thing suddenly turned hostile for everyone. The healthcare person were also taking severe blows, not in the relation of taking care of the patients, but in their individual lives as well. The family relationships and mental health. Different societal attributes such as avoidance, home confinement, stress, work-life balance, and increased expenses were experienced. And the final blow of the punch. The rising medicine prices and other healthcare costs have always been a concern. There were Indian population mainly is like devoid of health insurance and access to all the exclusive healthcare. The coronavirus pandemic has increased the scale of healthcare cost. And there were limited supply of safety equipments initially, PPE, N95 masks and sanitizers. There were infrastructure limitations and difficulty in addressing patient concerns, not only for COVID patients, but for non-COVID as well. So how to stabilize the things? So any discussion on healthcare remodeling or delivery must include the workforce. What we observed during this phase was a lot of non-medicine non-medical persons with non-medicine background were involved in media briefing, delivering the protocols and forwarding the literature and everything. So there has to be a synchrony whenever there is a medical condition around. So it is essential for administrative managers and top management to identify trained and skilled manpower, ensure equitable deployment and work motivation and morale of healthcare workers for promoting a holistic healthcare system. In practice, whenever this doesn't happen, there is a gap that is often perceived as managerial incompetency and ineffectiveness. So to summarize the hurdles that we all face during this phase, it can be mainly categorized in three categories: the most salient, the moderately salient, and the less salient ones. So the most salient ones that we all faced were shortage of equipments, infection control preparedness, resource allocation, perceived managerial ineffectiveness, inconsistent guidelines, facility layout challenges, training activities, and perceived occupational stress. Less salient ones could be managed easily and were actually managed well. So the lessons for health planners: public and private partnership should be equal stakeholders in long term. Both have to come forward and participate, or there should be a real division of work in both the situations. Treatment regime, diagnostic protocols, and waste disposal guidelines should be worked upon and followed. Leading agencies of the country such as ICMR, NIV, AI, HPH, and other reputed institutes should be consulted for technical leads. Resource management allocation, dynamic administrative measures, and a will to go an extra mile can ensure better combative management. So how to remove these hurdles? There has to be a financial support and sustainability, adaptive resilience in a frequently changing environment, infection risk mitigation for healthcare providers, and the preparedness for healthcare facility. This is a copy from CDC guidelines. The 10 ways healthcare systems can operate effectively. And these are mainly categorized in 5 headings. I'm not going to read out these. These can be related to the healthcare personnel first, the safety of patients second, the communication methods, the data interpretation, and the strategies to communicate. Thank you so much. I think I stuck to time, Dhananjay sir.
Gagan, I really can't thank you enough because unfortunately the speaker who was scheduled to deliver this talk earlier, he backed out at the last moment because of some issues. And I requested Gagan Srivastava, it was last night rather, that Gagan, you have to fill up for this particular slot, and the guy did this beautifully. Thank you so much, Gagan. I'm really thankful to you. Now about this particular talk, I would like to take some input from Dr. Neera Bharyok. Neera.
I am Neera Bharyok. I am an additional district and sessions judge. Nowadays, I am posted in DDA as chief legal advisor. And I have been hearing the doctors, and I also got a chance to hear Ma'am Kushwaha. She has probably left. The only thing I can say is that I wish healthcare was also like COVID. It could reach out everybody indiscriminately, regardless of their age, sex, creed, economic status. And probably one thing which is missing from all the lectures I heard so far is that there is no focus on paramedics. They should be treated with respect, and they should be also sensitized. They should be sensitized to the extent that they should not discriminate between haves and have-nots. That's it. I think that is a lesson probably we all need to learn. They have a different way of treating haves and have-nots. And that is probably the reason that the have-nots shy away from hospitals and medical facilities, and they rather opt for quacks and pahalwans and whatever. Thank you.
Thank you so much. Another last input would like to have from Astri about the education part. Dr. Meenakshi Kushwaha has left, but since Astri has also been involved with the teaching part, so I think her input is also going to be very important.
I'd like to talk a little bit about the have-nots as well. I was, during the pandemic, I was working remotely in a village, and I taught diplomats going through all the different digital platforms. At the same time, I noticed that the children in the neighborhood, who were the children of plumbers and carpenters and maids, that they were cycling from 7 in the morning till 7 at night. And so I asked them, so when are your classes and what are you doing about schooling? And they said, nahi, humko wo message aata hai, phone pe WhatsApp. So there were 6, 7 children sharing one phone, and they were of course helping each other. Now I decided to teach them, and I had classes with children from 6 to 12 years old. And the 6-year-old had of course never had the opportunity to start school because the pandemic came and she didn't start her class. And so they would get these WhatsApp messages. And so I would say, can you read? Reading skills totally disappeared. Whatever the children had learned earlier, they'd forgotten. And my students would point, they would be reading a text, they're pointing at one word, but they're saying something totally different because the teacher has read the text up for them, sent it as a WhatsApp message, and they've learned it by heart, but then they're pointing at different words. So they weren't reading the text. So they didn't know how to sit quietly in a class because they haven't sat in a classroom for a year, been cycling around all day long. All of these challenges, I mean, as the first speaker said, 42% did not have access to internet, and they were working out of this. So we have to think about it when we think about patients as well as students. You know, teleconsulting is there when you have internet, when you have the access. But of course, everybody has become more tech savvy in some ways. And but if you think about villages where the ANC doesn't come very frequently, or you know, what do people do? Most of us got used to not going to the doctor. You have an accident, you fall down. What do? You just sit at home. Same thing goes for parents. But kids, you know, if they manage, they manage. Otherwise, they say, "Acha, ye saal barbad ho gaya. हमारे बच्चों ने कुछ नहीं सीखा." Thank you.
Thank you so much, Astri. So with this, we end this session. I request all the panelists to stay back for the lunch. Please, no one should go away without having their lunch. And the next is going to be the inaugural session. And yes, do remember to take your memento also, because taking them back is going to be a tough task for us. Now, the next session is going to be the inaugural session. I'm going to invite all the speakers as the panelists itself. The first one to start is the inaugural address is going to be by Dr. Lalit Mani. No, not now. Later. We'll try to finish it off within half an hour. May I also invite Dr. Hitesh Lal, Secretary, Delhi Orthopaedic Association, Dr. Rajesh Malhotra, Director, HOD, Orthopedics. He is the ex-DOA President, ex-IUA President. Dr. Arun Gupta, the President of DMC, is on the way. He should be joining us shortly. The rest, two of the members, they have sent their message on video. I think we should be able to wind it up before time.
अच्छा ऐसे चलने पीपीटी हाँ तो इसमें आगे कैसे होगा इससे आरो से होगा उसी से किया ठीक है चलने तो अच्छा है ठीक है thanks Dr. Dhananjay Gupta and thanks the organizers for taking up this theme and welcome Dr. Rajesh Malhotra and Dr. Hitesh, dignitaries of the dais, friends, ladies and gentlemen. So we have a target of finishing in 30 minutes. So I've been asked to talk about overview of musculoskeletal disabilities and Dr. Malhotra's and Hitesh's heart, because we all practice orthopedics, and this is one of the core disability that we're trying to prevent. There would be a lot of definitions of disability if you go through literature, and this one I thought is very relevant. It's an impairment of body functions, body structure, limited activity, and restricted participation, which may be associated with common or burdensome musculoskeletal conditions. So if you need to understand it in a more practical way, if you can call accident as a disease and it leads to loss of a foot, which is an impairment, and then you cannot walk, which becomes a disability, and it leads to an handicap, that is you're unemployed now. So if interventions can happen at any level, at disease, impairment, disability, and handicap, and as you can see, the consequences would be similar. So as prevention is always better than cure, if we start at the time of disease or even before that. Let me just bring out this one metric, which is a standard metric used to measure the overall burden of disease. It could be for any disease. Since we are talking about musculoskeletal disabilities, it is about the disability adjusted life years. So it takes into account both the life lost, which is YLL, and YLD, which is a loss due to disabilities, the years you lose due to disability. So combined, we come to the disability adjusted life years, and this is normally applied to any disease when we are looking at policy making and healthcare assessment. So as I had mentioned, where do we intervene? And depending upon that, the prevention could be primary, secondary, or tertiary. Like for polio, reducing the occurrence of polio itself by giving immunization. And we've actually managed to eradicate polio from our country. And polio used to be a base for training in the residency programs in which we used to teach muscle evaluation and how to address disabilities. And now we only have adult disabled polio since the disease has disappeared. Similarly, secondary disability limitation by appropriate treatment. Once it has already occurred, you try to manage that. And the tertiary one, preventing the transition of disability into an handicap, meaning although the disability is there, you can still work around it and prevent a handicap. The example which I used, prevent an unemployed person. So musculoskeletal disorders would come in at all the ages of life from birth to death, and they would come in probably all forms, from arthritis to conditions of the spine, to inflammatory pathologies, to osteoporosis, to tumors, to injuries. So they would be affecting in different forms, and they would be affecting all the age groups, not being specific to any one age group. That brings the importance of the urgency of addressing this problem. And why do these disorders matter? Because they bring pain, limitation, and debility, affect all ages, and have a ripple effect across all ages, meaning that it will not only affect that particular person, it affects the family and society at large. And then it brings in a lot of cost to the society, because this is one situation which is going to bring in a lot of loss of years due to disability. It might not be loss of life, but then surely disability. So we've been listening since morning, billions and millions. So the magnitude of the problem is large, and we need to understand, as Dr. Anil Kumar had presented, that any program, whether it is small or large, it takes time to assess and then implement it. So we need to wake up to this and start working on it. Let's take you through a few examples of specifics. Now, this is just published last year and talks about the major contributions to years lived with disabilities. And if you can see, it is not a specific country-specific thing. It's spread all around. And backache is one of the major issues as far as musculoskeletal conditions is concerned, and neck pain and knee pain do follow them. This is an interesting graph, slightly crowded, but if you look at the increase in the global disability over 2 decades, there is a definite increase in the incidence of MSK disabilities. However, interestingly, if you look at developing countries and developed countries, the difference is glaring. In the developing countries, the increase of disability is 60%, and in the developed countries, it is 20%. That means they are awake to the phenomena and they are already working on it. And we are still probably at the initial phase of assessment that musculoskeletal disabilities are pretty large. So they form a pretty large circle if you look at the circle of non-communicable diseases, and that's why it's a large volume. And backache per year would amount to maybe 500 millions over the globe, and that's the magnitude. This is an interesting box in which you can very easily compare the years lived with disability. Should I cross this? Huh? Sorry. So should I minimize it? Yeah, I'll do that. Yeah. Okay. Is that fine now? I've done it. Okay. So you can see the dark blue is the musculoskeletal, and it goes to almost 140 million, which is almost double to diabetes, urogenital, blood, and endocrine. And it is almost comparable to other non-communicable diseases. So this is the years lost living with disability, and that's where musculoskeletal disability is very important, affecting the quality of life. So how does this move forward now? Neeraj, it's not moving forward. Okay, click that. Okay, great. Do that. Yeah. So some more diagrams before we wind up. If you look at the top circle, it talks about injuries in the past 2 decades, and they have almost stabilized as far as the disability adjusted for life. But if you look at communicable diseases, they again are being taken care of. However, the non-communicable diseases are definitely on the rise. And specifically MSK, the circle is also widening as well as becoming thickened. And the conditions which were mentioned in the earlier part are continuing to grow. I would recommend this excellent article published in Lancet, which talks about global burden of 369 diseases and injuries in 204 countries and territories over almost 3 decades. And the interpretation is very, very interesting, which says that as disability becomes an increasingly large component of disease burden and a large component of health expenditure, greater research and development investment is needed to identify new, more effective intervention strategies. So we need research, we need investment, and we need strategies. With a rapidly aging global population, the demands on health services to deal with disabling outcomes, which increase with age, will require policymakers to anticipate these changes. So we need to start working on musculoskeletal disability. That's why there is the need to be aggressive on it. Same has come out on another article in Lancet, which talks about global estimates of the need for rehabilitation. And it talks about the volumes of the problem to awaken the health policymakers to work on it. And this is a screenshot from WHO, which says that the YLD for MSK is almost 70% at this point of time. So why it needs to be tackled aggressively? It's rapidly increasing and it's going to continue the same way in the next decades. So better wake up. Limitations due to musculoskeletal disease. Let's go just to the last line. It's twice the rate of circulatory disorders. And limitation due to specific MSK diseases. For all musculoskeletal diseases, the rate of limitation increases sharply as the population ages. And in the first 2 lectures in the morning, we have looked at this point that our population is aging now. Bed days, that is a bed days, half or more days in bed due to injury or illness in a 12-month period. 72% of them had a bed day due to musculoskeletal condition. So 1 out of 4 adults will have it. So just trying to highlight that it's a sleeping giant, the musculoskeletal disabilities, and we need to wake up to this problem. It has a widespread prevalence throughout ages. The 3 most costly healthcare conditions, trauma, back pain, and arthritis, and low mortality from musculoskeletal diseases. So the mortality might not be high, but it's going to cause life with disability. And definitely the cost, the direct, the indirect, the aggregate, and the incremental, it's attached with this. And that's where WHO is now working on Rehabilitation 2030, and it has a very detailed call for action directing towards musculoskeletal disability. And what they have highlighted is that the call for rehabilitation is actually going to give us the data more specific on disability itself. So the rehabilitation initiatives itself was going to take us closer to what is the magnitude of the problem. And it's going to be more community-based, as we had discussed in the morning also. It's going to become multi-sectoral, and it's going to bring in a lot of initiatives and trying to give a more holistic outcome to rehabilitation in musculoskeletal disabilities. So finally, I think re-emphasizing that for any healthcare problem, we follow this circle of planning in which we need to assess, prioritize, plan, implement, and then again assess. Today, what we are doing, sitting here together, we are trying to assess at an organizational level, which is at the center of the circle. And when we emphasize this, this goes out into the community, it becomes a problem which is identified by the community. We are grateful that we have people from Government of India who are already working on these lines. And as data gets collected through various surveys and literature search, we end up telling the government that it is a priority, and that is where the plan is implemented, and we again keep assessing it. So time has a wonderful way of showing us what really matters, and no better than this COVID era, which has really shaken us up. And one thing it has taught everybody, whether on street or on the podium, is that data is very important and we need to respect it and then get sense out of it and work on it, because response time matters. The program for the elderly is been there for 10 years, but then ground level implementation comes in slowly. So response time matters. So finally, I would say musculoskeletal disabilities need to be tackled aggressively, and thank you very much for patient listening.
Thanks, Professor Mani. I think, yes, we are looking forward to a situation where we should be able to diagnose this early and take appropriate action to prevent the disability. The next talk is going to be by Professor Hitesh Lal, Secretary of Delhi Orthopaedic Association. Dear friend, I think it started in 2012. With the efforts of Indian Orthopaedic Association, 4th August was declared as National Bone and Joint Day. Since then, since 2012, Indian Orthopaedic Association comes up with a slogan, runs a campaign, and ensures the participation of all the orthopedic surgeons of India in some social event contributing upliftment and better care of the society at large. So Hitesh Lal will be speaking on that particular issue.
At the outset, I would like to thank the organizer for inviting me, and I'll be telling what Delhi Orthopaedics Association and Indian Orthopaedic Association has done in elevating the disability in the society and creating health education. So I'll be talking a little bit about the genesis of the Bone and Joint Day. The international community declared 2000 to 2010 as the Bone and Joint Decade by the WHO. It was primarily to raise awareness on the impact of bone and joint conditions, what disability they cause, and the pain they cause to the patient, and to raise global funding for research on cost-effective prevention and treatment of musculoskeletal problems. Indian Orthopaedic Association on 4th August 2012 requested the Ministry of Health to observe 4th August as a Bone and Joint Day. And this was the same day on which the IAOC Charter was signed in 1971. And 4th August every year is celebrated as a Bone and Joint Day. This was essential because problems like arthritis and osteoporosis among the aging population are becoming a major cause of disability. And more than 2 million fresh cases with debilitating arthritis all over back pain are added every year. However, it is the accidents which are the major killer, and almost 1.2 lakh, and the recent census which shows 1.5 lakh are killed due to accidents, and 4.5 lakh have injuries according to recent census in 2019. And these are the injuries which lead to disability and cause a huge strain on economic and social fabric of the family and society at large. So the purpose of this was that it was decided that Indian Orthopaedic Association should go to give back to society. And it was decided that every IOA member should conduct at least one operation free of charge before August 4th. So Indian Orthopaedic Association has a social responsibility has a bone care responsibility of the society, and it does by health education and as a preventive and a therapeutic aspect to it. And by therapeutic aspect, it innovates treatment and develops cost-effective treatments, and it coordinates with users and givers, the government, the secretaries, the police, the traffic, and corporations to spread health education in the society at large. Seeing the importance of this, the IAOC went further and declared August 1 to 7, which has to be celebrated as a bone and joint week. So from a day, it went on to become a bone and joint week. So August 1 to 7 is celebrated as a bone and joint week by the Indian Orthopaedic Association and all its state chapters. Each year, a special theme is chosen by the president of the IAOC, which is common and a universal suitable health problem which can be prevented or reduced by education, media, and simple communication maneuvers. And the IAOC, which has got a central state research council, it evolves strategies to improve the current state of medical and social awareness. The clinical problems are highlighted by the distributing posters, applying vehicle stickers, press releases, and doing school education. And first of all, the health professionals needs to be enthused and to generate interest among them. The recreation, walk, marathon, and are done amongst the health professionals and officials worldwide to develop a concrete strategy to solve it. And funds are generated to research on cost-effective preventive and corrective strategies, and free surgeries are done. So I will describe my journey as an honorary secretary of Delhi Orthopaedic Association and how this journey from 2019 to 2021 and during the COVID era has made a lot of difference to the society. So first is our president on the dais. First was in 2019. The president theme was healthy aging with strong bones. We make this theme in 2 languages, which are in any language which is prevalent in India. The Hindi was Dirghayu Ka Shakti Mantra Asthio Rahe Sasakt Samarth. So we met the Delhi Orthopaedic Association Executive Committee meets. They are seen doing exercises in Lodi Colony. They developed a plan. And this was a plan. It was planned to do free surgeries, hold free bone mineral density camps, do an health education program or campaign to general public, college, and school students. And this was to be executed through distribution of pamphlets, rallies, highlighting the healthy aging and strong bones, media coverage, and any other unique programs. Language also, निशुल्क सर्जरी, निशुल्क BMD शिविर, आम जनता, कॉलेज और स्कूल के छात्रों के लिए स्वस्थ शिक्षा कार्यक्रम, पर्चे बांटना, स्वस्थ आयु वृद्धि और मजबूत हड्डियों पर प्रकाश डालने के लिए रैलियां, मीडिया कवरेज, कोई अन्य अद्वितीय कार्यक्रम. So the Central State and Research Council sits down and chalks out some easy to do maneuvers which should be practiced to do this. The theme had 2 parts: healthy aging and tips for strong bones. For healthy aging, healthy balanced diet, maintain ideal body weight, walk at least 10 minutes a day, do simple exercises, do yoga, avoid falls, avoid slippery falls, adequate lighting, and avoid misuse and overuse of joint. For strong bones, healthy mother and healthy child, dietary calcium, take balanced diet. So these posters are distributed into the society, at the clinics and everywhere to impart health education at large. At clinics, all Delhi Orthopaedic Association members put up these posters and educate the public on these aspects. And we believe that the education should start early. So school education is a major part of our campaign. And because the school children can educate the elderly also, and as child is the father of man, so we impart school education in a big way. So we tie up with schools and impart education. Our members go there and educate them regarding balanced diets, yoga, maintaining ideal body weight, exercises, and other things. And for the tips of strong bones, we emphasize on the healthy diet, sunlight exposure, maintain high bone density, and a healthy mother. Besides this, we do a good media coverage also. On this, Dr. Dhananjay was the president, and we requested the Prime Minister to include all senior citizens in the Ayushman Bharat scheme, which was very well noted by the Prime Minister and conveyed to us. And next we come to 2020, and 2020 was a very apt topic. Our topic was prevention of deformity in degenerative diseases. This was very apt due to in COVID pandemic, as most of the people are homebound with sluggish activities and decrease in BMI. And they've also got altered sleep timing because of more of screen time with bad posture, leading to more backache and minimal sunlight exposure. So during this also we chalked strategy, the CSRC cell of the IAOC chalk strategy, it was decided to hold virtual health education lectures this time at this was the COVID era, distribution of pamphlets, display of poster, radio and TV coverage, print media coverage, social media coverage. So besides emphasizing on strong bones, these activities were required, that is to prevent malalignment of legs, avoid overuse and misuse of legs, and avoid injury during sports and improve muscle strength. The highlight was that on this day, Honorable Union Minister of Health and Family Welfare also gave a written message to the IOA and DOA to congratulate them on the 4th August. Besides this, we hold CME for the health workers, train them and educate them on the different topics. We also engaged with Rotary Club during this time, and it had an eminent panel which discussed prevention of deformity in degenerative disease, and its myths and social stigma were dispelled away. Besides this, we hold a public lectures, which was preventing arthritis in COVID pandemic, managing your back, and eating right to prevent arthritis. And this drew 3,000 participants on the Zoom platform. The press releases were also done during this period. And all members educate the public in their clinics and put up posters. Besides, there was Zoom clinics held with the RWAs and educating on this theme also. The next is a recent year. Dr. Lalit Mani was the president who is on the dais, and this time the theme was Save Self and Save One. So the mission was to create 1 lakh life saviors, as we think that the first hour of trauma is a golden hour and it should not be missed. And basic life-saving training was given to students, youngsters, policemen, and common man, and spreading awareness about healthy bone. So this is the executive team of the Delhi Orthopaedic Association. They meet on the first day, do a walkathon, and media coverage given on the radio, TV, and the print media. And the first was a CME on knee disorders. Then we held public lectures in different institutes highlighting the disability caused by osteoarthritis, osteoporosis, and how to do some lifestyle changes and their treatment. Besides this, we thought that after the second wave, our health workers were very mentally exhausted and they need some mental recuperation. So we invited Divine Sister Shivani, and she gave a talk on work-life balance. As we believe that if the health giver is not healthy, he will not impart good health to the patient also. Besides this, we had a beyond professional life. We had a talk by Dr. Mohit Gupta. He gave on 8 transformations that will change your life, and also about the spiritual and financial health during this period. Besides this, we have had a poster exhibition. This was done at RML hospitals, where deformities due to vitamin D deficiency, due to arthritis, due to osteoarthritis, childhood deformities like congenital deformities like clubfoot were displayed, and BMD camps were held. Besides this was an important part where the telecast live on school networks, both of NDMC and Delhi government, and 2,35,000 students were trained in the basic life support maneuvers. And this was a big task, and this was done by Delhi Orthopaedic Association. And beside this was a PowerPoint which is prepared by the CSRC and taught by the member associations. Besides this, we also did a plantation drive. As we see, a planting a tree gives food, shelter to 100 others. And this was 50 trees were planted in the New Delhi area in collaboration with the NDMC. And BLS training, basic life support training, was done at different colleges. The council, Delhi Medical Council was involved, and the school students were also involved. Besides this, we had a recreational evening for our association. So these are not like this. We are audited as an association about what we have done during Bone and Joint Week. We are assessed and points are given based on this. And our father, the Indian Orthopaedic Association assesses on this. And in this 2021, we were just the second best state who has celebrated the Bone and Joint Day in India, which a large group means more than 1,000 members. Besides this, the 2018 was a very good Bone and Joint Day. I will be briefly describing on this. The theme was road safety is everyone's responsibility. And in this, we collaborated with Joint Commissioner of Traffic Police of Delhi and they worked out this chart. This was very easy to do activities. And we distributed this to the common man, like wearing helmet, wearing seat belt, wearing, don't use mobile camera, mobile phones, respecting signs and lights and not. And this was a slogan we did, विकलांगता, विकृति और मृत्यु के से बचने के लिए हम अभी एक कसम लेंगे, हम सड़क सुरक्षा नियमों का पालन करेंगे, हम घर पे एक पुलिसकर्मी होंगे, दूसरों की ओर सड़क सुरक्षा नियमों का पालन करने के लिए आग्रह करेंगे. And these were the media clip which a conference or CME was done on trauma care where many health educators were trained and the local authorities were also involved. So in 2016, the main slogan was one member, one free surgery. And in this, we made a world record. Indian Orthopaedic Association made a world record of doing the maximum free surgeries in the world. And 2013 was a stronger bones lead to stronger India. And there was a need to develop optimum bone health and optimum orthopedic care and optimum hospital plan in the country. Thank you. So we as a daily orthopedician train school children, train health workers, and while observing the National Bone and Joint Day. Thank you.
Thank you, Desh. That was something, you cannot get from the net, you have to make the presentation by collecting all the pictures, all the data. That was fabulous, very hard work. I really appreciate you have been a very hardworking man. Thank you so much. Now, another one of the very important topics, which has been in the mind of a lot of people, and somehow the computer, the robot, people feel that this is the end point of all the surgeries, all the advancement, technology. The moment they hear that the robot is going to be the surgery, they feel so thrilled, they feel that this is the ultimate. So let's hear Dr. Rajesh Malhotra, what he has to say, what the literature says, what he says about this particular issue.
Good afternoon. Thank you, Dr. Dhananjay. With lunch, it may be easier for you to swallow the information I give you and maybe digest it. I hope it doesn't do anything bad to your appetite. I'm going to talk about robotics in surgery and what does it translate into when you eliminate human error and what are the advantages. So technology is here to stay. And basically technology has come around because we have always had the quest to improve, and that is what has brought a revolution. So we used to pass the pedicle screws in the spine freehand, then we started C-arm navigation, then O-arm navigation, and then we graduated to robotic guided spine surgery. This is something which went viral recently. This is a robotic kitchen. So you can just program, it can cook for you, it can do everything. I've got a feeling that it's going to be very popular with the husbands because it cleans up the kitchen and does the dishes also once the cooking is done. So that's the kind of impact it is going to have. This is our in-house robot made in AIMS at the beginning of the COVID pandemic in April 2020. It costed just 5,000 rupees. We made something which could go inside the ICU and take samples inside. It had a mobile phone mounted on it, so you could talk to people in ICU, to the doctors and to the patients, all managed remotely. Just giving a glimpse of what happens. The use of robot in COVID has been established and a lot of work was done, including the sanitization of the infected areas and walls. There have been robot nurses, there have been robot receptionists, there have been robot ambulances, even the drones carrying the AED to the patient or the first aid thing. There have been the rehabilitation devices, the sanitization services. We have a lab which is now robotic in AIMS, and then also we are in the process of acquiring a hybrid OT which will have a robotic angiography arm. So it's everywhere. Must differentiate between robot and cobot. Robot is actually fully automatic, whereas a cobot has got a human interface. The human is assisted by the robot. So what is the promise of this new technology? It is to save lives, improve access to information, increase productivity, reduce errors, and improve the quality of life. So this is something very interesting. It's called Scott's parabola. So Scott's parabola is whenever a new technology comes, people are, suspicious about it. They say, okay, maybe it's good for research purposes. Then it starts becoming popular. Then people start looking at indications. Then there's a media hype. Then people want to use it in everything. And then it starts coming down when people start getting the complications, and then the negative media publicity, litigation, and then comes back. And at some stage, there are these nurses in the operation theater wondering what to do with all the junk which is lying in the operation theater, is not of use anymore. So a caution was made about this Scott's parabola whenever there's a new technology. And this is a classical example. The ASR, or the large head metal on metal, all of us have gone through that scourge when there's a large scale failure, when it was touted as one of the best inventions. So let's talk about the history of the robot. The first documented use was in 1985. So first robot was non-endoscopic use. It was called Puma 560. It was used for a biopsy. And then the laparoscopic robots became popular. And then in 1985, there was the first robotic cholecystectomy, and then followed by the transurethral resection. Then came the AESOP, which was the first FDA-approved robot for endoscopic surgical procedures. So on top is the first generation, which was in 90s. They were fully automatic robots. The second row below is the second generation, where there was a human interface. The human was being assisted by these robots. Then came the Da Vinci system. It had 3D magnifier capability. It had 1 centimeter diameter arms which could work. And they reduced the risk of infection because of the minimal infection. And there was something called an endo wrist. So sometimes with the robot, you can even reach the areas which are possible to reach, not possible to reach even when you do an open surgery. So robots today can be, the programmed and autonomous like the RoboDoc, or the telerobotics like Da Vinci, or they can be collaborative where there is a interaction between the human being and the robot, which are like Mako and Globus Excellius, which is what we have in All India Institute of Medical Sciences. The tracking systems can be electro-optical or electromagnetic. The electro-opticals work very well close to the metal implants, which is a problem with the electromagnetic. But the electro-opticals are very bulky and have line of sight issues which are not there with the electromagnetic. What's the difference between robot and navigation? Now, whenever we are operating, say, for example, spine, the radiation from the pre-op CT, intraoperative CT remains a concern. And robot-guided instrumentation, one of the advantages, it reduces intraoperative radiation. Who needs the computer assistance? Now, it all depends on surgeon experience, surgical technique, case type, room size, radiology technician experience, and the ratio of navigation system to the total number of cases. So the robots in surgery have the potential to improve precision, facilitate minimally invasive surgery, require fewer workflow steps, and reduce surgeon fatigue, and reduce the ionizing radiation. We have been concerned about these factors in the conventional instruments when we are doing knee replacement, about the errors when bone cutting or the excursion of saw blade causing injury to the soft tissues. And then we have this system in NHS called Getting It Right First Time, which looks at every technology to see whether it's useful or not. The use of robotics and its literature is on the rise. This is an indication of the number of publications which you find on the PubMed on the robotics in orthopedics. So they are why, what, and how of robotics, robotics in trauma and orthopedics, and there are robotics for every part of the body as far as orthopedics is concerned. One of our own paper on robotic spine surgery talking about the potential. There have been robotic surgery papers on hip and knee arthroplasty. Now, this is a great use of robot, which is basically the training. So 16 inexperienced surgeons were randomized to perform 3 UK over a period of 3 weeks, 1 unicondylar knee replacement every week. So half of them did the robotic, half of them did without robotic, and the implant positioning was better there. So it's a great training tool. More about it soon. Another example of improved implant position and lower revision rates when you use unicondylar knee replacement assisted by robot. Another paper which showed decreased incidence of soft tissue, bone injury and other complications, and improved accuracy of implant alignment and even better gait. Now, robot-assisted knee arthroplasty coming on from the partial to the total knee replacement, better component positioning, but then the catch is in the last line. There's no conclusive evidence that this better positioning translates into the better patient outcome, and that's what has to be kept in mind. Another paper on the knee replacement, fewer complications, increased surgical time, but results, every other parameter was same. Now, another paper on systemic review and meta-analysis, better component positioning. So there's no doubt that robot has got benefits in terms of training. I'll talk a little more about that just now, and component positioning, but we still don't know whether it improves the outcome. This is a paper we published in 2015 in JBJ's American, where we showed that the navigated total knee gives rise to less of systemic emboli. The same has been shown with the robot. So the robot is able to reduce the embolic load on the patient because of the femoral milling technique. It also causes less stress shielding in hip replacement, of an effect which is seen even at the 10 years when the same cohort is followed up. And this is about the spine surgery, freehand pedicle screw versus the robot assisted, and there were fewer facet joint violations and better screw orientation with the robot. Another paper on robot assisted spine surgery, high precision rate of screw placement. So in spine, it means not only higher precision, but also lower risk and less risk of injury. Now, freehand cannulated versus robotic assisted fracture neck femur, where they looked at the screw parallelism and the amount of radiation. There was significant difference when the surgery was done assisted by robot. So there's a trauma pod, which is a semi-automated telerobotic surgical system, which assists in the surgery, and there have been minimally invasive trauma surgeries using this. So is it the rise of the machines or just rise of the cost? This is again a paper where an experienced hip replacement surgeon did surgery and inexperienced surgeons did surgery using robot, and the results were comparable, which means that it is possible to do precise surgery even if you are not very experienced when you are using the robot. So what is the learning curve? The learning curve for total knee replacement has been pitted at 6 to 20 cases, and for UKR it is 6 to 36 cases. So that you have to do that many cases with the robot in order to get proficient with it. There's always the cost argument, and this is a very nice quote by Edison, which said, "We'll make electricity so cheap that only the rich will burn candles." So expense is a problem. $1 million for purchase, at least about $100,000 a year to maintain. So how do you counter that cost of robot? So hospitals and doctors try to do that by decreasing the length of stay, shorter recovery period, but then that may not cover the expense. In this model, it showed that if you do robotic partial knee replacement, you need to do at least 94 cases in a year and have a failure rate below 1.2% to recover the cost. This was another way of healthcare utilization and how the cost can be cut down by using robot. So there was less episode of care cost at 30, 60, and 90 days when robot was used. 90-day readmission was significantly lower. Length of stay was less. Higher rates of discharge. So it depends on your center how much you can recover the cost of robot in terms of these. So it was discussed whether it is worthwhile to put a robot in the public healthcare system, and it was decided that, you know, if you do navigated or robotic knee replacement, the cost is the same. But then when you add the cost of robot and the cost of maintenance, it's way high. So running cost is not different, but it's the overall cost which becomes more formidable. A quick word about types of robots you should know because it's a talk on robot, the various features which you look for, open versus closed, image versus imageless, the approach, active or passive or semi-active, and compatibility. So you have an open robot, you can use any type of system with that. The advantage is that there's a loss of functionality and specificity. There are no specific instruments to use with that. So there is some compromise of functionality and specificity. In a closed system, it's everything meant for a particular system to do. So there's a loss of patient preference. Image, one will acquire all the images before surgery using radiation. So there's increased cost and increased radiation. Imageless will be done during the surgery in the operation theater. But then there's a system called ROSA by Zimmer, which comes in both the versions, image versus imageless. Other type is active. Active is when the robot performs the entire surgery. The passive is when after registration, the surgeon will perform everything. And the semi-active is when you get these are called haptic robots, where the surgeon gets the feel, even if it is drilling. And if he tries to sort of overshoot the perimeter or the safety ring, it will be interrupted by the robot. Now, this is just an example of comparison of some of the orthopedic robots when it comes to doing the joint replacement. And at this point of time, you'll see the Miko robot, which is actually most comprehensive, but has one disadvantage that it is image based. So it involves more radiation and it's more expensive. There are other systems which are comparable. There's a few slides about the spine surgery. These are the instrumentations for the robotic spine surgery. These are some of the pictures from our own operation theater. You have the intraoperative CT fixture and you have the dynamic reference base array, which is here. So what you do is you use this O-arm, take a O-arm spin, and then the DRB remains in place, but the ICT fixture is taken out. And then you plan the trajectory of the screw, and then there's something called an end effector, which is a rigid robotic arm through which the instruments go. So you could actually do it blindfolded because the robot is now going to guide you right to the exact track which I planned, and this is how it will look. And it keeps on showing which all screws, which level screws you have put in. It is showing here the pink ones are done, the greens ones are planned. It will show you the diameter of the screw, the length of the screw. And so these are the various advantages of the robot, the shorter, the smaller scar, the shorter hospital stay, the less complications, etc., etc. And in a comparison now, its technology looks very attractive and very lucrative, but then the robotics improve accuracy, but surgical time is increased, inventory is increased, capital expenditure is increased, recurring cost is increased, and learning curve is very high. And all this with the background that we don't know for sure whether the functional results are improved or not. When you start using a robot, this is what Napoleon said, don't wait, time will never be just right. And this interesting paper from Sebastian Parrott, who's actually going to be in our faculty in our conference fortnight from now. He has written that the assistive technologies are here to stay. They are not going to follow the Scott parabola. And in the support of his argument, he shows the Australian and Norwegian registry, which shows an increase in publication, increase in use, and he says the improvement in accuracy and possibly improved functional outcome will make sure that this will not turn out to be one of the Scott's parabola examples. So for and against the robot, the benefits are there's increased precision, it's a physical assist, it's the procedures reduce the risk of death, complication, and hospital stay, as an enhanced 3D high definition visualization, and there are key benefits to the patient like reduced trauma, less risk of infection, and faster recovery. On the downside is the cost, removal of physical contact, increased duration of surgery, increased learning curve, the size of actual equipment takes a lot of space, and all the operating instruments may not be compatible with the technology required. So to take home messages, it's a unique dilemma for this at this point of time. It does not make a difference in it does make a difference in terms of accuracy and implant positioning, but there is a loss of tactile sensation, clinical outcome, and survivorship need further data. But then if I were to ask you which cycle would you recommend for weight loss, and if money is not a problem, the answer is actually a given. And other thing which is often quoted is once a new technology rolls over you, if you are not a part of the steamroller, you will be the part of the road. And I'll end by inviting you all to the current concepts in arthroplasty 2021 at the end of this month, where we are going to have a lot of discussion on the technology, including robots. So we have arranged a session of debate where 4 different companies will argue why their robot is better than the other. So I think you will find it enjoyable. I thank you very much for your attention.
Thank you, sir. As usual, I mean, you can definitely write a book on whatever material you present in your paper. Quite enlightening. I'm pretty sure a lot of my doubts have been cleared. Now that the lectures are over, we have 2 video messages coming from our chief guests and guests of honor, so that we can take up. In the meanwhile, let me invite our young, budding, going to be a doctor soon, I mean, joining the medical college, Shambhavi Agrawal. She has written a poem on this particular topic. Let's hear out first. Let's give it a big.
Good afternoon all. I'm Sanvi Agarwal. Thank you for giving me this very good opportunity to speak on such a prestigious platform. I'm not a very expert person when it comes to these medical terminologies, but what all I could inculcate about arthritis in the past few days, I have tried to put that in form of a poem. And the poem is called We Will Get Them Changed. So it's about a old couple and who has got a very bad habit. We can say that whenever they break an organ, they just say that we'll get it changed. So Mr. Gupta got an insurance to get his health assured, got all his pills in abundance, and his future was all secured. When Mr. Gupta turned 60, celebrations were at peak, but at lunchtime he broke a tooth and his jaw became too weak. Seeing this, Mrs. Gupta suddenly began to weep. Who will crack my walnuts now? His teeth have begun to sweep. A brand new pair of dentures for Mr. Gupta was arranged. Don't worry, dear, said Mr. Gupta, we will get them changed. When Mr. Gupta turned 61, celebrations were at a cruise, but as he swam, he broke his hip and the femur became too loose. Seeing this, Mrs. Gupta suddenly began to cry. Who will drive me to the ladies' club? His hip has said goodbye. Listening to this, for Mr. Gupta, a hip bone was arranged. Don't worry, dear, said Mr. Gupta, we will get it changed. When Mr. Gupta turned 62, he dressed in a suit and a bow, but while climbing stairs, he tripped and broke his knee with a blow. Seeing this, Mrs. Gupta suddenly began to complain, who will clean the fans this Diwali? His knees have begun to pain. As always, for Mr. Gupta, a patella was arranged. Don't worry, dear, said Mr. Gupta, we will get it changed. When Mr. Gupta turned 63, we will party grand, he said, but while dancing, he badly fell and cracked his sturdy head. Looking at this, Mrs. Gupta remarked with a frown, who will listen to my gossips now? His head has fallen down. After this, for Mr. Gupta, a cranium was arranged. Don't worry, dear, said Mr. Gupta, we will get it changed. But this time, this change was not an easy bit, because in this new head, his brain would not fit. This time, Mrs. Gupta didn't cry, didn't weep. This time, she had no fear. She smiled and took a breath deep, from where now a new brain, my dear. Insurances are rising on 5th gear. Medicine too is improving for sure. But there is no insurance for happiness. Prevention is always better than cure. Thank you.
When she was speaking about Dr. Gupta, I could see my future there, I'm not going to go on to the cruise, that's for sure. Very well, son. Very well. Sami, wonderful. Great job done. So now we have a small video from Dr. Shiva Shankar, the reigning president of Indian Orthopaedic Association. Sorry. Nimat, can I see that video, please?
Everybody. Greetings from Indian Orthopaedic Association. Congratulations, Dr. Dhananjay Gupta, for arranging this musculoskeletal health and global disability prevention strategies program. Due to my prior commitments, as I am in Bhopal today, I will not be able to attend your meeting in person, and hence I am sending this message. I am glad that on the occasion of Bone and Joint Week, which falls from 12th of October to 19th of October, the first day being celebrated as the Osteoporosis Day and the last day being celebrated as the World Arthritis Day, we have arranged this wonderful program to highlight the musculoskeletal disabilities arising because of various conditions. I have gone through the scientific program, which will cover lectures by eminent speakers of repute in respective fields, covering the latest government programs in healthcare and advancements in medical science. There is definitely a need to relook at the present educational and financial system in the society, as COVID pandemic has definitely shaken the basic structure of our civilized society. And I'm glad that all these issues will be covered during the whole day by experts. My only suggestion is there are many government schemes which pay the same amount to a government setup as well as a private setup. So I request the people who are in the government agencies to look at this, because in a private setup, the owner of the setup has to bear the cost of the salary of the people, the premises charges, taxation, etc. Whereas a government setup will be all owned by the government. So I find it little odd to see that. Treated in a government setup or in a private setup. This is my humble request, and I wish this program conducted by my friend Dr. Dhananjay Gupta from Otis Vasant Kunj all the very best. Thank you for having me here today. Thank you very much.
Thank you, sir. The message carries a lot of great support for us. I really appreciate it. Thank you so much. And I think it was a very pertinent question which was raised by him, that we talk about the public-private participation. And perhaps the government can afford doing the surgeries for a very minimal cost, but to expect the same from the private setup is something which is quite difficult, because they have to maintain certain standards. Now, the last video will be by our chief guest, Dr. Ashutosh Raghuvanshi, MD and CEO of Fortis Healthcare.
Greetings and good afternoon. I thank and congratulate everyone involved in organizing the India Arthritis and Osteoporosis Conclave, which has brought together some of the finest minds to discuss critical issues related to musculoskeletal care. Musculoskeletal disorders are amongst the leading contributors to disability worldwide, especially amongst the elderly. According to the WHO, 9.6% of men and 18% of women aged over 60 years have symptomatic osteoarthritis worldwide. 80% of those with osteoarthritis have limitations in movements, and 25% cannot perform their major daily activities of life. In India, osteoarthritis is a common rheumatological problem with a prevalence of 22% to 39%. Studies also reveal that nearly 45% of women over the age of 65 have symptoms, while 70% above the age of 65 years show radiological evidence of osteoarthritis. Arthritis is a fairly common disease in young patients with heart disease and diabetes, making managing of these conditions all the more difficult. The prevalence of musculoskeletal disease is increasing due to population aging and an increase in related factors such as obesity and sedentary lifestyles. As effective medical management is limited, raising public awareness regarding the preventive aspects, including lifestyle modifications, diet and exercise, is the need of hour. I'm happy to note that this conclave also focuses on various other dimensions of healthcare, especially in the post-COVID world. Personally, these discussions are of great interest and value to me, and I'm sure that the conclave will shed light on the way forward for healthcare administrators and policymakers. I extend my heartiest good wishes to all the delegates and wish you great success. Thank you.
Thank you so much, sir. It was something which we all were looking forward to. Your candid support, and I'm pretty sure we will be able to continue with your able guidance, a wonderful job in the future also. Now I declare the lunch officially open. So we'll have a break of almost 10 minutes. We were supposed to have our next session starting from 2:30. What was the time? Is there anyone left who hasn't had his lunch? So we can wait for 5 minutes, 10 minutes, no issues. Fine, so we'll have a break of 10 minutes then. Thank you so much.
Our next session is about to start, and we are talking about drafting an action plan to combat COVID disease and its aftermath. And in our panel, we have three doctors. Dr. Anmol Maria, who's an orthopedic surgeon. I would request him to come and sit up on the stage. Dr. A.P. Mishra, a senior physician at Fortis, and Dr. Gauri Shankar, who's a director head of critical care services at Fortis. Please do come and join us. The first lecture that we're having is by Dr. Vipul Jain, a pediatrician from Delhi. He'll be talking about staying safe, emerging vaccines and vaccination protocols. Dr. Vipul Jain.
Good afternoon, everyone. May I request the people with the lunch plate to sit on the tables so that we will start this very important session. And we'll be having two topics are being discussed in this session. First topic is about the vaccines, and Dr. Jain is here to clear various doubts, even among the medicos minds about these vaccines. And the second topic, so let me first, so I shall request Dr. Jain to start his deliberations. Light.
Thank you, Dr. Dhananjay, for inviting. And it's, I think, vaccines are being heard is a great thing, great news for me. Before this, I believe everyone believed that vaccine is just a tool for a pediatrician to earn his bread and butter. This pandemic taught us that, yeah, vaccine is probably the cheapest modality to save a human life. I will try my best to answer a few queries that everyone asked me about the vaccine. And I would be open to answer any queries that you have, you wish to ask about the vaccines. So I would be covering the type of vaccines that are there. Everyone asks me which one is good for me. I would like to elaborate on what are vaccines, what all type of vaccines are there, and how they work. Once you know how they work, you will automatically be able to decide that which vaccine is good for you or is good for COVID. So I would not like to give a judgment that this is better than that, but if we come to know how they work, we'll lead to a conclusion that, okay, this is better. We'll try to understand the difference between immunogenicity, efficacy, and effectiveness. Lot of things are being talked about nasal vaccine, which is shortly coming, being made by some Indian manufacturer. And common and uncommon notable side effects, contraindications. Can we mix two types of vaccines? How long the effect lasts? Do I need a booster after taking the full course? And I have so many unvaccinated people around me, how they affect me. This is the success. India, I believe, has given a good success story of giving vaccines to almost 2/3 of our population, out of which 1/3 has taken both the doses. And it's going to be a great story if we cover even 70–75% population with a single dose. It is going to have a huge impact later on in controlling this pandemic. We have three basic type of vaccines. The first one is the killed. In the killed vaccine, you have two famous vaccines. One is Covaxin, another is a Sinopharm vaccine, which is being given throughout the world. It's a Chinese vaccine. And both these vaccines are basically of same technology. And they are basically the killed vaccines, the old technology that we have been using in producing DPT for almost 5 decades. The second and the third are the new generation or the new non-conventional newer generation vaccines, the viral vector vaccines and mRNA vaccine. In later slides, I would be telling how they basically work. The three vaccines, viral vector vaccines, which are available are Covishield, Johnson & Johnson and Sputnik. mRNA vaccines available globally are Pfizer and Moderna. This is how the immunity works inside the body. You basically take up the virus inside, and once that virus enters the inside, it is taken up by the cells, and these cells eat it up and produce cell-mediated immunity and humoral immunity, which basically generates cytokines and antibodies to kill and control the infection. So by giving vaccine, we tend to basically replicate the same process so that our body is sensitized towards that infection. And when the natural infection attacks the body, the same process is not repeated, rather only the last process, which basically identifies the antigen and produces antibodies and toxins, cytokines to kill the organism, is just repeated. Why I'm telling you all this in a vaccine session? Because when we talk about vaccines, and especially when we read about vaccines in media, we realize that only antibodies are talked about. This vaccine makes this much antibody, this vaccine makes this much antibody. If this much antibodies have been made, it is working. If this much antibodies have been made, it is not working. Actually speaking, antibodies, or the marker called antibodies, is just a small check card which says that vaccine has actually worked inside the body. But in long run, this vaccine is successful, or it is going to work when a natural infection is going to come inside the body. This antibody level doesn't tell that. For that, you need to study some other things, and you need to know some other things. And even if your antibodies are zero, if you reach a point, maybe after a year of taking vaccine, when you do not identify antibody inside your body, then there is something called memory response or anamnestic response, which takes place inside the body. As the natural infection comes, you see that even if the antibodies have fallen zero, the B cells, they get stimulated by the virus or the antigen, and they produce good amount of antibodies. And if the infection has a good incubation period of more than 24 hours, anamnestic response is usually so robust that it doesn't let the infection take over anything, and it is able to kill the infection. Another important thing is, when we talk about antibodies, this B cell response, as I talked, is producing antibodies, and then we totally forget the phagocytic response, the killer cell response, and these things, they are parallel and different from the cells which are producing antibodies. And when we talk about this vaccine is good, this vaccine is bad, we actually fail to acknowledge all this process, which is more important than just neutralizing that infection. Now, when you study or when you read about vaccine, there are three terms used. They are not interchangeable: immunogenicity, efficacy, and effectiveness. I would like to explain this simply in a term in relation to the car. You have a car, and if this car runs on a road on any kind of fuel, whether it is petrol, diesel, or electric, it runs. This is immunogenicity. You put either 1 drop of petrol, one drop of diesel, or very minimum electricity into it, is going to run for that amount of time or that amount of energy. This is called immunogenicity. So when you talk about a vaccine which says I am 100% immunogenic, this does not mean that it is working 100%. What it means is when you inject that vaccine inside the body responds to it. For example, in COVID, we had more than 200 candidates initially. They were squeezed on to 10, 15 candidates finally, which we had for the vaccine. So they were basically looked for the immunogenicity in initial studies. Now comes the efficacy when the researcher decides how this vaccine is going to work or how this car is going to give you the mileage. They create a environment which is totally controlled, and they give you a mileage of 20 kilometers per liter. But actually when this car comes onto the road, especially in city conditions, it never ever gives you more than 10. So this is efficacy and effectiveness. So even efficacy, when you read this is 90%, 92%, it doesn't mean that vaccine is 90% going to be effective. No. Effective could be something else. Yeah, efficacy, that is perfect. So all kids these days are getting 95%, 99% marks in school. That doesn't mean that all are genius. It is the examination system these days which is making them 95, 99% marks. So similar is the efficacy and effectiveness. We hardly talk about effectiveness, but we majorly talk about efficacy of the vaccine. So please do not compare the vaccines with efficacy. Another thing, we talk a lot about antibodies, but there is no measure to measure the antibody. When you read the value of the antibody, it is in terms of AU per ml. Here A stands for arbitrary. Nobody knows what it is. It is arbitrary value. So for me, it is different. For Bharat Biotech, it is different. For Serum Institute, it is different. For Pfizer, it is different. For Moderna, the manufacturer decides this AU. And they say it is immunogenic. This is. Now, these 3 sets of vaccines, how they work, they can be easily divided into one doing the targeted attack, another doing the untargeted attack. Now, let me give you an example. You have an orthopedics association, and if you want some work done from the association, you know that Dr. Dhananjay is the president. There are few ways you try to contact him. He is accessible or he might not be accessible. Then you decide that there is some work which is very pressing and you need it to be done. Then what you can do is you can give dharna in front of your association office and get the work done. So this dharna is quite similar to the killed vaccine. Killed vaccine is just formaldehyde virus you inject inside the body. Virus doesn't know where to go, body doesn't know where to take it. And this is just a blind vaccine. How it will work? Both the processes don't know. It will work, it might not work. Immunogenicity doesn't mean that it is going to produce those memory cells, T cells, B cells, and the killer cells, and the level of memory B cells which are needed in future. But this vaccine will give dharna inside the body and create a noise inside the body. Now, coming to viral vector vaccine knows that there is something called adenovirus, which causes common cold in humans or all mammals, I should say. So this is an agent which is known to the body. Now you attach a spike protein onto this agent and send this agent, who is also known to Dr. Dhananjay here, and gives him the information that people want this job is to be done. Now, again, it is up to Dr. Dhananjay to accept this job or not. He might accept, he might not. But again, it's a better one step ahead in comparison to the dharna. Now, let's come down to third mRNA technique. It's even smarter. what you do is you catch hold of a better spy, as this agent was in Raji, who was made wife of the army officer of the opposite country. So here you can catch hold of Mrs. Dhananjay and you can tell her this work needs to be done. And she takes the information, this information in the form of mRNA, enters into Dr. Dhananjay, brainwashes him and replicates the spike protein. Remember, mRNA is not carrying the spike protein, it is carrying the code of spike protein. So Mrs. Dhananjay is not carrying any raw thing information, but he is making sure Mr. Dhananjay gets the information and produces inside and comes with a spike protein and makes antibodies against that spike protein. So it's a step ahead, far step ahead technology. And this will for sure is going to work. Mrs. Dhananjay is, I'm telling you, is going to work and the work is going to be done. It's the memory produced by mRNA is very specific. It cannot be non-specific and it cannot be cross-reactive. So this is a highly modern technology which was there for almost 2 decades. For other researches it was being used, but has been used clinically for the first time. Now, nasal vaccine we have used in flu. There are challenges. As you inject, a lot of people sneeze it out. You have URI, acute illness following nasal illness. Sometimes it is so severe that actual illness is not that severe. Again, this might come. It is again a challenge to see whether this is going to work or not. As I have used in past, I don't see much promise in nasal vaccines, but it's a fancy thing which is going to come. Most common serious notable side effect that I have seen with the current COVID vaccines, rather it is a property of COVID, thrombotic thrombocytopenia syndrome, quite rare, usually occurs after the day 5 of the vaccine, can be as late as 1 month after the vaccine. It needs aggressive therapy, a referral to a proper hematologist, and warning signs are neurological and renal functional dysfunction, could be fatal in some patients. There is no contraindication other than allergy to the previous dose of that vaccines. Whether you are on anticoagulant, whether you are on any other therapy, whether you are thrombocytopenic, it is not a contraindication. It can be given in pregnancy, it can be given to lactating mothers, and if research done, it can be given to infants and younger children also. Mixing vaccines is technically, yeah, if you talk to me as a student of immunology, I will say mixing 2 vaccines is never a challenge. But the only challenge in mixing 2 vaccines is that you need to validate before mixing them. Validation means doing a study and asking a regulator to approve it. That's all is the challenge. I think there are a good number of studies done in Spain and South Africa, which suggest you can mix 2 vaccines. Rather, there is one study which says, Combivac study says that mixing 2 vaccines gives better results in comparison to giving single vaccine. These are few recommendations by regulators from different countries I have mentioned, where you can mix more than 2 vaccines, and they allow mixing these vaccines and they authorize mixing these 2 vaccines. A lot of people ask me the one very important question, we have taken Covaxin, it is not approved globally, can we mix? Rather, I would say it's hardly a 1 month or 2 month away where this Covaxin would be approved by WHO finally. So I don't think there is any need to mix the vaccine for that cause. Another thing is mixing vaccine for an individual at its own risk is a very risky affair, should not be. Now, how long this vaccine is effective? This is the data of Pfizer vaccine, which was evaluated on Delta strain. So 3-4 months after taking both doses, usually there was a good protection against delta strain, but immediately after 3rd month, this protection starts falling. This is protection against infection, this is symptomatic infection, and this is infection among healthcare workers. You can see the sudden drop after the 3rd month of the 2nd dose. So as of now, for 3 months, this vaccine is working very well. Some studies still quote that it is working till 8-9 months, but time is going to tell. This probably will open a new Pandora box of modifying the vaccine, having newer vaccines. Do I need a booster? This recommendation came from CDC on 23rd September. And CDC, after collecting data from all the studies from all over the world, suggested yes, at least Pfizer data suggests that you can have a booster, but minimum 6 months from the 2nd dose. Initially, they are recommending for high risk, not for the general public. Reason being the shortage of the vaccine. Now, unvaccinated and how they are risky to us. Yes, vaccine, the foremost and the most important benefit of the vaccine is that you don't become a carrier of the virus. You don't become a super spreader once you take the infection. The problem with unvaccinated is they are the culprits, those who become super spreaders, they become carriers and they spread the infection. And it is the unvaccinated, those who become the channel of mutants. Once an unvaccinated person takes the infection, multiplies inside the body, he is the person who mutates it. And the risk of hospitalization is very high in unvaccinated. So unvaccinated population is a risk for vaccinated and for themselves also. Thank you. Thank you, sir.
Thank you, Dr. Jain. I think since you did not elaborate on the point about the boosters, so let me clarify certain things. CDC has come out with the recommendations that anybody 65 years or above should be given booster dose, and from 18 years till 65, persons who are having medical conditions, they have defined various conditions, or people, elderly people who are living in a old age home, or people living in shelters, or people living in prisons. So certain of these kinds of situation, these people should be given booster, but it must be at least 6 months after the 2nd dose. Secondly, they have also come out with a important recommendation that Johnson & Johnson is no longer 1-dose vaccine. Johnson & Johnson's 2nd dose must also be given to increase its efficacy. So these are the current recommendations by the CDC. Thank you. Dr. Gauri, you want to add something?
Just one more thing, sir. Now there is recommendation for a 3rd dose, even with Pfizer and Moderna in immunosuppressed patients. So there is, the evidence is still to see, but now there is recommendation for 3rd dose.
Now we shall, if anybody want to ask any question to Dr. Jain, I think he has covered the most of the topic nicely.
Yes, we did discuss that.
Various studies are going on. NHS in UK, Germany, even before that, and many other things they are doing. And I will give you an example, like in the pneumococcal infections, if you do both the conjugate as well as the polysaccharide vaccine, so mixing is there. So it is being documented, so it is to be confirmed by the various studies in the different places. In India, so far, there has been no recommendation. ICMR is actively studying it.
Thank you.
Now it is my pleasure to welcome Professor J.C. Suri, who is who needs no introduction, at least in Southeast Asia. He is a renowned pulmonologist and extremely competent critical care physician. And he has trained lots of pulmonologists, and his trained students are now occupying the various exalted positions in the different parts of the country. So Professor Suri shall be speaking upon the long COVID syndrome and how should we recognize it, how shall we manage it. Professor Suri, please.
Thank you, Dr. Mishra, for the nice introduction. At the outset, I would like to thank Dr. Dhananjay Gupta and the organizers for inviting me and giving me this opportunity to speak on this important subject. This is a hot topic these days, ever since the pandemic has started. So what I'm going to do basically is to talk about what post-COVID-19 sequelae or post-COVID-19 condition is, how do we define this, what is the epidemiology, clinical feature, risk factors, and what has been the role of extensive use of antibiotics and steroids in the outcome of these patients, how to evaluate, and then finally, what are the possible management approaches which are available to us. There have been a number of definitions, one by CDC, where they have defined it as post-COVID conditions, which is defined as wide range of new, returning, or ongoing health problems people can experience 4 or more weeks after being infected with the virus that causes COVID-19. Then this definition has been extended beyond 4 weeks, what we call ongoing symptomatic COVID-19, where it goes from 4 weeks to 12 weeks. And then finally, post-COVID-19 syndrome, when the condition, the symptoms, the sequelae goes beyond 12 weeks. So that's the way it has been defined. What are the important epidemiological features? Now, this is the first few studies, were done on patients who were discharged from the hospital. And you can see here, can I have the pointer, please? Is this the pointer? Yeah, sorry, thank you. Where is the pointer for? Yeah, thank you. So you can see here, this is ICU patient and the blue one is the ward patient. And you can see that there is a significant number of patients having residual symptoms, and the two most important symptoms were fatigue and breathlessness. Now, fatigue is a very vague symptom. It can have physical domain, or it can also have psychological or psychiatric domain. So this has to be seen from both the domains. And then there are other number of symptoms which you can see. And you can see that 72% of the participants have the symptoms, and those who have come from the ICU, and 60% of the patients from the ward. Breathlessness is the second most important symptom. There was also a significant drop in the quality of life in these patients. Then again, this is another study which was done on the patients who were discharged from the hospitals. And this side is you can see that the symptoms with which this patient came to the hospital, and these are the residual symptoms at the time of the discharge. Again, you can see that the two very important symptoms are fatigue and breathlessness. And what was important was that only 12.6% of the people were completely symptom-free, those who are being discharged from the hospital, and 32% had 1 or 2 symptoms, and about half of the patients have 3 or more of these symptoms, in these cases. So this is a very important thing, when we are talking about fatigue and breathlessness, we should try to understand what could be the underlying pathophysiology, whether it is the ongoing inflammation, whether this disease is unlike other viral infection, which normally last for 7 days or 10 days, and most of the people recover. So it's one of those viral infections where the disease course continues and the underlying inflammation, like a smoldering fire, goes on and on, giving rise to diverse symptoms, and these symptoms will, go into the different disciplines as we will see more and more about it later. And then, we have studies where they found that the first 2 studies which I showed you was at the time of discharge. And then when these patients were followed up over a period of months, then what they found that still these patients had significant symptoms. And this is a 6 months after discharge. You can see very clearly the fatigue again continues about in 63% of the patient. And additional, you have sleep disturbances, about 25-26% of the cases, anxiety and depression. So these, you go into the different domains, sleep, anxiety, psychiatry, and fatigue again is a very non-specific kind of symptoms here, So, so we have now a number of studies here, and most of these studies have been done after up to, I would say, 6 months from the discharge. And what you find that 50% of these patients continue to have fatigue, musculoskeletal symptoms, because these patients, particularly those with a prolonged hospital course, have been, lying in the bed and also in different positions. Patients were kept on prone positions or other situation, and more or less they have been confined to bed. So they have a lot of deconditioning, muscle wasting, and these musculoskeletal symptoms, at least in 47% of the cases. And I think when we are talking about fatigue, large number of these patients may also have the musculoskeletal issues with this. Again, we find that the sleep disturbances continue, breathlessness continues, and psychiatric symptoms are continuing. So these are the all the studies, going up to 3 months, 6 months, and still we see that there are persistent symptoms, adverse mental health outcomes, and physiological impairment, which are present in these patients, and they go on and on. So this, highlights a very important morbidity these patients go through beyond the acute illness, and it is very important for us to understand the pathophysiology and try to find out some means of effective treatment in these cases. So for how long these post-COVID sequelae or symptoms continue? These are some important studies where they have seen that it is lasting more than 3 months in most of these. I think maybe if they have continued these studies, the whole process will still continue. So in most of these, what we have seen that you have these common physical symptoms again, fatigue, dyspnea, chest discomfort, cough, anemia, backaches, all these kinds of symptoms, and then psychological and neurocognitive, particularly post-traumatic, impaired memory, poor concentration, what we call the brain fog, because these patients have gone through, and this whole process continues, and making them quite morbid, both at a physical level and also at the psychological and mental level, So people have tried to look into who are these people, who develop long COVID, what are the risk factors? Again, some factors have come: older age, female gender, pre-existing cardiopulmonary disease, and then need for going into the intensive care. We know in the intensive care, patients develop a lot of complications. They develop sepsis, they develop hypotension, and with the result, they go on to various kinds of life supports like mechanical ventilation, and they are on hemodynamics support. So all these things can lead to what we call critical care neuromyopathy. So when they have critical care neuromyopathy, this leads to profound muscle weakness, which can last for weeks to months together. Poor mobility it creates, and then of course the features of brain fog, like poor concentration, memory, fatigue, anxiety, and depression. So all these things, are particularly important. And another very important thing which was noticed in the subsequent studies, that it is not those patients who are hospitalized or those who are in the ICU who develop this long COVID syndrome. It is even patients with mild disease and those who are at home, and they develop these symptoms which continued for weeks to months together. So that means the development of fatigue, dyspnea is not linked with the severity of the disease. So this is the another important thing here. Again, another study, you can see the persistent fatigue may occur in those with the mild disease, and you can see the 50% of these patients, have some kind of symptoms. And not these are the some kind, these are the consistent symptoms of fatigue and dyspnea and depression. So these were the symptoms which were continued. Now, how much the role has been played by antibiotics, antifungals, and steroid? Now, we know that COVID-19 is a viral disease, and there is no role of any antibiotic in a viral disease. But at the same time, it is recommended, even in the WHO, that if a patient is hospitalized, the patient is in the ICU, that means the patient is sick. So there is some probability of this patient may be having secondary bacterial infection, and antibiotics may be reasonable or desirable in a situation like this. But normally we see that 75% of the patients receives antibiotics, than the 8% bacterial co-infection. So this is something very strange also and very significant thing which has happened, because we know the COVID-19 has been a prolonged disease with phases of exacerbation. So when a disease becomes worse, so it becomes sometimes very difficult to differentiate whether there is a secondary infection or it is a progression of the disease itself. So these patients have been put on number of antibiotics, very high generation antibiotics, with the result, there has been a lot of bacterial selection, drug resistance, and all those things. And along with this, when these patients were not responding to antibiotics, many of them have been put on antifungal drugs, the common antifungal drugs against Aspergillus, Candida, and these things. So we have tried to completely eliminate the most of the bacterial and fungal flora which responds to common antibiotics. So this is the reason, we had more of mucormycosis here, because we have treated this patient with such high doses of antibiotics and steroids that we have selected that, and that is probably one of the reasons in this thing. So this was just the WHO recommendation that antibiotics can be only used for patients who were sick. Next was the steroids. Now, normally we don't give steroid to viral infection. We know we treat patients with influenza or chikungunya or other viral diseases. We don't give them steroids. But one study which came from Oxford, which suggested that if you give steroids to sick patients, not the mild, but the patients who required oxygen, patients who required maybe admission to the intensive care. So these are the sick patients, and if you give them steroids, then probably there will be an improvement in the mortality. So that was, and that too, the recommendation was on a dose of 6 milligram dexamethasone, and that too for 10 days. But what happened actually during the course of this pandemic, there were many patients who became very sick and who did not respond to the standard doses of steroids. And they were given, of course, without any strong, high level and evidence, they were put on very high doses of steroids, pulse steroids, going up to 250 milligrams or more in 24 hours of methylprednisolone. With the result, this resulted into a lot of complications, particularly patients who were pre-diabetic becoming diabetic. And then there are so many other things, which these patients develop: fluid retention, high blood pressure, hyperglycemia, and of course, problems with mood swings and memory, behavior. So this also contributed to development of critical care neuromyopathy, because if you give steroids to patients who are on ventilator, they are at a high risk of developing critical care neuromyopathy. So all these things, these complications occur. Although, as I said here, nowhere, the steroids were recommended. So many guidelines to mild to moderate patient. But what happened during this pandemic? Even patients who were treated at home, those who were mild, were given steroids as a part of the first line therapy. And I think these two things, the indiscriminate use of antibiotics, high generation antibiotics, prophylactic antifungal, standard antifungal drugs, and the large doses of steroid, which resulted into high blood sugars, severe diabetes, difficult to control diabetes. So this became a kind of a recipe, for the new and the emerging infectious disease like the mycosis. So this is what something which we noticed in this pandemic. And I can tell you that this kind of complication were not seen in other countries. It was only specific to Indian circumstances. So this clearly shows local practices. You know, when you are using some drugs, you know, more than desired, then it can have a very serious flip side. And that's what happened. You know, we actually noticed so many cases of mucormycosis and the mortality associated with this condition. So this is what, and then now we are going to see long-term side effects of these steroids also, you know, the standard side effect which you all know, and we have to follow up this patient on long-term basis to see the development of this complication and trying. So these are the things, you know, which we see that the people who develop mucormycosis, and this is the median time to diagnosis of mucormycosis, about 18 days in most of these patients. So this is about the complications, the problems which we faced. Now next part I will just quickly discuss is about the evaluation. Who are the patients who should be evaluated and how should we evaluate? All patients, I would say, those who were sick enough to be hospitalized, or they were in the ICU, or patients with mild disease, but had some comorbidities. So these are the patients I think we should evaluate after they are discharged, and they should be discharged something between 4 weeks to 12 weeks, and depending upon their age, their background comorbidities, and the severity of their illness, they needed to be evaluated. And in the terms of evaluation, most of these patients need to have some kind of chest imaging, because COVID disease means COVID pneumonia. Majority of these patients would have developed pneumonia even if they were not having significant drop in their oxygen level, but still you have to see the impact, because the pneumonia which we saw with COVID was different from the pneumonia which we see with other viral illnesses, because this was a necrotizing pneumonia. That's why you had many patients with the hemoptysis and other illnesses, and this was associated with development of fibrosis. So that's what we need to do. You may have to do some kind of imaging to look for residual fibrosis. You have to do the lung function test to see whether there is a lung. With the lung function, the advantage is that not only you can tell about the degree of lung involvement and the fibrosis, but you can also actually differentiate the gas exchange problem between the pulmonary fibrosis with the vascular, with the multiple thromboembolization of the pulmonary vessels. So that also, you know, you can differentiate with the diffusion capacity. So this is a very important and a very sensitive test. You have to evaluate them from the cardiac point of view with the cardiac markers, neuromuscular, skeletal, psychiatric, all these things, you know, you have to see in these cases. And then CT scan, if there is a significant fibrosis, then the question comes, you know, whether these patients should be treated with anti-fibrotic drugs, you know, and you must have seen that large number of these patients have been treated and put on anti-fibrotic drugs on long-term basis, but there has been very little evidence for this thing, you know. And the other thing, you know, let me first complete the evaluation, then I'll come back to the anti-fibrotic drugs again in the management. You have to look for the thromboembolism, and then you have to see this, you know, functional assessment of the patient. You can use this, what is called 1 minute STS. You know, this is sit to stand, you know, in 1 minute, you can come to know about the patient's ability. Normally this test we use in patients with COPD. You have this SPPB, short physical performance battery test. And then you can do this, what is called the Barthel, this thing where you do it in patients with stroke, that is performance in the activities of daily life. So this gives you some global idea about the quality of life of these patients. So with this assessment, knowing what are the issues with this patient, let us discuss about the management in these patients. When you look into the management, unfortunately, we do not have specific drugs or adequate drugs or well-studied drugs to treat these sequelae. So we'll go by symptoms, whether the different presentations have different pathophysiological mechanism, or probably it is the expression of the same underlying pathophysiology, that is long-standing smoldering inflammation these patients have, which is lasting for weeks to months, that is responsible for fatigue, tiredness, symptoms of breathlessness, and this thing. So that's why the low-dose steroids have been very frequently used in these patients to treat this kind of inflammation. But we do not know clearly what exactly is the reason. So there are some strategies which have been advised that if you want to treat fatigue, because fatigue is the most common presentation. So this actually clearly shows a drop in your reserve. So that means there is a almost 50% drop in the reserve of all organ functions, be it your muscular performance, it is your lungs, or your mental capacity in terms of memory, concentration, performance, and this thing. So to treat that, it said that taking into account your limitations in your reserve, you have to restrict your activities, and you restrict those activities in the form of planning here. That means plan to do important tasks when you expect to have the most energy. So there are circadian features of your energy when you have the maximum energy. Then you plan to do those activities. Don't overdo it. The moment you feel fatigue, you stop there, and then prioritize that on a particular day, what kind of important activities you want to do. So that's way is given. Sleep hygiene is a very important thing, because the sleep problems were the third most important sequelae which we see in the form of sleep onset and sleep maintenance insomnias these patients had. So giving them good sleep hygiene means going to bed at the time when they feel sleepy, waking up at the same time, and use of some drugs like melatonin, which can set your circadian rhythm back to normal, because you have been in the hospital for days together. So where you have lost day-night concept, your circadian system has been significantly affected. The patient has not been exposed to sunlight for such a long time. So all these things, affect your circadian system and then the performance. So these are important things which need to be understood. And of course, finally, the physiotherapy and the rehab, because we know that these patients have remained in the bed for such a long time. They are physically deconditioned, mentally deconditioned, so require a kind of a comprehensive approach to rehabilitate them to back to their pre-COVID level, this thing. And of course, psychological effects, anxiety, depression, poor concentration requires counseling and maybe some degree of treatment, because many of these patients may have pre-existing depression or anxiety, or maybe a tendency to those illnesses, so which has been precipitated by COVID. So they may, there is a need to do treatment for all these things. So this is regarding the pulmonary fibrosis. As I mentioned to you, most of these patients, when you do their CTs, they have still residual changes in their CT scan, and they have a long-standing smoldering inflammation. And I think low-dose steroids probably are the best option here. And when you treat them with the steroid, it results into significant resolution. Regarding antifibrotic drugs, actually they have been used off-label. These are the drugs which are primarily used for progressive fibrosis. And they are the drugs for idiopathic pulmonary fibrosis, which is a progressive fibrosing disease of the lung. And COVID-19 is not a progressive fibrosis. It is like any other illness where you have necrosis followed by fibrosis. Like tuberculosis heals and fibrosis, and then it becomes stable. So it is not a kind of progressive fibrosis. We have not been able to prove this, and we have seen most of these patients improving on treatment. So these are routinely, I think these drugs are not recommended. So to summarize, post-COVID-19 complications and sequelae, they are very common and involve about 2/3 of all patients with increasing prevalence with the severity of the disease. But we have seen that even patients who have mild disease have developed these symptoms. The range vary from pulmonary fibrosis to involvement of other systems like cardiac, neuropsychiatric, renal, and coagulation system. It appears that pulmonary fibrosis develops early in the course of illness here. Yeah, we did see that. And whether it is progressive in nature is not fully yet clear. It has not been proved that it is progressive. In fact, over a period of time, the X-ray clears, the lung clears, the lung function improves. So at least there is no evidence to say that it is a progressive fibrosis and a strong case for antifibrotic drugs. So long haulers are real and common, and we are seeing them in large number. And these patients need to be evaluated regularly with pulmonary functions, echos, and other tests, as per their symptoms, for understanding the long-term outcome of these patients. The role of chronic inflammation, fibrosis, and intravascular thrombi need to be defined in the causation of these various symptoms. So COVID-19 is a unique and novel infection that has already demonstrated a range of perplexing clinical syndromes. Its legacy will be felt long after the pandemic has passed. So it is vital that the medical community is primed to detect and manage the long-term consequences of the infection. Thank you for your kind attention. I'll be very happy to answer if there is any question.
Thank you, Professor Suri, for giving a very exhaustive and lucid presentation of the long COVID or the post-COVID presentations, which we all are seeing in our day-to-day practice. One thing I would like to mention that about 20% of these patients, they have hair fall also. So if they come that they had COVID, and 1/5 of them will have hair fall, and some high-risk patients must be given, as you told in your presentation, must be given either the anticoagulant or mostly antiplatelet agents in some certain high-risk situation, at least for 45 days. And I again compliment you for giving a very exhaustive presentation of the whole gamut of the post-COVID thing. And I think it was really a masterly talk. I shall ask my co-chair to give his comment.
I think it was pretty extensively covered. I don't have anything else to add from my side.
So let us give Professor Suri a big hand. I think with that we end this session.
जगह नहीं है पेन ड्राइव डालने के लिए। Yes, done.
While Dr. Bijlani is getting ready, I'd like to invite the panelists for the last session onto the dais. It's Dr. P. Bageja and Dr. Bajinder, who are executives in the Delhi Orthopaedic Association, as well as Dr. Vipul Khera, who is also an orthopedic surgeon. Would you kindly come to the stage? So we got to start this last session, which is about futuristic medicine and ergonomics. And to speak to us is we have Dr. Neeraj Bijlani, orthopedic surgeon from Bombay. He's the co-founder of OrthoTV, who's been one of our, getting us online for this conclave. He'll be speaking about the new normal, mastering teleconsultations. Dr. Neeraj Bijlani, when you're ready.
Yeah, hi, can you hear me? Yeah, thank you very much. And so my topic is, I'm not going to talk about on laws, on legalities, on many other things which teleconsultation brings us. I know everybody knows here and who are listening to me online that the teleconsultation was introduced on the day the lockdown hit, and it is there to stay. For all practical purposes, it was a big advantage to people who are into private practice.
because then they could actually ask for legal fees, which were now legal for doing a teleconsultation or a video consultation. So I'll just tell you how I do it. And this is one of the ways, that there are many other ways, and I would definitely ask for a discussion after this. So I have used the following platforms for teleconsultation. Zoom, which we are using on a day-to-day basis. Then there is WhatsApp Business. WhatsApp Business is just another WhatsApp app with a different phone number in the same mobile number, same mobile phone which you carry. And of course, there were third-party electronic medical records, which I was anyways using for giving printed prescriptions. One of them was DocOn, which I continue to use till date. Practo Ray, which I was using before the lockdown. And Librate is something which I just tried for a few days and I gave it up. So the easiest way for anyone to do is on WhatsApp. And many doctors will say that I don't wish to share mobile number of my personal mobile number with the patients. So what do I do? So Indian Academy of Pediatrics came out with something like this, this poster somewhere in the month of May or June, and teleconsultation for IAP doctors. It's a 5-minute setup. It's a free of cost and it is fully secure. So you just install another WhatsApp Business app using your Play Store or App Store. Use a different mobile number. So what I did in those days is that I bought another mobile number. The SIM card was inserted in my receptionist or the assistant who was sitting at home, and I set up WhatsApp Business. So then you'll say that how will WhatsApp work in your phone? So my question is that what do you need to start WhatsApp? You just need one OTP. The OTP comes to your phone, the WhatsApp starts on your phone. So WhatsApp Business, though the WhatsApp Business is on my phone, I will not receive phone calls for appointments and everything. She will receive the appointments. I will just be doing the video consultation on WhatsApp Business. I keep the notification off so that I don't get disturbed, and my personal WhatsApp number remains completely separate. How do I take the payment? I will come to that. So this is a simple way of WhatsApp Business, how it looks and why it is different. So this is another app, WhatsApp Business on my phone. It looks different. No, it looks exactly the same, but there is something different. You go down here in the settings and there is something called as business tools. In the business tools, you can put up something like a clinic photograph. You can put up your mobile number. Then you can even put up your clinic timings, the address, email address, website. And you can put up an about that this is a dedicated WhatsApp number only for patients. So I eventually went and put down that do not call on this number. This is only WhatsApp number for me. If you want to call, make a normal call to people. I could, as the year went by, there are a lot of features which WhatsApp introduced. It had a greeting message. It had an automated reply. So supposing my WhatsApp is off, patient will get an automated reply. And of course, there was this very nice thing, new thing which WhatsApp has introduced, though I'm still yet to use it, but many of my friends are using it. It's called a catalog. So in a catalog, you can put orthopedic cases. Like supposing you are a joint replacement surgeon, you can put some cases and x-rays that this is a knee replacement which I do, or this is a fracture surgery which I do, or this is a spine surgery which I do. You can always share this as a link to the patients that this is where you have to connect with me on WhatsApp. So this is WhatsApp Business. So this was the flow. Normally, this is my patients, this is my communication. On the left side, you see is the communication with my receptionist. I will send her the mobile number if I have received the phone call, or she will send me that. So I will tell her that this is my Google Pay Paytm number, which is again a different number than my personal number. I don't use WhatsApp on that number, so that patients don't start communicating with me unofficially. And then once they have agreed, even if they have principally agreed to do a Paytm or a Google Pay, I will start the WhatsApp video consultation with them. Then if they want to book an appointment using an app and they don't want to do Google Pay Paytm, I will send them this ready-made message, which my receptionist was sending to everyone. That Dr. Neeraj Bijlani is available for online video consultation. This is the link. Click on this link and take an appointment. I also want to connect with patients on an admin-only group, which is called my patient care group, where only I can post. So I always send these patients that WhatsApp group link. So patients are connected with me on that number, which is not calling number. And this is how I worked during the pandemic sitting at home, besides OrthoTV. So this was my flow of appointments. Somebody receives the call from the patient. So it could be me or my receptionist. And nowadays they are asked whether they want to do a video consultation or a physical consult. And if they want to do a physical consult, the appointment will be given, the address will be sent by SMS, patient visits me, it's over. Now, how do I do a video consultation nowadays? If you don't want to use any software, just they are explained about the WhatsApp Business and the Paytm GPay. patient books prepaid appointment, that patient pays beforehand. Then the receptionist will send me the patient's number and I will do the video consultation on that different number on my mobile. I will send the prescription. So if you are writing a prescription, always you can write a prescription, send a photograph on the same WhatsApp, patient receives it, very easy. I usually use a software. So in that software, the prescription is anyway sent to the patient by WhatsApp in the PDF format. So it's a proper clean prescription. So there is no issue of handwriting or anything. So these are the main flow of my appointment. Let me show you the software which I use. So how does the patient take appointment? It is electronic medical records, full-fledged records. It was mainly iPad. Now they are allowing on laptop and mobile also. It works very smoothly and very easily. You can do a video and physical consultation. And it is a dedicated software with orthopedic symptoms. So I will show you the patient side first. So this is the patient side. It's a doc-on app available on iPhone and Android, where patient just has to register using an OTP. So for example, this is a patient. I'm just setting up a text patient by the name of Neeraj Bijlani. And if the patient wants to take an appointment from me, they will get a patient ID here and they will have to just go under my name and they can be able to take an appointment. So now by going here, they can search my name here and they will type the name and they get this. Once they click on this, they will see my open slots, which I have kept open for video consultations dedicatedly, and some are for physical consultations. So they will say no available slots. So tomorrow, yes. So see this morning video consultations, afternoon video consultations. So they will just select one slot here. And after selecting a slot, they will get a reason whether they want to do a consultation or a follow-up, because the fees can be different if you want. And then when you click on next, they get an option for payment. They just write the name again, mail, and then add patient. And then they decide the date of birth. They have to just give the date of birth because this was originally a pediatric based software. That's why the date of birth is compulsory. And then they click on consultation and then they select. So they select. In this, the main advantage was here. I will want to show you with one number, there are 3 people connected. Why it is like that? Because supposing if there are many patients, like for example, I have operated a patient from Kanpur and that patient was, but their relative was staying in Mumbai. So they took an online appointment. Yeah, and with the same mobile number, they can take the same appointment for me also. So under one mobile number, DocOn allows multiple patients. So you can take appointment for a mother-in-law, father-in-law. So that was very convenient for people who are sitting abroad. So, and basically then they can allow the mother-in-law, father-in-law to join in on the video consultation. So then this is how the software looks. And the patient connects with me inside the software. If you see, this is a video consultation happening where I am sitting on the left side here. And this is a video consultation happening here. And in the background, I can make the prescription. Let me show you how I make the prescription. So this is how the software looks. And this is my video consultation patient. So let me make a test prescription of my name only, which I just created. So I put a test, then I click on new consult, and then I tap on some symptoms, which I want to type here. I can type the symptoms, or there are ready-made symptoms, say neck pain, for example, and then pain is radiating. So once I start radiating, it automatically picks up the symptoms. These are all pre-filled. These symptoms are already there in the software. If I want to add something to it, like mild, moderate, severe, or number of days, I can always add. I can add no neurological signs. So there are many symptoms which are already there. Of course, if they are not there, you can add your symptoms. But once you add, then you don't have to add it again. And the important part is that supposing if you're seeing only spine, all the spine symptoms will be coming on the top. If you're starting to see only knee, then only the knee symptoms will be on the top. So the software understands automatically. You can even put the medical conditions. You can put the, like for example, patient had diabetes. I want to put diabetes, so I'll put diabetes here. And I can put since how many years they are suffering from blood pressure, diabetes, dyslipidemia. And then I can start adding the medicines. Medicines also, you can make templates of the medicines. Say, for example, like the orthopedic surgeons will give an NSA ID, will give a PPI, will give a calcium. So we can always make those and keep it ready. And if we feel that we want to give them, we can give them, or we can add or subtract whatever it is. And it picks up ready-made. Once you have to just put it for 10 days and then it picks it up always. And then this is how the full prescription is made. At the end of this is my prescription with my signature, it comes, and I can easily share it with the patient. Once I have saved the prescription, if the patient has a doc-on app, like I just opened the doc-on app on the right side, on the mobile, patient will automatically have received the prescription here. And view prescription, this is the same prescription. If you see, both prescriptions are the same. And patient can share the prescription on WhatsApp to this pharmacist or chemist, and the medicines will be delivered at home. So it becomes very easy. The flow, the main advantage of this app for me was the flow was not easy only for the doctor, but also for the patient. So both of them, the flow is very easy and everything can happen inside one app. And one patient can take care of the whole family with a one single mobile number. It can be taken care of all the 5 members of the family and multiple doctors. This is a very popular app amongst pediatricians, at least in Bombay. And the second most popular is of orthopedic surgeons nowadays. So that's it with my presentation. So if you wish to see or participate in more of these technology related discussions, join our WhatsApp group on OrthoTech. It's called OrthoTech. For more such events and learning, log on to our website. You can even go and see the recording of this whole session. And yes, what she's doing is right. You can take a photograph because you're not going to remember the mobile number. My mobile number is 9892021844. This is my personal number, not my business number, and my email address. If you wish to join our groups, do message me, and I am okay with taking questions now. Thank you very much. Yes, please go ahead. Can you take the mic? Can you someone give her the mic? You had one mic in your hand, no?
Is available for out intubation.
It's available for, sorry, I did not get it.
Yeah, Africa.
So I'm not so sure that whether it is available for Africa, but I can ask and get back to you. You have taken down my number, you can WhatsApp it to me and I can find out. But I have seen international patients. I have done video consultations with international patients, yes. Yes, yes.
Can we save the X-ray pictures, clinical pictures, videos along with these prescription?
Yes, it is a possibility. So what my receptionist does, that actually is done. So what my receptionist does, or if you have an assistant doctor, it is even easier. So my receptionist will take, whenever the patient comes with a file full of reports, what she will do is that she will take photographs using the doc-on app, which is installed in her phone. So there is another app called the appointment app, which is installed in her phone, and she will install it. And she will install the app in her phone and she will take photographs, and that will get saved under that patient of all the photographs. If you have an assistant, you can even install the complete doc-on app, like assistant doctor or a fellow. You can install the complete doc-on app in his mobile, and he can store all the X-rays properly in a systematic way in the doc-on app itself, and it will be associated with the patient. There is no limitation to the number of X-rays you can keep with the patient. So when the patient comes for follow-up, it actually becomes like a full record that pre-op, post-op, intra-op, everything is there. You can keep everything there, yes.
Is online prescription allowed? Because I heard that, I mean, there's some rule.
It is allowed now. After the lockdown, yes, it is allowed. If you have a registration number properly, and it is allowed. Otherwise, how was video consultation and teleconsultations allowed? So it is allowed. I've been giving it outside Bombay, left, right, center during the lockdown. In fact, the last 2 spine surgeries which I've done, both were diagnosed on remote consultations. They came with me fully investigated with an MRI. And after that, they came with me to just take the date of the surgery. I examined them first time during, of course, I would have cancelled it if it was not genuine, but they came with me with an MRI for the first time. Our whole diagnosis was happened online. So it is possible, yes. And it is legal now. You can give an online prescription. It is acceptable. Except there is only one, I think there is only one point which does not apply much to orthopedic surgeons, that tablets which are like, I don't know about the psychiatrists, what they are doing, because those are the tablets which sometimes they cannot take, like something like narcotics and something like sedatives, like clobazam or something like that, diazepam or something like that, those type of drugs. Yes. So that class, I don't know. We are orthopedic surgeons. We only know 4 drugs.
Last year when we did your call, we had this discussion through one MG, vice president. So it was discussed at that time, rather, that a certain class of drugs which cannot be prescribed online. They have to be prescribed only through physical consultation.
Yes.
There are no more questions. Thank you so much, Dr. Neeraj Bijlani. And I would like to start with my vote of thanks now, right now. Dr. Neeraj Bijlani and Dr. Ashok Shyam, they have been instrumental in providing us with the online platform on which the live streaming of this event has been happening, number one. Number two, they flew all the way from Mumbai to ensure the smooth running and functioning of this event. So we are really thankful, indebtful rather, to them for their invaluable support to us in this particular endeavor. Thank you so much, partner. Thank you. I think they have to catch a flight now. Would like to say something, Ashok, before leaving?
Yes. Thanks for inviting us, and it has been pleasure since yesterday. We have been around here understanding and helping with the technology to bring a smooth event for all of you here as well as everyone watching online. I think it's a great opportunity for education, learning for everyone, which COVID has opened in terms of online content development as well as retrieval of content and rewatching. And I think everyone should take maximum benefit out of it. Today's event was very unique as it lands in the Bone and Joint Week and focuses on the problems that are prevalent in India. And we got to hear about a lot of government as well as administrative office holders about various programs and various things that Government of India as well as private institutes are doing, as well as the research going on, which will help in times to come. So thanks for organizing this and thanks for having us. Thank you.
I hope you would like to come up with a trip here. It was worth it, I guess.
Our next session now is a video talk, which is by Dr. Sandeep Srivastava. Professor Sandeep Srivastava is the CEO, Hospital Establishments, DMI, MSC, and he's speaking about going natural, biologics in MSK disabilities.
I think it was supposed to be a video recording or what? ये वीडियो में आया है क्या? ये कौन से फॉर्मेट में आया बेटा?
ये पावर पॉइंट है, ये वीडियो नहीं है सर, ये पावर पॉइंट है। वीडियो कहाँ है? ये तो पावर पॉइंट है, वीडियो ये है। हो गया। Sound?
Good morning, friends. This is Professor Sandeep Srivastava, and I bring greetings from Jain Medical College, Wardha, Maharashtra, India. And their website itself, you can go for patients.
उन्होंने ऐसा बनाया है।
वीडियो प्ले हो रहा है,
लेकिन ऐसा हो रहा है ना।
Good morning, friends.
इसको छोटा सा विंडो बना के कि ऑडियो चलता है, उसको ओरिजिनल पीपीटी उसको स्टार्ट कर।
हाँ वैसा कर,
Rich, so not
ऐसे ही बनाया है उन्होंने। मोबाइल पे बनाया लगता है।
I think out of all those trees,
पीपीटी यहाँ चला देते हैं। हाँ ठीक है, वीडियो शायद बैकग्राउंड में चलने दो। वीडियो उधर से ठीक है, चालू कर दो आप। पीपीटी लेंगे, किसी को खड़े रख के चालू करना रखना पड़ेगा ना। पीपीटी को इसको कॉपी कर दीजिए, टेक्स्ट किधर करो, टेक्स्ट निकाल लो। मैन्युअली करना पड़ेगा। ऑडियो वो दे देगा।
is discussing about how we can go about natural studies, role of biologics in musculoskeletal disabilities. First question first, why we should be looking forward to biologics? Well, friends, because now there is enough evidence for us to believe that biologics have potentials for tissue repair, regenerative process, and immunomodulation all, which is what the need of hour is for disrupting the musculoskeletal disabilities. The FDA defines biological therapy as sugar, proteins, nucleic acids, or complex combination of these substances, or maybe living entities such as cells and tissues. For us, as a clinician, it means that there is a branch which is getting developed in the form of regenerative medicine and includes certain biological treatment which is derived from natural resources such as our own body and cells. Now, three types of products are available. One which are derived from blood, such as autologous platelet concentrates, that is OPCs. Another one which are cellular derived, such as from undifferentiated cells like stem cells, and the commonest form is bone marrow aspirate. And another form which is non-cellular in nature, that is through extracorporeal shock, which stimulates healing by releasing certain growth factors in the environment. Now, the objective of all this biologics is first to stimulate healing response, second to modulate tissue regeneration, and third, arising out of first to eliminate pain, and arising out of all those three to increase the function. Now, biological therapies, as per the regenerative medicine, as I already said, includes autologous blood concentrates, which have growth factors to stimulate their repair, stem cells, which have potential to replenish dead or dying cells and enhance the limited regenerative local capabilities. Some other biologics are also being tested now, but they are still not in clinical practices, such as HPCs, and the negative roles of RBCs, particularly apoptosis and oxidative stress, which can be restricted with the help of nitrous oxide. As far as musculoskeletal disorders goes, the whole problem is of impairment. So we have series of musculoskeletal disorders such as tendinopathies, osteoarthritis, chronic ligament tears, connective tissue disorders, soft tissue rheumatism, fracture impairments, vascular necrosis, and even sometimes complex wounds in these patients leading to disabilities. The common preparations by which a biologic can be prepared includes two, that is centrifuging or culture. Centrifuging is a process, it's a mechanical process you all understand, which can be used to concentrate the number of cells, and culture, which can help us to grow number of cells. Particularly in cases of mesenchymal stem cells, both the processes can be used to get a preparation of MSCs. Now, the advantage of centrifuge is that it can be prepared at a point of care. So, fresh autologous biologic can be made available right inside the operation theaters if they need be. Coming to the first one, that is platelet-rich plasma. We all know that platelet-rich plasma, or PRP as it is said, is also known as by certain other names such as autologous platelet concentrate, PRCs, etc. What it actually implies is that the normal platelet count, which is around 1.5 times to 1.5 lakhs to 3 lakhs, is concentrated to about 5 to 8 times in this platelet concentration, which has got a huge therapeutic value. Now, this therapeutic value comes because it has got growth factors which are liberated through its alpha granules disruption when it's injected infiltrated, leading to liberation of growth factors, which includes TGF, PDGF, EGF, IGF, and VGF, etc. Now, this presence of growth factors translates the whole ecosystem into a cycle of proliferative healing through its different actions on different cells, and sort of it modifies, sets a pattern of healing which is slightly different from normal pharmaceutical healings, that is, we rely on inflammations. And this here we are relying on proliferations. That is what the major shift of biologics is, that from inflammation to proliferation. The platelet-rich plasma has proven that the healing time is decreased. That the healing cascade, if you see in the diagram below, the first 3 stages of healing is shortened with the help of platelet-rich plasma. That is of hemostatic barrier, inflammation, and tissue inflammation. Friends, the activation of PRP as of now includes in the upper limb such as shoulder, rotator cuff injuries, tennis elbows, lower limb, tendinopathy of Achilles, plantar fasciitis, patellar tendinopathy. So one area where PRP is being used is tendinopathy. Another area where PRP has a role but not so established includes cartilage degeneration, particularly in osteoarthritis knee, or focal defects of cartilages, and also in meniscal and ligament repair and reinforcements. Another area where this is being used includes impaired fracture healings, such as in delayed and non-healings, and also associated healings, such as in cases of complex wounds and irreversible necrosis of involvement. Now, PRP can be prepared in 2 ways, or rather, finally, the PRP products are of 2 types. That is, one is leukocytic rich, another one is leukocytic poor. Now, when to use when is slightly not clearly understood as of now, but a lot of things are happening so as to understand the behavior of these 2 PRPs, so that particularly we can target it towards certain diseases. As of now, the platelet-rich PRP with leukocytic poor concentration helps more in tendinopathies, and leukocytic-rich PRP helps more in fracture healings. That is what evidence is getting built up. And the second product of biologics is stem cells. Stem cells are nothing but indifferentiated cells with the capacity for unlimited, prolonged self-renewal that can give rise to differentiated cells. They can be pluripotent, that is, all cells can differentiate. A cell can differentiate to all types of cells of the body, or multipotent, that is, it can be differentiated to certain types of body cells. They grow by slow cycling in cell division, and they can be regulated by specific gene expressions. The best part is that they are self-renewing for long periods, so they are not to be needed to be given time again. There are 3 types of stem cells which are being investigated, and this includes embryonic stem cells, iPSCs or induced pluripotent stem cells, or adult stem cells. Now, embryonic stem cells, they are derived typically from blastocyte of 5-day-old embryo. They are pluripotent in nature and renew themselves indefinitely. Unfortunately, embryonic stem cells are banned in our country and many other countries. Induced pluripotent stem cells, iPSCs, they are adult cells which the induction is done, reprogramming is done, so that they start behaving like embryonic stem cells. They are again pluripotent, and they have the ability to renew themselves indefinitely. Now, adult stem cells, these induced iPSCs, they fall in sort of a gray area and being investigated for clinical utilities. Adult stem cells are one which are being used particularly in our field, BMMSCs. They are isolated typically from adult tissues, from bone marrows or adipose tissues or cord blood, but then they are not pluripotent but multipotent in nature. That is, they can give rise to a certain number of related cell types only, and they can renew themselves number of times but not indefinitely. Embryonic stem cells, as I said, they are derived from early stage embryo, and embryo have got all derivatives of 3 primary germ layers, which include each of more than 220 cell types in adult body. So they have got a huge potential, but for certain ethical reasons, they are banned. iPSCs is a new generation stem cells, I would say, and they are genetically reprogrammed to an embryonic stem cell-like state. They are being forced to express genes and factors important of maintaining the defining properties of embryonic stem cells. So currently this is being done by transducing the mouse fibroblasts with a selection of those genes such as 4 key pluripotent genes as mentioned over here, and also retroviruses. The main another product which is mostly being used clinically other than PRP from stem cell category is mesenchymal stem cells. As I said, they are multipotent and they can be derived from main 2 sources, that is bone marrow and adipose tissue. From this, they can be led to behave in a manner where they can yield osteoblasts and chondrocytes other than other cells such as neural cells and blood cells. The main MSCs which is being developed as a biologics for musculoskeletal systems are hematopoietic stem cells or bone marrow cells. As I said, they are again multipotent only. They have got 2 lineages, that is myeloid lineage and lymphoid lineage. The average human requires approximately 100 billion new hematopoietic cells each day. And these HSCs are being now routinely used, particularly as a BMTs in cases of cancer and other disorders of the immune system. For orthopedic purposes of musculoskeletal disorders, we have bone marrow MSCs. They are prepared by aspirating the bone marrow mostly from iliac crest, that is posterior SIS, and then they done the centrifuge. Now, whatever may be the centrifuge process, one thing which is very important to realize is that the cellular content of bone marrow dish should be maintained so that a maximal cellular yields are obtained. The targeted bone marrow cell concentration should be increased to 5 to 8 folds to get a good therapeutic outcome out of disease. So mostly the first spin cycles are of anticoagulation aspirated bone marrows. That is, you take a bone marrow aspirate in the anticoagulation, preloaded anticoagulated syringes. Mostly polymer syringes are used because they are said to be less cytotoxic. Then second spin cycle, after second spin cycle, there is separation of bone marrow components according to their different density gradients. And finally, you get a on top a concentration of erythrocytes and WBC layers, which are extracted via the aspirating pipe. These multipotent stem cells has a mesodermal lineage cells as against embryonic stem cells, endodermal ones, but they can be very well differentiated into osteoblasts, chondrocytes, and timocytes. So they all help in promoting biological process to angiogenesis, cellular proliferation, and differentiation. The best thing about BMCs is it is mixed with platelets. So it is sort of creating a synergistic action where a direct cellular source for tissue repair and regeneration of the host is present, as well as concentrated platelets are also present, which have got a paracrine effects which are mediated towards through various growth factors as we have done. Where it can be used, it can be very well used for osteochondral defects, particularly focal osteochondral defects in osteoarthritis and in robotic of tissues. Then another stem cells which is important, mesenchymal cells which is being now developed and being used is neural stem cells. Particularly these stem cells are helping us to overcome certain degenerative diseases of neurogenic in origin such as Parkinsonism, AML, and also now results are encouragingly getting better for brain and spinal cord tumors. Now, where we can use in orthopedic applications? In orthopedic application, the stem cell has got a clear-cut use for cartilage repair, robotic of tears, non-unions, investment episode of femoral head, enhancing spinal fusions, and even filling up of bone defects or voids. Hence, nowadays, if you look at the biologics, a little bit more development is being done with the help of integration of biologics with 3D printed tissues. So there are structures, there are scaffolds which can be printed to fill up the defects exactly like what is missing, and then they can be triggered, induced, healing can be done with the help of presence of stem cells. Now, MSCs have diverse immunomodular properties leading to expanded interest in their various uses for various therapeutic applications. Understand? At this point, we would like to share our clinical experience with PRP as far as biologics is concerned, because as you have realized by now that yes, biologics have the potential for musculoskeletal, overcoming the musculoskeletal disabilities, reducing the morbidity timing by increasing the healing potentials. So what are our experiences with one, that is PRP? Now, we have been using PRP in osteoarthritis since now almost 7 to 8 years, and the best approach I have found for PRP is through direct approach, prepatellar, parapatellar approach, directly inside the joint and injecting about 2 ml of PRP. This is repeated after 21 days, and usually we are giving 3 cycles of such PRP infiltrations. Now, the PRP triggers, or rather arrests the proteoglycan's actions. So it sort of controls the proteoglycan, proteolytic actions, which is causing degeneration of the cartilage. And this is mediated through PDGF and TGF1, which upregulate the production of endogenous hyaluronic acid levels, and PRGF with the help of TIM1 and 2, which controls the protoglycitic mechanisms which are destroying the cartilage. So both the things happens, and over the time the cartilage and the joint shows little difference. In our study, we have found that mean movement scores have significantly decreased on a long-term basis. And similarly, mean VOS have also decreased before intervention and almost up to the 8 months of. Another area where we use this biologic PRP is in tendinopathies of fasciitis. The word of caution is here, it is always better to inject it into the defects which are there, instead of just infiltrating the surroundings, which may have less, which may yield less results. It is better to infiltrate in the defect which is happening there, and this can be easily done with the help of a ultrasound guided procedure. And as we all know, the ultrasound probe is to be kept perpendicular to the middle so that we can visualize the position of needle inside the going inside the defect and inject it into the. Now, we did a clinical evidence also in the rabbit model studies if this helps in tendon healing, and how does it help? By correlating the PRP inflammation with with the inflammatory marker such as CRP, and it very well correlated with the timings of the natural healing cycle. So at the point of around 21 days, started falling. It was minimal, came back to the base, and peaked at around 4. A few examples where PRP works for middle collateral, for ligament tears, such as grade 1 middle collateral ligament, as seen over here. And you can see it has improved the healing. Or for better visualization, we have grade 2 middle collateral tear, as seen in the ultrasound over here. And after PRP infiltration, after 21 days, sorry, after 4 weeks, it has healed well over. You can visualize that in that MCL. There is direct evidence of engineering tissue degeneration repair arising out of use of these biological repairs, as you can see over here in the foot culture of a diabetic lady, or of a here in a impending gangrene in a young lady, where the gangrene reversal and wound healing has also taken place with the use of biologics, or even in very bad case of gangrenes, where we have been able to sort of reverse the gangrenous changes, salvaging the limbs, bones. As you can see over here, this is almost, particularly the lower portion of the bone is almost calibrating dried. It has started showing good recovery in the form of axis of angiogenesis that is seen over here. Or in this such case, where we are able to sort of regenerate the whole tibia, which has gone into the necrosis, everything after compartments. Friends, The biologics, particularly the PRP, which we have used, have also helped us in controlling the pain. And here you can see that the pain, which was measured through VAS scores, significantly decreased after 4 days. Only word of caution over here, in few patients, particularly with chronic lesions, if the infiltration quantity is too much, it leads to a very severe pain eventually while injecting. So my advice would be that on the first sitting in chronic cases, try to minimize the amount of infiltration. If the patient is having severe pain, then restrict your further infiltrations, and maybe you can repeat it after a few days. We have also used for controlling infections, particularly in those areas where salvage and bone grafting was not possible. So here is the case of diffuse osteomyelitis, where we started giving PRPs, and you can see over the time how nicely PRP controlled the infection also. Because so many times, a lot of musculoskeletal disabilities are associated with low-grade infections, and it is very difficult for us to clinically or even after lab diagnosis come to the conclusion if this is a clear case of infection or is it just a musculoskeletal or fibromyalgic or something like that, chronic tissues or connective tissues. It can be used for regenerate consolidations as has been done over here. These are all cases, particularly when they are in fixators, even when they are fixators, they sort of, when the healing is not going good, they sort of create a painful condition. And early relief from this can be done with the help of these biologics. So there are extended indications where you can use biologics to help out the patients. The current evidences as of now shows that there is robust and reliable data available for the biologics use, effectiveness, and safety. However, what is lacking is we do not know what is enough. So standardization procedures are lacking. We do not know the exact indications where it works. And also the mechanism of action is getting explained more and more, but we are still not sure if this is the way these biologics should work and they work. What I would say is all of us, if we turn our evidences together or maybe publish it, then probably these answers will be forthcoming very soon. So any study which is taken up in this direction is not going to get wasted. At the end, I would say, regenerative care with natural biologics have huge potential in management of MSK disorders. Thank you so much once again for giving me a chance to be here. You can contact me on my digital footprints if you want to, if you are interested in assisting with one of our studies or want to share more information. Thank you so much.
Thank you so much, Sandeep. That was, as usual, a very comprehensive and very useful and very practical talk. Really appreciate it. Thank you so much. Hope you're having a nice time back home in Nagpur. This is raining in Delhi. Good luck. Thank you.
Present here today and have participating through the day. We've had Tatendra Chinhamu, of the student coordinator of the Afro-Asian Students Connection in India, who we would like to invite, if you could come and tell us a little bit about MSK conditions in Africa. Thank you.
Compliments of the day, honorable guests, and all officials with us today. My name is Tatendra Chinhamu. I'm a student of BMLT, Bachelor of MLT at Kolkata University. And I'm standing on behalf of the founder of the Afro-Asian Students Connection in India, Mr. Sekul Dembele. For me, I am the students coordinator, and they found it proper for me to come here because I'm studying in the same field, in the medical field, and it was more proper for me to make this presentation. So my topic is about the effects of COVID-19 and other infections in Africa. So basically in Africa, the situation had always been terrible way before COVID. The greatest effect of COVID in Africa was fear. Why was fear generated? It was because there was misinformation about the disease, misinformation about its effects and where it is coming from. And this situation continued for a long time, which generated anxiety. And many of the people suffered more from that. This had made people to run away from the treatment of COVID. And fortunately, after some studies were made concerning COVID, the impacts of COVID were lesser in Africa compared to other countries and other continents. But that limited impact of COVID was not the only thing that affected Africa. Because of COVID, Africa stopped its production, companies were closed, schools were closed. And Africa being covered with most of the third world countries where internet and social media is limited, again, students suffered more because they couldn't even attend the online classes. Well, in the other parts of the world, it was better because students could attend online classes. But in Africa, students could not attend online classes, which means even as the previous presenter was presenting about telecommunication, even in Africa, that is not possible because of the limited services that we have. So again, the situation is in Africa was more delicate, and the impacts of COVID were beyond COVID itself. Now, after COVID, the situation again has not yet improved. Why? With the world moving out of the pandemic, moving out of the lockdowns, there is a better information about COVID around the world, the vaccines, which vaccines to take and how to take in this. But in Africa, the situation is worse because first, people are misinformed about the vaccines. People don't know which vaccine to take and which one not to take. People don't understand the usefulness of the vaccine. So this has greatly affected Africa. And we were hoping that with people moving out of the pandemic lockdown, there would be such wonderful seminars like the one which we are having today, where also Africa has been informed. We would not want to ignore the special fact that India as a country has been very useful in supporting Africa during the pandemic. With the help of the Indian government, African countries have received several dosages of the vaccine, but compared to the population, the numbers were still very small. And this has also limited the help which is coming to the individuals in Africa. And now our greatest request was if, with the help of our wonderful doctors who are here, Africa is so much in need of information, and wonderful seminars like this would be very useful if the information that we are sharing could also be shared in Africa. If it might be online seminars like this, we could also broadcast them to officials in Africa, in our different countries in Africa, so that there might be more enlightenment about diseases, more enlightenment about treatments and vaccines. India, for example, has now become a medical hub for African patients. And this is because of the continuous feedback that people in Africa get from the people who are already here. So that continuous relationship, we believe, is a very good foundation to bring stronger ties of Africa and India. And not saying much in my conclusion, I would want to thank the organizers of this event and say, we are so much honored to be invited to this platform. We are so much honored to be invited into this event. We look forward to more of this interaction, and thank you so much.
Thank you very much. The impact of COVID in Africa or in India has been not just for the medical profession, but for all of us. We've had to adjust our lives in different ways. And our last speaker today is going to speak about personal space, about designing homes for work from home professionals. So I would like to invite Mr. Kapil Sarse, who's an architect, who's going to give his impressions on how we live with COVID.
Good afternoon. I think it's rather late in the day that we are talking about work from home, because everybody over the years has made such progress in working from home now that there is really nothing that one can add on to what we need to do about it. So professionally, architects already wired to the, can I have the slides, please? It said work from home, couple sessions. This is the second one. I sent two. Three. Yeah. See, professionally, architects already used to be wired to work from home, because you get up in the middle of the night and you have a idea in your mind, and you get up, you go to the table and you sketch it out. Gradually, once the pandemic hit us and it was not possible for us to go to the offices and all, a lot of friends basically shared their concerns and asked to find solutions, how to go about it, so that they can also work from home. Essentially, the technology came to our rescue in that. And when the lockdown was first imposed, we made shift admission arrangements to work from home. Now, 2 years and 2 waves later, it was clear that the work from home in this hybrid form is here to stay. The video consult, which the doctors have also been doing right now, and which they thought was a temporary substitute, but is become a very widely used option today. And the home is doubling up for everyone as a classroom, since the kids are also there, the office for the people who are working there, and for entertainment, since we cannot step out of the home anywhere. So there's a distinct need to plan and accommodate and integrate the work from home in this space. So essentially, I would say that there are 3 ingredients which we normally look up to, which is the space, the services, and from our end, it's the vastu of the space also, which helps us in identifying where we should be working out of the office. We identify a space in the house which is available during the day. Like dining table, obviously, is not available all the time. So we have to find a space where it's about 4 feet by 5 feet of a space, which is dedicated, where we have a chair and a table, which we leave the way the office is there in the evening also, and we don't have to come and set it up the next day. Lighting is very important now because of the Zoom connections that we are making and the meetings that we are having through Zoom, where initially we were having problems where it wasn't very clear as to the light and everything. So the images were not very clear. Over a period of time, we found out that the natural lighting, which is obviously which doesn't give glare, is what is required for a work from home environment. Artificial lighting in terms of table lamps, we use them so that, the workspace is lit up without casting any shadows. Then the noise is one thing where we were having problems when we were starting work from home. In a house, normally there's no dedicated corner. And in our kind of houses, 70% of the people do not have a dedicated space where they will not be disturbed. Staying away from the kitchen, staying away from the main door or the balconies, which get the sound in, was the first and the foremost thing that we needed to address. The chair, which we use for working, in an orthopedic conference, I can't dwell much further on it, because that basically is something where you'll be spending so much time, and it's very essential that you have an ergonomic chair, which you can sit in for 8 hours and continue work. Proximity to a Wi-Fi modem or a booster is very much required as a part of the services. Clutter is one thing which either it works for someone, it's a very personal thing. Either it could be cluttered or it could be composition, depending on which way we look at it. Like here we see, a very comfortable chair where a person is also very comfortable working on it. But the thing is that this is not something which you can work on for 8 hours continuously. Then we face the windows so that we have totally glare-free lights, and it does not add to the shadows. Multitasking from home or having a teamwork with your kids around and all has become a norm as well. And we don't mind now if a kid walks in behind us and then, in the meeting, but we do normally are very comfortable with it now, even in the offices. Chaos versus composition. It's to each his own. It basically works both ways. Some people like everything that they're working on right close to them, and some people want a place specifically for everything that they need to work on. In terms of services, the technology has come to our rescue. Wi-Fi, high-speed internet is a must for any kind of a video, Zoom call or a video consult. We have to get IT savvy, because the IT department is not there at home to fix our problems. They're not on call. And even the children who are more tech savvy than us, for a few times they might help you out, but after that, they also just let you be. We should keep the equipment very simple, since the maintenance and services is rare. Enough and more electrical points should be there for the phone and the laptop charging, so that it's a continuous process that goes on without any hitches. The disturbances and the distractions which we have at home, they can be even taken as breaks, because now we do not go to the office. We can get the table home, but we cannot get the environment of an office home. There are places, where we used to meet next to the coffee table or something and help each other out with a few things, which is not there now because the person alone is working over there. In terms of Vastu, for the believers, for the followers, we have certain areas in the house which are more conducive to working, which give you a better vibe in the entire thing. The best colors are obviously muted, not too loud colors, which we need to use. The drawers and the wardrobes, they can be in a certain place to give you an enhanced Vastu of the working space. The work chair should cover the head of the person behind him, in front of him, because it represents supporting life. We avoid using colors which are deep, so that your emotions, they don't destabilize your emotions. Thank you so much. Yeah.
Thanks, Kamil. I think, yes, you did clarify a lot of issues pertaining to the placement of that desk and everything. And that added gold charm was something which was totally brilliant. Thank you so much. With this, I would like to conclude today's session as well as today's conference. I'm indeed thankful to the panelists. Before closing, I would like to have their input. Dr. Barjinder Singh, please, on all the 3 lectures which you attended. Sir.
It was a nice session. We enjoyed it thoroughly, other than orthopedics also. So just for a change, especially the last lecture and a day before that on online consultations, they are really helpful. I think they are here to stay with us for a long. Thanks again for inviting us.
That is totally answer. Vipul.
Thank you, sir, first of all. And the best sessions which we had was one, talking about the internet, talking about the online discussion, which we can give online discussion to the patients, and talking about the different types of vaccines. It was a really wonderful experience, sir. Thank you very much.
But you have made a hospital. Do you think you have done some setting because of Vastu or only because of the practical utilization of the space and other stuff? How much important Vastu is for you?
Sir, some people definitely believe in the Vastu.
About you. Okay, fine.
I definitely believe in Vastu.
Good.
That's the preference. We definitely go for the Vastu first. Then we decide about definitely the room where we should sit should be of around 5 to 6. What should I?
But what about the operation theater? I think that's a place where the maximum revenue is generated. Is there any specifications regarding the operation theater?
I don't think so. We can do surgery in the house. So for that, the hospital is mandatory.
All right, fair enough. Okay, Pradeep, anything specifically about the PRP lecture?
PRP is very important, and we are using normally in osteoarthritis very commonly in our practice, and tennis elbow. I'm using 2 places. So I just want to comment for the last lecture. So in the as far as light is concerned, in drawing room, what light you prefer, and bedroom, white light.
Mike.
So for the working time, we put on the white lights, and otherwise in the evenings, it's theme lighting and yellow lighting for me.
Yeah. Thank you.
So why should we have yellow light? I mean, you said working white light for the office and yellow light for the home.
Yes.
What's the differentiation?
Definitely, I think what I felt always, Dr. Dhananjay, white is always for more concentration, and yellow is more for
it provides
relaxation.
less shadows also.
Just to avoid
Less shadows. Yeah. So there are no pockets of darkness over there. Yeah.
Fair enough. I think it was a very, very informative discussion what we had. Thank you so much, gentlemen. It's been a great day for all of us. I really appreciate you coming over all the way. Thank you so much.
Thank you.
Please,
Thank you so much.
Please do pick up your mementos. I just dread the idea of taking them back with me at home. Thank you so much. And at the end, it's a privilege, duty, and an honor to present the word of thanks. I'm indeed grateful to all the faculty who have taken time out from their busy schedule. See, it's something, very easy when you go through a 10 minutes or 15 minutes talk, you feel that, they just took out everything and just presented. In my opinion, one presentation of 10 minutes at least takes 10 hours of preparation. You have to go through the content, you have to pick up the material which suits your thought of process, and that's how it is sort of cultivated and created. So I'm really grateful to all the faculty, all the speakers, and it's been a wonderful effort from their part. The delegates who have really logged in and they have benefited because they were the basic focus, the basic concern why we created this particular event here. I'm thankful to Astri Ghosh. She's an esteemed member of our society, and she came back from Norway, I think almost a week back. She said she was tired, but I could simply drag her all the way from Goa to Delhi. You have to be part of this. We are thankful to Delhi Orthopaedic Association. They have always stood by me. Whatever has been the event, 1 day notice, 1 hour notice, they always come up to support me and help me out. I'm indeed thankful to our delegates, our invitees, especially from Africa. They've been here since the first lecture started. Honestly, hats off to you guys. I couldn't do it, honestly. So that's a special appreciation. My secretarial staff, Michelle and Priya, who have been putting up with me with my tirades and long calls and whatnot. I mean, if I'm disturbed, I see to it that everyone else is disturbed, because of me. They can't sleep easy because of that. And we have already extended our thanks to Ortho Online. They have provided us with a platform, and they were here all the way from Mumbai to take care of it. And of course, Dr. Dhananjay Gupta, he has just left. He has been a backbone. All the other co-hosts with us, Goenka University, Fortis Hospital, Vasant Kunj, and of course, the hotel administration. Thank you so much. With this, we conclude that today's proceedings. Thanks a lot. Thank you.
Yeah.
मुझे टॉक से दे बेटा, सॉरी जितनी टॉक्स